Welcome everyone to day 3 of Virtual Wish 2020. There is plenty more to come in this live stream and elsewhere on this platform, and I hope you've had the chance to connect with participants even in this virtual setting. Now, the next forum panel discussion is looking at digital technology and mental health, the tools of our age and how we can best deploy them, especially as we come to the end of a year that has taken a great toll on mental as well as physical health. Here it is.
It is one of the greatest challenges of our generation, how to effectively diagnose and treat the issues of mental health, especially in this time of technological advancement and a global health emergency. Hello, everyone. I'm Foli Batibo in Doha. On behalf of the World Innovation Summit for Health 2020, I'd like to welcome you all to this panel discussing mental health and digital technology. I hope you've all had a great virtual experience at WISH so far. And a big thank you, of course, to the WISH 2020 team, the Qatar Foundation, and all its partners for making this event possible today. Now, as we've heard over the last few days, this year has been an unprecedented one, an unprecedented challenge for billions of people around the world. The COVID-19 pandemic has not only presented an immediate threat to our health, it's also created an immense pressure on our mental well-being. The decisions we make now at this crucial juncture could have significant impact on how we deal with the aftermath of the pandemic on our mental and physical health. But the crisis has also presented us with opportunities to re-examine certain stereotypes about healthcare and also recognize the importance of digital health as the dominant future mode of healthcare delivery. Even before COVID-19 struck, mental health services were struggling in every country around the world, and the pandemic has made the situation worse. The WHO estimates the outbreak has disrupted or halted critical mental health care in 93% of countries around the world at a time when the need for mental health is increasing. So many countries have had to adapt, of course, to overcome these challenges posed by the disruption to in-person services. Many have adopted telemedicine, for instance, or teletherapy, but there are significant disparities in the uptake of these interventions. So how do we tackle this? How can technology and digital innovations help us revolutionize the way we deliver mental health treatment and services? And how do we ensure that the most vulnerable get the treatment they need? These are some of the questions that we'll be addressing today as we discuss the Digital Mental Health Revolution report, written and published for WISH under the leadership of Professor Helen Christensen, whom we have the great honor of having on our panel today, and also Dr. Tom Insel. This report gives us incredible insights into existing mental health needs and what can be done to address them. More on the report in just a moment. And we're also thrilled to have with us some of the most trusted experts on mental health who will be sharing their perspectives and solutions on how to develop digital mental health care and address inequalities in access. Let me introduce our panelists to you now. We have Ms. Deborah Kestel, who is the Director for Mental Health and Substance Abuse at the WHO, the World Health Organization. Also with us, Ms. Chiwendu Ukachukwu, a pharmacist and mental health advocate with the Lancet Young Leaders for Global Mental Health. Professor Miranda Wolpert is also with us. She's the head of mental health priority area at Wellcome, an independent global charitable foundation. Dr. Dina Alfani is assistant professor and director of interdisciplinary programs at Hamad bin Khalifa University here in Qatar. And of course, as I mentioned, Professor Helen Christensen, director and chief scientist at the Australia-based Black Dog Institute. A warm welcome to you all. I very much look forward to this conversation today because it's an important issue that we're all facing, obviously, today. And I'm happy to say that this session will be a highly interactive one. We very much look forward to include questions from all of you who are watching us online today. So please do send us your questions in the comment section of your screen, and we'll attempt to put as many of them as we can to our panelists. And of course, by the end, we hope to provide you with concrete actions on how we can move forward on the issue of mental health in the digital age. Now, to kick off our event, we're honored to have a message from Dr. Olivier Véran, who's France's Minister of Solidarity and Health. Dr. Véran shares with us his thoughts on the importance of mental health and the opportunities with digital technologies to improve patient care. Take a look.
Her Highness Sheikha Moza bint Nasser, Chairperson of Qatar Foundation, and Her Excellency Dr. Hanan Mohamed Al-Kuwari, Minister of Public Health for the State of Qatar, for inviting me to participate in the WISH Summit. Madam Director, dear Deborah Kestel, WHO Mental Health, ladies and gentlemen, professors, researchers, health professionals, dear all, it's my pleasure to join the World Summit on Innovation for Health and to speak specifically on mental health. Mental health is a priority, and I know that in Qatar, as in France, this topic has gradually moved to the forefront of our concerns. The World Health Organization estimates that 1 in 4 people will be affected by a mental disorder at some point in their lives, a situation that will affect not only individuals, but also their families, friends, communities, and caregivers. Leading causes of cost and disability, mental illness is ahead of cardiovascular diseases and cancer. Promoting good mental health, preventing mental illness, improving treatment and fighting stigmatization is therefore a real public health issue and a great challenge for society. In France, despite the health crisis, we are committed in a vast plan of reforms to meet this challenge. This is the roadmap on mental health and psychiatry, which is based on the 3 fundamental pillars of prevention, care, and support and community-based programs for integration. The challenge we are taking up is also to move away from vertical logics by fully involving users, health professionals, and all the players who will be required to contribute to the person's personalized care pathway. And I stress this point, a care pathway is also a life pathway. Combining cure and care is not a watchword. It's a small revolution in public health policies, and I am convinced that it is the key to take into account the person as a whole, his and her expectations, life, relationships with loved ones and friends, and his environment. New tools are emerging, and although we have invested digital technologies for a long time in the field of physical disorders, the time has come to exploit its full potentials in the field of mental health. Whether in the areas of screening, health promotion, early intervention, treatment, or relapse prevention research, digital technologies hold great promises. It's our responsibility to turn them into reality. One of the keys will be the ability of carriers and patients to contribute to the design and development of digital tools and to appropriate them. This is part of a whole issue of empowerment, a major issue for patients with mental disease. And this is a priority as long as we imagine a user citizen who is an actor in his own health, a partner in a growing digital ecosystem. This is a particularly important issue in mental health, since this appropriation, as we know, is a fundamental condition for recovery. Another issue to which I pay a particular attention is the promotion of rights and citizenship in persons with psychological disability, because each person, whatever their pathology, must be able to assert their rights and fully participate in the life of their community in the city. Here again, in this field, digital technology is an asset, and it will be one of the themes of the Alliance Interministerial Summit, Mind the Rights Now, to be held in Paris in the autumn of 2021. Until then, I wish your fruitful discussions on the challenges of e-mental health, and I confirm my full determination to give its rightful place in our health policies. This is also a call for scientific cooperation. It's a global challenge, and a summit such as yours will definitively help to meet it. By the way, I also wish you the best for the management of the crisis.
Dr. Olivier Véran, France's Minister of Health, for highlighting the need to exploit digital technologies to their full potential in the field of mental health. Let's now hear from our forum chair, Professor Helen Christensen, who is going to give us an introduction of the subject and overview of the report on digital mental health revolution. Take a look.
Well, hello, everybody. I'm really delighted to be here to present a very short summary of our report for WISH. I'm Helen Christensen. I'm the director of the Black Dog Institute in Sydney, Australia. And I'm here with my co-chair, Tom Insel, who will introduce himself as well.
Thank you, Helen. I'm Dr. Tom Insel from a Silicon Valley startup called Humanest Care. It was a real privilege to work with Helen and our colleagues on this report called the Digital Mental Health Revolution. I'll start by just saying that one of the main issues we had to deal with in thinking about what needed to happen for mental health care, both in developing and in developed countries, was to address the problem of engagement. We know that mental illness is very, very common. We usually think about 1 in 5 people being affected, 1 in 20 really being disabled by mental illness. So these are serious medical problems. And yet, unlike so many other areas of medicine, a big barrier to progress has simply been getting people into care. We sometimes talk about a 40-40-30 rule. Only about 40% of people ever seek care. Of the 40% who do get into care, only about 40% get really evidence-based, high-quality care. And of those, somewhere between a third and a half will actually show the full benefit of getting treated. So when we started to think about how we can begin to change that huge challenge of engagement, that massive barrier to getting care, technology becomes a really important opportunity.
Yes, I couldn't agree more, Tom. And I think one of the things that's happened, of course, in 2020 is COVID-19. And this has brought into higher profile the need to get services and technology-based services to people. We know that 75% of some populations are experiencing psychological distress. Many people are developing mental illness for the first time. And how are we going to deal with the scale of this problem? And I think we're really excited by the fact that, if you can be excited by COVID, that there is an envelope now about doing something where we can deliver digital therapies through the internet to people. And it's not just doing it face-to-face over Zoom. What we're talking about here is amplifying what digital can do and making mental health services more efficient.
We've been really struck in the course of doing this report by what we're calling a revolution. I think it is a revolution, that if there's one area of medicine that's going to be transformed by technology, it may well be this area of mental health. Because, as Helen just mentioned, we have the opportunity to democratize care, that suddenly the main vehicle of care, which is listening and speaking and going through a process of joining with someone in their pain and helping people to recover, can be done through technology wherever you are. And so high quality care can be delivered with now very much improved access in a way that we could hardly have imagined 10 or 20 years ago. So what the report does is it begins to break that down and to show where that's happening, when that can happen, and what some of the best principles are for thinking about where the revolution is right now. In addition, one of the things we talk about in the report is what still needs to happen and where the challenges are in going forward.
Yes, Tom, I agree. And I think the challenges that are really one of the biggest challenges is actually trying to create the right sort of ecosystem, if you like, to allow digital and face-to-face services to work well together and to work well even better than what even the best health services can do simply face-to-face. I think that was one of the big learnings for me from this report, that we can do things better and more efficiently. We can monitor things better through digital health. We can have the scale and be able to reach people.
Yeah, I thought so as well. You know, one of the things, Helen, that I thought was maybe most useful in the figures that are in the report is it breaks the kinds of technologies that are available into two big clusters, one that are really focused on consumers and others that are focused on health systems. And both are important. And we have now an ability to look at the whole range of the kinds of care and the kinds of diagnostics on both sides that are already out there. And we're already seeing some big impacts. Lots more to learn about their efficacy, but clearly we're at a moment where we can already begin to see that this is a game changer. We have the ability now, in a global sense, to have an impact on some of the most refractory and difficult problems in healthcare, which are really these mental health problems. We often say that there's no health without mental health. And now for the first time, we can say we have a way of improving mental health outcomes, even maybe before we're able to do much on other kinds of chronic diseases. So huge amount of traction, a lot of enthusiasm here.
Yes, and I think what we tried to do in the report as well was to give really good case studies of where things were happening and how they were doing different models in order really to showcase the ways in which people can move forward, governments, health systems, consumers, and so on. We looked at in Europe, in the US, in India and China, and in Australia to illustrate different ways in which digital is really finding a way forward. Because I think it is quite a complex environment that we're working in, and seeing these case examples really makes a difference to being able to conceptualize how it might work if you're a particular government around the world at the moment.
One other thing that we think is really going to be helpful in this report that we wanted to call your attention to, the digital mental health maturity model. That is, what we've tried to do in the report is to give people in any sort of role, any sort of position that would have to think about implementing mental health technologies, a sense of what are the issues they would need to look at and the maturity of these systems in different contexts. So issues around trust and regulation, funding and payment, the workforce, how they get integrated, monitoring and learning through this method as well. What we'd like to do and what we have in the report is an opportunity for you specifically to look at where your own needs would be and where the science is, what's available that can help to guide you into selecting the tools and in implementing them in your own setting. So we hope that you'll take a look at that maturity model, maturity matrix, as a way of taking what is essentially now just a white paper, but being able to put much of this into action. We had a lot of excitement in putting it together because we began to realize that not only are the tools beginning to become ready, but they're really, it's at this point possible to implement even in a variety of different kinds of environments.
Yeah, I think that what they're doing in that matrix, Tom, is really, we're really trying to show that where you can already locate yourself in that matrix, and then you can see what the next step is. In addition to that, we've thought about the actors that exist out there in trying to implement and put into place these new digital ways of thinking and systems. And so we've broken down suggestions or recommendations according to whether it's a government person looking at it, a policy person, for example, whether it's investors or developers, what they should be looking for in the next move in the digital space, what health systems can do, and also from an educational perspective, what can educators do to use these digital programs, particularly in preventing the development of mental health disorders in young people, using school environments and other areas to other settings in order to do it. So I think that was a really useful thing that came out of the report as well.
In closing, we are really excited to be able to share this report with you. We do think that this is the moment that, as we often say, meeting the moment right now with all that we're dealing with this pandemic means getting ahead of what we think will be a mental health crisis. We already had a huge challenge before. The COVID pandemic makes this even more of a challenge, even more urgent than it's ever been. This report, we hope, will give you some of the tools that can help you address this and provide better outcomes in an area where the need has just been so great.
I'd also like to acknowledge the wonderful work that our team did, and I look very much forward to actually presenting the report very soon at the WISH conference. Thank you.
Thank you, Dr. Tom Insel and Professor Christensen, for that insightful look into your report. It certainly laid the foundation for our panel discussion. So let's get to that now. And let me just briefly reintroduce our panelists in case you're just joining us on this session. We have with us Ms. Deborah Kestel, who's Director for Mental Health and Substance Abuse, the unit at the World Health Organization. Chinwendu Ukachukwu is a member of the Lancet Young Leaders for Global Mental Health. Professor Miranda Wolper heads up the mental health priority area at the Wellcome Trust. Also with us, Dr. Dina Althani, Director of Interdisciplinary Programs at Hamad bin Khalifa University here in Qatar. And once again, Professor Helen Christensen, Director and Chief Scientist at the Black Dog Institute. Ms. Kestel, let me just start with you. And an important point that Dr. Insel made towards the end of his presentation there, and that is the impact of this pandemic, the coronavirus pandemic. Just how much more difficult has the pandemic made it to effectively diagnose and treat mental health issues?
Well, we have, hello, good afternoon, and thank you for having me here. We have come up with a survey, a report that was mentioned by Minister of Health from France, actually, that showed how the disruption of mental, neurological, and substance use services has been significant. And we are talking about 93% of countries among the 130 that answered to that question that have seen at least one service disrupted. And in that, it means that the capacity to reach out to those in need has been smaller, decreased. We do know that then around 70% of, again, respondent countries have make use of some sort of telemedicine, but we don't know. I think that many of the questions, comments just mentioned by Tom Insel are precisely related to that. We do not know what is the capacity that countries have to use that existing technology, and how countries manage to know what is the good, the useful technology or the useful tools among the 10,000 apps and 100 websites new coming up every year.
It's true that there are a lot of tools out there already. I just want to follow up on something mentioned in the report, Ms. Kestel, and this is the need, it says, to highlight across and connect across sectors, whether it's research, policy, and practice, to basically stop the siloed approach to digital mental health that exists right now and that can trade off evidence-based practices and engagement. So what sort of approaches would you advocate for better connecting researchers, developers, policymakers, and those people who are working on the ground? And have you seen the dynamics shift during the pandemic?
Well, maybe a beginning of a shift, and there are a number of strategies that one could consider. One, funding and project mechanisms that should be set up to ensure the existing evidence that is being used as the basis of digital mental health interventions. Those mechanisms should help in together researchers and developers by the one way to address this issue. And the benefits would be that they can work together, combine expertise on evidence-based approaches with expertise on engaging design and development process. We do have, for example, some tools, psychological interventions, PM+, that was developed as in a traditional way and is now being adapted by researchers into remote delivery version. And this is something that can help. Another issue would be digital mental health tools that should also be developed in partnership with end users. And I'm sure we will hear something about this later on stronger focus on users and application of human-centered design principles that will help to enhance engagement factors and so make more accurate products at the end. Another possibility or issue to consider is that digital mental health interventions should also be made as possible open source. When interventions are created under copyright is hard, right? To ensure that access is going to be available for everybody, no matter the resource settings they have. And then, as I was saying, there are so many applications and tools out there that we need to have some clear guidance on which ones to be used and how.
Indeed, guidance is an issue because there are over 100 tools and websites out there already doing this. Dr. Alfani, let me just come to you and just go back to a basic issue when it comes to mental health, and that is the question of stigma. There's still a lot of stigma surrounding mental health in many communities around the world. And then when you come to young people, there's that added pressure of not appearing weak if they admit to having mental health issues. So how do we take that into consideration, Dr. Alfani? How do we take into consideration local customs and culture when designing these mental health tools?
Actually, firstly, thank you for the invite and for the interesting talks in the beginning. One most important factor, actually, which also Dr. Castell referred to, is the user-centered design. So if we want to design for a specific group, a specific ethnicity, a specific age group, and you want to avoid the stigma, you need to understand this group. You need to know their needs. How do they look at this specific problem? So therefore, we strongly in our field, which is human-computer interaction, we always stress on the user involvement and user-centered design. There is a lot of research that has been done in this toward this school of thoughts. In fact, also in policy making and in the world at large, the famous mantra that says nothing about us without us also lead to this school of thought that you need to communicate to the target group. Usually what we see now, the technologies available out there are targeted toward the Western society, towards society that consider mental health or look at mental health from a different perspective toward another parts of the world. So therefore, we need to include all groups, and by groups, I mean specific nationality, specific ethnicity, specific disabilities, and the different age groups that we look at when tackling mental health problems.
Yeah. Ms. Ukachukwu, would you agree with that? Did you find that the cultural relevance or lack of cultural relevance of the tools that exist right now is an issue? I mean, with Western users being used as a model.
Yeah, of course, especially for young people, there is need to create culturally sensitive content for them in mental health. So the different and diverse group need to be considered in creating digital mental health solutions for young people, because what matters to a community may not necessarily matter to another community. So there is need to create diverse but culturally sensitive content for mental health among young people.
And how do you achieve that?
So there is much need to these content. There needs to involve community developers in creating these, but most importantly, there is also need to involve tech developers, because for the lower middle income countries, there may be access issue, access to the internet, access to data. These access issues are so much seen among young people. So it's a collaborative effort between different stakeholders, bringing the young people to understand their needs, community developers, tech developers. These people need to be there to create youth-friendly and culturally sensitive content.
And you make an important point that there are still inequalities when it comes to access in data, access to Wi-Fi for many communities around the world today. And we'll talk about how we as a global community can address that a little later. I just want to bring in Professor Wolpert. Professor, we talked about the fact that there are currently, 100,000 health mental apps that are already available to download, but there is a lack of standards for development, evaluation, and regulation, most importantly, of these tools, whether they're used for healthcare or self-care. So how then do we do things differently if we're going to create the next generation of treatments and approaches? And what does this mean in terms of the digital agenda?
So I think it's really helpful in this report that we do talk about both ends of that digital agenda that ranges from healthcare to self-care, and not see them as separate parts of the digital infrastructure. And in that, exactly as everyone said, there is a whole plethora of different ideas around about how to support people's mental health. What we're trying to do at the Wellcome Trust with colleagues around the world is trying to disaggregate those into their component parts, and to try and identify what are the active ingredients that really make a difference for different communities in different parts of the world, whether it ranges from cellular change to societal change, whether it's about changing how people think or how they sleep or what they eat or how they communicate or how they work in communities or how much money they have. Any of those aspects need to be thought about in terms of the digital sphere.
Right.
So rather than trying to find one evidence-based app, it's about trying to find the different active ingredients that might be dispersed across a range of different digital areas.
So what are these active ingredients that you talk about? What are they precisely, and what impact can they have on the digital future of mental health?
So they range from the biological to behavioural. I think the mental health science community is just trying to agree what they see as the most relevant and most important. There isn't agreement currently, and the mental health science community is quite fragmented in its views on these. But some of the things that people would, I think, probably come to agree on would be the importance of sleep regulation, for example, the importance of behavioural activation, doing things that are small pleasurable things to address anxiety and depression, the importance of changing mindsets to help you address or manage problem solving or address difficult thoughts, but also about communities and cohesion that we've really seen during the time of COVID, about how communities need to come together, because we know that loneliness is a major problem for mental health problems.
Indeed. Professor Christensen, so how have you seen the global relevance of the key messages of your report shift in light of the pandemic and reshaping of both mental health care needs and mental health care provisions in digital space?
Yes, thanks for that question, because I think COVID has really absolutely elevated the key messages of this report. We've seen this huge increase in telehealth in many countries. And I have to say, I have to preface this by saying, I only know the countries I know, and I do appreciate that there are different health systems and different access. But even in Australia, access to the infrastructure, the internet, is not guaranteed for everybody. So you get this variation across the world about what these structures are. And I agree they absolutely need to change so that everybody has access to the internet. But I think we demonstrated during COVID that digital technologies show that treatment can be delivered through telehealth, and that there is absolute potential for scaling. It is a scaling thing. I think it's changed the views that people have around trust and the culture of digital. So there was a lot of suspicion and clinicians were not all that keen about doing this. And I think because we've had to, because of social distancing, it's really changed people's views about digital. So it creates this great opportunity. I'd say it's amplified a variety of responses. So we have huge use of websites, COVID tele lines, mental health lines, social media. It's all gone up 30 or 40% during COVID because people have needed to reach out and communicate, but also to find out information. And also new treatment programs have been developed, which go from digital all the way to face-to-face. So offering some cohesive interaction between coming online and ending up with the potential of seeing somebody directly face-to-face. I mean, that is very new. That's really a different model that's occurred. And also there's been a lot of training about how to do digital amongst clinicians and so on. But in some ways, not enough has changed because I think we're still sticking to the old ways of doing things rather than looking at what digital can do that's different. So, you know, if you like, we've seen a shift from a room into Zoom, but haven't rather fundamentally rethought how digital can help. So there's a number of ways it can do that by the delivery of automatized suicide prevention ideation apps, for example, across the world, or online programs. These could be delivered right now, right, or having digital programs in schools.
You mentioned, Professor, the shift from a room to Zoom. Once the pandemic is over, hopefully soon, do you think people would have gotten enough used to this idea of Zoom, of having mental health care through Zoom? Or, you know, because a lot of people that I still talk to today say they'd rather have someone face to face than digitally. So how do we encourage people to move to that space now?
Yeah, I think it really depends. A lot of people don't want to go and wait, you know, for 2 hours to see a specialist. They don't want to get on a bus to get there. I think a lot of people have learned that there could be some models where you do have face-to-face with a clinician, but after that you can do mini interviews with your clinician. You don't have to have an hour to do something in psychotherapy. You can actually mix it up and get a different way and more efficient way in which health professionals' time is used. One of the statistics is one person can see 9 people if they use a blended program compared to just face-to-face.
Right. Dr. Alfani, I want to talk to you about the issue of privacy because there are already concerns when it comes to privacy online, and there are already concerns about privacy when it comes to using digital tools. So how do we then convince people to use digital tools on such a sensitive issue as mental health care, when they're already very reluctant to use these tools on a day-to-day basis?
I think as my colleague have clearly stated, that the shift during this pandemic has made us somehow and to some extent trust in the technology. Of course, there are always the privacy risk, it's always there. However, the more trustworthy the sources, the more trust we as a user would have on the tool itself, the more affiliated this tool to research, and maybe because I'm a researcher, I'm more biased toward research, the more affiliated this tool to research basically sources, the more trustworthy the tool becomes. So, and I think of it in the end of the day, it's more of a perspective. And when we design these tools around the user rather than producing the tool to the user, and in the final stage asking the user to try this tool, so if we involve the user way in early on this process, we then gain their trust more. We then gain basically their engagement more. So that's my point of view from the privacy perspective.
All right. Ms. Ukachukwu, we talked about the disparities and the inequalities when it comes to access for many countries around the world. So what do you think, you know, rich countries where this is already picking up, what do you think they can learn from low resource communities in regard to developing digital mental health support?
Okay, so I believe rich countries will learn community supports from low and middle income countries.
Here's what I found.
Most low and middle income countries use groups, social media groups, to discuss. So that offers some sort of community support to the participants using those tools. But most times in developed countries, they use personalized apps, wearables, and other very personalized and individualistic apps that may not bring or offer community support. There is actually very much need to create digital friendship benches that will mimic exactly the friendship bench we have when we used to have face-to-face interaction. So that will actually really be an important lesson developed countries will learn from low and middle income countries that use more of WhatsApp groups, Facebook groups. Why they still use digital technology? They use it in groups and not individually. So that offers the community support that everyone yearns for.
Yeah. Professor Walker, coming back to young people, do you think the impacts of poor mental health on children, on students, on young people in general have been carefully considered and quantified? I mean, how can the people surrounding a young person, families, whether it's schools, communities, how can they be better supported to help a young person find and engage with the appropriate digital tool?
So I think that there is an increasing recognition of the importance of youth mental health, and I think there are many ways to try and quantify it. We don't have fantastic tools at the moment. There's no objective measure out there, and there are 280 different measures of depression, for example, out there that people are using. So one of the things we're trying to do is to try and get policymakers and researchers and clinicians to all use some core measures in common, so we have a common language that helps us at least understand what we mean globally when we talk about having these mental health problems in young people. And I think for parents and carers, it's as others have said, there's no one right way. It's about helping people find the right way for them, which may mean trying out some different things and finding out what works for them in their context.
Right. Ms. Cassel, the report, just coming back to it, it highlights global case studies in various aspects of digital mental health care. What are the best examples that you've witnessed in your experience? What would you say is the best example of how this has worked?
That is a very difficult question that I don't know if I'm able positioned to answer. I don't think we have come up with the best. I think that with also summarizing what has been said, the role of the communities, the role of the specifics in each culture that can match at some points with the evidence and the research that is being generated is what will bring us there on what is the best. I like the expression that was mentioned before about the digital friendship bench. I mean, how do we get there, right? To the community experiences that were developed with using scientific evidence, but then becomes also specifically valid for the culture where it was developed. How do we move from there to some global context and parameters? And how do we use this current situation as an opportunity, as somebody said, right? We learned that it is possible to use digital care. I think we overcome some barriers there. Now it's a matter of saying, okay, how do we get there? And how do we make it, how do we generate hybrids that are a bit of digital care with a bit of traditional care and the community engagement in all of this?
Another barrier, Professor Christensen, is, I guess, investment. You know, the report highlights currently a discrepancy between mental health need and investment in digital between the Americas and the rest of the world. So how do you think that can be addressed?
I've just been listening to this fantastic conversation because I want to just go back to that quickly, and that is, you know, digital is a way for people to connect. You know, the friendship bench digitally is what happens in forums, and people do support each other. But I think for some mental health problems, we really do need that combination of clinician, content and help, or not even clinicians, but that knowledge that is effective in changing people's thoughts and behaviours so that they improve. So I really do think that this mixture, as was just said, between community and the knowledge that's required or has been acquired through clinicians over a long time, which can be shared digitally, is really the ultimate way to do it. It is a question of funding, and it's a question of funding even in America, where there's so many of these apps being developed, because it's got a very much a capitalist market view. In other countries like Australia or Sweden and potentially the UK, it's much more around governments helping to fund the development of a particular intervention. So you don't get that commercial startup type frenzy that you often see in the United States. So I really think that it's ground up. The way in which you can build digital interventions at ground level in every country really comes from the people, and they have the knowledge about what engages people. And when young people see something that's in their language and it speaks to them culturally, they will use it. Whereas, obviously other digital products just won't be of use to them.
Right. And I just want to remind our audience who are watching us right now, if you have any questions for any of our panelists, please do send them to us. I think we very much want to hear from you as well. We want you to be part of this conversation. So just put the comments in the comment section of your screen, and I'll pass them on very soon to our panelists. Let me just come back to Ms. Ukachukwu one more time. If I can ask you, Ms. Ukachukwu, about your experience. I know that you've supported the development of WHO tool to assess mental health needs in emergency settings, in an emergency situation. So what mental health needs did you see arise in crisis settings, and what can we learn from them in order to develop the right support, the appropriate support in this current global crisis that we're all facing?
Okay, in emergency settings, like in different emergency settings, there is much need to integrate mental health service provision to the primary healthcare service that are being offered there. Most people in emergency setting had post-traumatic stress disorder, but their services, the mental health services provided to them, wasn't integrated into the general primary health care. So there is so much need to integrate mental health services as a basic form of the primary health care provided for people in emergency settings.
Okay, thank you very much. So anyone else want to add to that? The needs observed in times of crisis and how we can learn from past experiences to apply to the current experience we're living through. Dr. Kessel, perhaps.
Well, I'm not sure I get fully the question, but while listening, I was thinking about experiences that we collect at the point in just anecdotal way of support that is provided to people in emergency settings that are due to the current situation, the COVID-19, and that is actually far from any sophisticated, newly developed app, but is more focusing on using the technology that is at hand to provide the support that it can be offered at the time. I'm not aware of any specific, again, newly developed tool that has been put in place.
All right. Well, that was an incredibly important and meaningful discussion. I want to thank you all very much for sharing your ideas with us and offering solutions on how we can address this critical issue. We have questions now from our audience who have questions about how we can move forward. Okay, so questions, audience questions. I have one here, and perhaps I'll put that to you, Professor Christensen. What is the one message that you would want a health system leader to take away if they're considering embedding digital tools in their mental health care systems for the benefit of entire communities? What's the one message you would push?
Wow, that's a hard question to answer. I certainly think that looking at what is already existing and seeing where health systems are going, and then working out what the goals and aims are of your need, your health service, and then designing it backwards so that digital can be actually enhancing that service. So, you know, we tend to just think about what's required and think in old ways, but really if you think backwards and try and map out what are the digital technologies that can fit in to facilitate those sorts of goals that you have for your health system, I think that's the first, a pretty important thing to start with.
Mm. Professor Wolpert, I guess the same question to you. I know that Wellcome is a strong proponent of ensuring that those with lived experiences on mental issues are involved in all aspects of developing mental health support. So what advice would you give to global leaders thinking about how and why to engage patients and the public with lived mental health experiences?
So I think it's, as Helen was saying, it's designing around the needs of those you're trying to serve and making sure that you are meeting those needs and looking at their needs for wellness. And as I think Helen was saying earlier, those needs will vary depending on the type of mental health problem that people have and the range in which there could be for self-care through to healthcare needs in relation to that. So I think there's a real opportunity here for us to rethink how we provide care, but also how we empower people to make their own decisions within that. And there's an opportunity for both policymakers and healthcare providers to join forces in that.
All right. Thank you for your answer. Dr. Alfani, one here for you. How can we design digital tools to ensure that they're inclusive and that they support mental health and quality connections while avoiding potential harm such as screen addiction concerns?
That's a very good question, actually. So screen addiction has been correlated now in the literature to mental health problems. And terminologies like the fear of missing out, which refers to an individual feeling the need to always be online, always be on social media, has also been strongly connected to internet addiction, and that leads to anxiety and disorder. And those symptoms exhibit behavioral addiction that is also basically treated from a psychological interventions. How can we sort this out? I strongly believe the tech giants has actually hand in worsening such a situation. And what I believe, what I strongly believe is involving the user from day one of requirement gathering, having the user, your target group, as a member of the design team, and there where the terminology participatory design or collaborative design come through. And I feel to design such technologies that would be of help, we will always need approaches such as co-design and participatory design. However, I know these approaches are very challenging to put on in the real world, but I think we have to try to do that.
Yeah, Ms. Ukachukwu, your thoughts on this? How do we design digital tools while also taking into account, the potential harms that these tools can create for young people, especially, screen addiction concerns and so on?
Okay, so there is much need for regulation of the 1001 mental health apps and services out there. But most importantly, there is need to co-create with young people, because you can't understand their needs and you can't talk about them without them being involved. And when they are involved, there is need to empower and encourage young people. But most importantly, there is need for an integration between app or web-based services and the community services for full participation and usage, especially among young people. And interestingly, there is need to expand internet access. Internet access should actually be a basic human right, especially in these our times and age. So young people can have access to internet and they will be able to access services online and utilize the digital solutions being provided out there. Thank you.
Thank you for your response. Thank you. Ms. Wolpert, Ms. Ukachukwu mentioned an important point there, regulation. As she said, there are over 100,000 mental health apps currently available. You know, if digital mental health is going to be the thing of the future that everyone turns to, who should be responsible for regulating it?
So I think the digital mental health revolution also requires a revolution how we think about regulation and control, and how we think about who controls data and in what forms. And I think there's a real danger sometimes that we set up false dichotomies between people being more concerned about privacy than public good, for example. If you ask end users themselves about what they want their data to be used for and in what ways, they may have different ideas about openness or others, for example, for research, than commercial providers may have. So I think that it's really important here not to impose old models on our new world. We need regulation both for healthcare that's face-to-face and bricks and mortars based, as much as we do for healthcare that is provided by digital. And we must make sure we don't set higher standards for digital because we fear it's new and we don't understand it in the way that we haven't imposed on bricks and mortar healthcare. So I just think we need to be careful here that we have an opportunity to create new ways of empowering end users to have control and make decisions for themselves whilst also protecting them. But it won't be the old system of regulation.
Professor Christensen, your thoughts on that? Who should be regulating this?
Oh, I really like Miranda's answer, because I think, first of all, around data, the user should own the data. The user should own the record rather than somebody else owning it. But I do think that governments have a role to play in regulating to some extent standards. Just like they have standards in regulating healthcare services, they should have standards in regulating mental health or digital services. So I think there's a parallel thing there. I feel that we also I've just done a review on the effects of screen time, and I think to some extent, while I'm cognizant of the fact that there are these correlations between it and understand the points that have been made, I don't think we actually know the extent to which the digital is actually causing people to be more depressed, or whether people are seeking digital for solace or for the wrong reasons and so on. So I think we have to be very careful about these relationships between digital, which is also being used, I think, sometimes to make the argument that, you know, for example, suicide rates are going up because young people are exposed to digital technologies. And I just don't think we have enough information yet to know that's the case. We should be careful. I agree we should be careful, but I think we have to really look at these and if you like, the last 20 years that I've been working in this area, these views come up all the time, and yet we really do need to keep challenging them, as we can see some of the positive things around digital health as well.
Ms. Castell, another question here from our audience, and this one asks, building on the use of data from these tools, what benefits can digital provide to research that understands mental health needs that we can't get from traditional methods?
And thank you for this question also, because I wanted to make a comment in the previous one, and this is related. I mean, I think that we should not forget some of the comments that were made at the very beginning. The number of people with mental health issues has already been big and considerably before COVID. We are seeing now a trend that is maintaining or increasing some of those numbers. And what we knew from before and we know now is that the services out there are not available. And so although digital care is maybe great in the possibilities that offers, including regarding new data that can be made available, the responsibility is, in my opinion, from governments to make sure that services are out there that are responsive to the broad needs of the people with mental health issues, including whatever is available in the context of digital area. So if there is a possibility, as I was saying earlier, to establish a regular mechanism of exchange between developers and science researchers and policymakers, then the data that is generated can be used to improve the situation. But there is something that was mentioned not too deep maybe for the next opportunity, and is the need to increase funding for mental health from the government.
Where do you get the funds from? That is a really important question.
Because we don't, I mean, the funds globally that are spent in mental health are 2% of the health budget, and we are saying the mental health is so important, and the numbers are increasing, and the impact is huge, but there is no funding to those
Why
needs.
do you think that is? Why do you think, despite the needs that are out there, the funding is still lacking? What is that down to?
I think that the knowledge about mental health is still developing, although for us, some of us working for so many years, is so clear, right? But the stigma is still high. The priority has been forever, for many, many years, into traditionally communicable diseases, and we see why, right? COVID is impacting us. But then the role that mental health conditions have in populations has been minimized, has been ignored, has been not considered. So slowly we are bringing evidence with all the work that is being done from these different aspects, and hopefully we'll be making the case to explain to policymakers and demonstrate to policymakers that there are problems, but there are also solutions. And if we want the solutions to happen, we need to invest in those solutions. And the solutions are broad and diverse. That's another reason probably why mental health has been lagging behind. There's no one particular, there is not a vaccine that can prevent or eliminate the mental health problem. Indeed. It's much more complex than that.
Indeed. Dr. Al-Thani, can you tell us about the experience here in Qatar? We talk about mental health, being still surrounded by stigma in many communities. And we talked about, the lack of funding in many communities because of that stigma. What is your experience here in Qatar in dealing with this issue of mental health?
From a research perspective, in terms of funding, actually, I was part of a grant led by Dr. Muwaffaq Housa, who is actually one of the people contributed to this report, and it's on digital mental health and chatbot, intelligent chatbot. So in terms of funding in Qatar, I see, in fact, this is highlighted actually as one of the priority areas within the Qatar National Research Fund Institute. But as well, in terms of the medical or the public health in Qatar, there is, I see a lot of campaigns that happens during COVID and prior to COVID that highlights the importance of mental health, and basically people taking the initiative if there is a problem to come forward and seek for help and ask for help.
Okay, one last question for Ms. Miranda Wolpert, and this is also a very interesting and important question, and it's how can research keep up with the tech sector, which is innovating so quickly, and but we still need evidence about what works. How can the research sector keep up with the tech sector?
Great question, and 2 points on that. I think we are in the midst of a digital revolution for mental health science, and the opportunities are amazing. Tomorrow we'll announce the launch of our first global mental health data bank, which will try to draw together some of the things we've talked about today and some of the principles of the report, where young people are helping form ideas around what data should be collected about mental health and in what form, in a way that can be shared with researchers globally to try and understand what helps prevent and address anxiety and depression in young people. And if we can find ways of doing that can be scaled, then those are the ways that digital can be enhanced to revolutionize research. The second way, I think, is that we need to find ways of having really productive partnerships with commercial agencies, the big tech players. I think, as Helen said earlier, and as others have said, we've got to be really careful not to demonize, whilst also recognizing some of the difficulties and tensions between the commercial agenda and the research agenda. But if we can find a way of collaborating here and finding sweet spots where there is a health compact around what good health looks like for the users of those big tech platforms, then there is an opportunity here to do research at scales that have never been thought of before.
Collaboration is the key word, of course. That will bring this discussion to an end. We'll end it on that note of collaboration. Thank you all very much. for your insight and sharing your views and experiences with us on this very important issue that is mental health in this digital world that we live in today. And as we've learned from the report, the next generation of technologies need to combine the best of clinical science and consumer engagement. Developers and healthcare providers alike need to come up with solutions that are different from traditional mental health services. A profound change and shift is needed, as we've heard from all of our panelists, and technology will help achieve that. As we deal with the COVID-19 crisis, it's become even more critical today that we focus on the well-being of our mental health and that reach millions of people. There needs to be a next generation of digital mental health innovations connecting across sectors from research to policy and practice, while ensuring at the same time that there's equality in access and that it's tailored to the needs of different cultures and communities. Thank you all very much once again for your valuable insights, to our online audience for watching and taking part in this important discussion, and of course to the whole Wish 2020 team, the Qatar Foundation and all its partners for making this event possible today. I'm Foliba Thibault in Doha. Thank you very much for being with us once again. Have an excellent day.
Of Equality, the African Network of Medical Excellence. Is it possible and sustainable to provide free, quality healthcare to everyone who needs it, respecting human rights and ensuring the dignity of every individual? In countries affected by conflict and poverty, there is a serious need to rethink the models of international cooperation in the health sector. This panel aims to bring together international health and development experts to question the idea of two-tier medicine in favour of more comprehensive approach for an equal access to healthcare for all. So I would like to introduce our speakers. We have Dr. Ahmed Al-Manhari, the World Health Organization's Regional Director for the Eastern Mediterranean. And Dr. Al-Manhari, where are you joining us from?
From Cairo.
From Cairo,
Egypt.
Lovely. Thank you so much. We also have Dr. Paul Farmer, who joins us from Boston. He joins us in his capacity as co-founder and chief strategist of Partners in Health, an international non-profit organization driven by the belief that healthcare is a universal right. Hello, Dr. Paul Farmer.
Thank you for having me.
And also we are joined from Milan by Rossella Micio. who is the president of Emergency, an NGO offering free medical and surgical treatment to the victims of war, landmine, and poverty, alongside building hospitals and training local staff. And this panel is partly in thanks to the partnership of that organisation, Emergency. Hopefully, we will be joined by another panelist as well in Uganda. I think some slight technical difficulties there, which of course we can forgive. This is a technical feat of genius getting everybody together in this virtual way. So hopefully she'll be able to join us in a few minutes. Rosella Micho, I wanted to start with you. It was your organisation, Emergency, that set up the African Network of Medical Excellence. Firstly, how many countries are involved? What's the model? How is it different?
Good afternoon, everybody. 10 countries signed the Manifesto for a Basic Human Rights Medicine that was the basis of the development of the African Network of Medical Excellence. The idea was very simple, was to identify health priorities, health gaps in these countries, and then establish centers of excellence in each country in the different specialty, and then have them working as a network, both in terms of patients referral, but also in terms of training of the medical staff, and also developing joint research programs and sharing the medical knowledge. And this was a model that we identified as feasible and badly needed to fill the gaps that we identified to strengthen the health systems in Africa.
So localized healthcare systems, and what was the inspiration?
Well, actually, the first experience was the Salam Center for Cardiac Surgery that we established in Khartoum back in 2007 with the idea of providing these very specialized services, cardiac surgery, not only to Sudan patients, but also to the patients coming from the neighboring countries. And actually, we have been operating on patients coming from more than 30 countries. And therefore, from that experience, we decided to sit around a table with the ministries of health of the countries involved, trying to understand if this could be a model, a replicable model, something that they would be interested in, and how to develop it jointly together, because it was supposed to be, and it is, a joint effort of NGOs, local governments, international bodies, and community. It cannot be just a one or two single actors approach and initiative.
So it's a model that can be replicated across many different countries instead of random, if you like, individual clinics with different partners and different funding. And Dr. Paul Farmer, you have experience down on the ground in Haiti, for example. You've seen there the poverty, the lack of healthcare. From your perspective then, can this model centered around these centers of excellence, can they really tackle key health gaps in low-income countries?
Well, you know, my experience is that not only can they do so, it's really one of the best ways to address really complicated health problems. We've worked with Emergency, for example, in settings where, you know, if you open your doors as a clinic or a hospital, you know, pretty much anywhere in what, you know, just to use a metaphor, might be called a medical desert, you're going to see patients, a lot of them very young, coming in with all kinds of problems. And, you know, the first time you see a child come in with a, you know, heart valve disease who's gasping for breath, and the idea of having nowhere to send that child is a crushing defeat, obviously, for the family and the patient, but also for the caregivers. So, you know, having these centers of excellence that can lift up aspirations is an important contribution well beyond the number of patients that could be seen in a center like Khartoum. We've also sent patients there, by the way, from Rwanda. And what we've done in Rwanda, working with the same approach with the ministries of health, with the folks like Dr. Ahmed in WHO, is to establish centers of excellence. In fact, we've even done it in rural areas, rural Haiti, rural Rwanda, rural Malawi, rural Lesotho, because for lots of reasons. One is that many Africans live in rural areas, but another is that is the most desiccated part of the clinical desert, and lifting hope can lift hope across entire nations. So I would even put it this way, Luisa, my experience is that this is the best way really to propagate excellence, especially in this in the post-colonial setting where for so long there were no aspirations to excellence locally. There wasn't even attention paid to proper care for the natives, as they were called, under colonial rule. So we're making up for lost time as well.
But does it really cater for even more distant, marginalized communities? I mean, you talk about these centers really filling a gap in a clinical or medical desert, and it sounds fantastic. But what about outreach for those people who can't even get themselves to these clinics for all sorts of reasons?
Yeah, that is really the key question. One of the reasons that this model is linked to not just to other district hospitals, as they're often called across the world, that is a local regional hospital rather than a referral center of excellence, but also to clinics and communities through community health workers. And I can just tell you, if we send a child, from Rwanda to the Sudan for a valve replacement, depending on the kind of valve that's used, that child may need anticoagulation with a medication that has to be taken every day, so that a lot of good surgery probably ends badly because of the lack of follow-up. So implanting these centers of excellence into national healthcare delivery systems is the key. In northern Rwanda, and we have established a center of excellence for cancer care, and it's again in a rural area. When I was just back there in the height of the COVID pandemic, I asked, well, what happened to the patients during the shutdowns, and found that they had all been found in their home villages, and if necessary, brought back up for their chemo or whatever, or their therapies brought to them. That's what happens when you take this model that Emergency has been promoting and implant it into a proper national healthcare system. So I'm a true believer.
Okay, thanks, Dr. Farmer. Well, we can see Dr. Diana Atwine there has managed to join us from Uganda. Just waiting for confirmation that the audio channels are working as well. So, Dr. Diana, can you give me a thumbs up if you can hear me, please? Just waiting for Dr. Diana to put her microphone on.
Can you hear me now?
Yes, we can hear you now. Thank you so much for joining us from Uganda. We've been hearing about the centers of excellence that have been set up. Oh, and I think she's gone again. I think we've lost Diana. Well, hopefully we will be able to hear from her before the end of the session. But thank you for that, Dr. Farmer. And now, Dr. Ahmed Al-Mandari, I want to turn to you. And before I do, I just wanted to point out something that the UN Secretary General Kofi Annan said, the former UN Secretary General. He said, a rights-based approach to development describes situations not simply in terms of human needs or of developmental requirements, but in terms of society's obligations to respond to the inalienable rights of individuals. So, Dr. Ahmed, how can the international community contribute to ensure effective and concrete fulfillment of a rights-based approach to health?
Thank you very much, Louisa, for leading this discussion. And in fact, I may start, as you all know, we live here in Eastern Mediterranean in a very dynamic and diverse region with a lot of challenges, social, economic, and demographic challenges. And at the same time, I must say also, we share strong values of solidarity that promotes partnership, so that we are able to give a voice to those, if I may call them, voiceless. And just listening to Paul and Rosella, is a true reflection of that sort of partnership, either between the UN agencies or between non-UN agencies. For us in WHO, a key priority is ensuring healthy lives and well-being of all here in the region and beyond. Our driving force for that aim is, as you all know, the SDGs in general, and SDG number 3 in specific when we talk about health and pure health-related issues. And these sort of targets and goals are framed within something called General Program of Work number 13, which is guiding WHO in general at a global level, as well as regional and country levels. Here in IMRO also, we have added to that sort of driving force, the GPW 13, focusing on the SDGs, and SDG number 3 is the IMRO Vision. We call it IMRO Vision 2023, which is health for all by all, a call for solidarity and action. So to make sure that everyone in the Eastern Mediterranean region can enjoy a better quality of life, as you have mentioned. Now, at the heart of these sort of good, sort of terminologies, we have something called the universal health coverage. And it is considered as one of the best tools within which we have the primary health care. This means that all people and communities and individuals in these communities can use the promotive, preventative, curative, rehabilitative, and palliative healthcare services they need of sufficient quality to be effective, while also ensuring at the same time the use of these services by those people does not put them on financial hardship, as what is happening in many parts of the world. And here I must just mention the spirit that was carried by Alma-Ata Declaration more than 40 years back. And recently, 2 years back, Asitana, in which we have all met, in fact, UN and non-UN agencies, Asitana Declaration at a global level. At a regional level, in fact, 2 years back, September 2018, we met in Salalah, Oman, in which we have had, this Global Compact 2030 and Salalah Declaration to make sure that these sort of noble driving forces and guiding principles for us all as a UN agency are really implemented at a country and regional levels.
And Dr. Ahmed, sorry to interrupt you there, but to that point, in your experience, which actions should states prioritize in order to achieve the goal that universal access to healthcare is put in practice for everyone without discrimination? What should states be prioritizing?
Exactly. I mean, this is something that we have been working with member states and donors, as well as UN and non-UN agencies, by creating partnership. So member states are requested and asked, in fact, to prioritize actions on strengthening primary healthcare in general, to make sure that people at the center or the peripheries of each country are getting access to a quality and high-level safe service, focusing on family medicine with its holistic meaning, introducing packages of essential healthcare services to make sure that every citizen is getting access to these services, facilitating and improving whatever payments that are supposed to be there for these services without putting any hardship or any sort of burden on the communities, and engagement of individuals and communities in their own healthcare services to promote their health, And then, as I said, partnership, strong partnership. That's why we call it health for all by all. Health is no more the responsibility of the Ministry of Health. It is the responsibility of every organization, every individual in the community, and every authority, government and non-government authorities in each individual country.
Thank you. And Dr. Farmer, I guess you'd agree with that, because Partners in Health really believes that healthcare is this universal human right. But, you know, we are seeing that it is possible, but is that a very utopian view, if I can play devil's advocate? Because, you know, it comes down to funding, it comes down to training, it comes down to having enough people to even be able to help others.
Well, you know, it's certainly utopian, but the alternative is, of course, to have a dystopian view of this, and that's very much what many are facing right now, a dystopia. I mean, that's what has led the three of us, and I'm sure Dr. Diana as well, into this work. This was a very troubled arena where, of course, healthcare is not functionally a right at all. So the utopia is necessary as a guiding aspiration, just like a center of excellence, to lift up our aspirations. But I would just say this: every effort to promote universalism is going to drag up the quality of care, as long as it is accompanied, as you just said, Luisa, by the right investments. And I want to go back to Rwanda, which has been a real standout on the continent, not just for its improvement, which has been stunning. In fact, looking at mortality data and life expectancy at birth and following a number of pathologies, Rwanda has shown the steepest declines in mortality ever recorded at any time and in any place. And if you want to know why, you've got to know about their investments in a national healthcare delivery system. Emergency and Partners in Health are NGOs. They're by definition non-governmental. But when we can contribute to the efforts of a visionary, for example, government that is putting up to 20% of its public treasury into healthcare delivery, we're going to see big results. And when we can coordinate that in the manner that Ahmed said, we're going to see even more yield on these investments. And after all, it is governments, not NGOs, and not the World Health Organization, that can confer rights, right? The right to healthcare is not something that an NGO can waltz into a country and say, hey, we're going to decree that you have a right. This is the obligation of governments, as Ahmed said, and pulling together, and through collaboratives like the one that Rossella has described, we think is going to help make a difference.
Rossella, to that point, you've had to encourage governments and ministries to get on board. What are the constraints you found in establishing this model of the centres of excellence? Rossella, if you could put your mic on, please. Thank you.
Sorry. Yeah, I was just saying that I totally agree with what Paul just said. I mean, a utopia is not something that it's impossible. It's just a project that is not yet been in place. So we should just work towards it. And this is what we have been trying to do. Of course, the constraints are many. One is, let's say, constraints in terms of a general approach. When it comes to proposing to dedicate attention and allocate resources to medicine of excellence, because most of the attention and the resources are going to primary health care, or to just infectious disease, which is of course needed, but it's not enough if we really want to have a human rights-based approach. Because if we just limit ourselves to those sectors, it's like we are stating and acknowledging that there are different rights according to the place where you have born, when you're born, and this is something that we cannot accept. Therefore, it's first of all a change of mindsetting, of attitude, and then it's of course trying to find the resources necessary. But I think that the resources are there, both in terms of economic resources, knowledge, human resources, and actually this approach can trigger a positive fallout, a positive effect also to the other sectors of health system, and then result in an overall strengthening of the system.
Yeah, and Rosella, we were supposed to be joined by Dr. Diana Adwine from Uganda. We saw her, she disappeared. I don't know if we'll get her back. Oh,
I'm here, my dear.
She's here, brilliant. We can hear you, you can hear us, all is good. And perfect timing, Dr. Diana, because I wanted to ask you, the second centre of excellence in the network is due to be built in Uganda. You, from the Ugandan Ministry of Health's perspective, what encouraged you to want to collaborate on this project? And tell us a bit more about it. Dr. Diana, is your microphone on?
Yeah, I wanted to start from where Rosella stopped from. First of all, Uganda, as part of the African countries that has still growing, yet with a high disease burden. When we talk about infectious diseases, it accounts for over 60% of the cases registered in our hospitals. And then now also we are seeing now the lifestyle diseases, the non-communicable diseases on the increase, and yet they are very expensive to treat, as you know. Now, we have, first of all, as a state, we have to balance. We have to treat, we have to take care of the primary health care issues. We have to treat the infectious diseases, but at the same time also, we are now investing heavily in improving on the tertiary services. But now, as you know, in Uganda, we still have the big gap in funding for health. And so we are seeing a lot more diseases that are very difficult to treat, for example, out of pocket, and people are spending a lot of money to treat, for example, cancer, from heart disease. And now what the country is doing right now is to set up the centers of excellence so that we are able to offer these services for free. We have expanded Mulago. Now we have introduced, actually today I wanted to give you good news this morning. We have separated the Siamese, our doctors had carried out 20-hour surgery to separate the Siamese, where the Siamese were even conjoined all the way from the spine to the genital organs, to the bones of the spine, and they have successfully separated this. But it took a lot of work to invest in technology, to invest in equipment, to invest in infrastructure and human resource. We cannot say that we are there, but let me tell you, to offer universal health coverage, it has to be a multifaceted. We can't do it alone as government. That's why we are collaborating, for example, with Emergency, and we welcome them so much because they are bridging the gap where, for example, the people who cannot afford can get the services for free. And we do believe that even if we really as government wanted to offer free services to everyone in the country, give free services for cancer treatment, give free services for surgery, give free services for maternal health, it cannot happen because we still have huge numbers of diseased community. Actually, right now, government is investing more money in prevention. We are now looking at preventive method as one of access to universal health coverage.
Diana.
Yes, please.
Thank you so much for explaining all of that, and very interesting to hear all the challenges that you're facing in Uganda, but that you welcome this new Centre of Excellence. Tell us a little bit about it. What's it going to be?
The Center of Excellence of Emergency is going to offer free services, free specialized services that otherwise would make Ugandan children fly out of the country and
so
go
it's
and
pediatric surgery.
Yes, please. And it is going to offer a wide range of conditions, gastrointestinal diseases, spinal diseases, the heart diseases, and so many. But otherwise, where those vulnerable people, where they would not be able to get their services and have their children die, these are people who are coming in the country to bridge that gap, to make sure that everyone in the country who deserves to be treated actually can access the service for free.
And having gone through this process, when will this Centre of Excellence be built? When are you expecting it to be up and running?
It was supposed to actually to open in April because of COVID. It was not possible, so we postponed it, and we hope, if all goes well, we are going to open it in January next year. But all is set, and we are looking forward to seeing this Centre of Excellence fully operationalized.
Fantastic news, and let's hope that happens early next year. Having been through this process, going through it, which lessons that you have learned would you share to the benefit of future countries looking at replicating this approach? What lessons would you share with other nations?
There are 3 lessons that we have learned through collaboration with Emergency. The first one is that we do still have philanthropists that are really out there that are willing to support. So if we work with those people, they can actually expand the services, and we get more people who are vulnerable, who don't have any hope, and they can be given the chance to live. The second lesson is that we can actually collaborate, because I think before we don't have this kind of arrangement where we work with NGO, where a full government works with NGO that is able to give national services and set up a Center of Excellence and run it and give excellent services and sustain it. Number 3, it is also an avenue for us to prioritize the skills that are needed. The emergency services is not only for this hospital, is not only for treating, but is also going to offer specialized training, especially nursing training in these key skills, because we don't have enough workforce. So we are also looking at this opportunity, and we know that this is possible, and we are going to build a big workforce that is specialized, and it can even, that service can spill over to other hospitals, because we will get the expertise and we take them also to other hospitals, and therefore it will be the springboard for the improvement of care in the country.
Dr. Diana, thank you so much. We'd love to hear some questions from the audience. Please do submit your questions and I will put them to the panel. Just before I go to those, a question again to you, Rosella. You've got decades of experience running high quality hospitals from Afghanistan to Sudan. How can you ensure that the model of these centres of excellence that you're proposing is sustainable on a large scale and a long-term basis?
Well, I think that the key of the success and the long-term sustainability is the involvement of local authorities and the local community. Because at the end, as Dr. Diana was saying, I mean, we are just partners coming to help and support, but definitely the final owners are the local communities. So, and I really think that when it comes to providing quality services that are patient-centered, this makes the difference also in terms of engaging the local authorities and the local communities. We have seen it everywhere. I mean, the hospital in Sudan, as the one in Uganda, but also the one in Afghanistan, are supported by the local ministries of health, also in terms of funding, which is something quite incredible, if you say, but it's true, it's real, it's not utopic, it's the daily practice. So when you work in a real partnership and share the same aim of strengthening the local health services with a quality approach, then I think that resources can be mobilized and people also feel more, let's say, convinced to be part of a project.
Thank you, Rosella. And Dr. Farmer, do you have some ideas then how we can ensure these centres for excellence are going to be there for years to come and in many different nations?
Certainly, and my experience is very, our experience rather, is very similar to that of what Dr. Diana described and Rosella as well. I mean, just to give an example, in founding the Center of Excellence that I mentioned in northern Rwanda, not far actually from the Ugandan border, you know, Partners in Health built in 15 months a modern hospital, but for the government of Rwanda. It is a Ministry of Health hospital, just like the big one we built in Haiti after the earthquake, right? And within about a year of opening that hospital on government land, the Ministry of Health and other parts of the government were paying over 70% of the salaries of the staff there. And you know, it's not, when we use the word sustainable as an adjective, like something is a sustainable or not, it's often to get us away from the utopian vision that we need to pull us forward. The question is, can we sustain it? And here we are 10 years later, that that Center of Excellence is growing. And again, the government, largely the Ministry of Health, but other branches as well, have been so excited about this progress, which they regard rightfully as Rwandan progress, that they've helped us to establish a university in that same formerly rural area to focus on what Diana describes as a need, which is building up the workforce that was never built before during colonial rule. And I'm sorry to keep going back to colonial rule, but it's amazing to me that, for example, in Sierra Leone, where the British could have been there over 2 centuries, they didn't even build one medical school or a nursing school. So again, that's why I think it's important to say we have a lot of catching up to do.
Well, that's interesting. You talk about that colonialism, because we've had a question in from the audience, which is to you, Dr. Farmer, which is, are there colonial artifacts left baked in the infrastructures of African countries that are obstacles to health delivery? And from what you've just said, it sounds like the fact is that nothing was done to help the health care in these countries.
Well, something noxious was done, you know, and I'm not disparaged. I'm sure there were many good things done as well. And I'm sure there were some visionary colonial health officers. You know, you can read their biographies, no doubt, or their autobiographies. But what was done that was noxious was to knock down people's aspirations inside, for example, post-colonial governments, and in which it became considered utopian to try and do anything that would rival the kind of basic services that are taken for granted in other parts of the world. So although there aren't many victories from colonial medicine, there was some damage done. And I think that's why I've always been a supporter of emergency, because, you know, from the beginning, when a kid steps on a landmine, you know, in Afghanistan, and if there's a team there to say, no matter what has happened here, we will do everything possible to put this child back together, that's the kind of utopian vision that we need to lift up, you know, health, to lift up the fight against health disparities. And that's why I keep going back to Rwanda, because on a national level, they've moved forward that ambition.
Thank you, Dr. Farmer. We've had a question in: how has the global pandemic made you reassess the different factors that could impede building the Centre of Excellence network? But I guess that could also, you could give your thoughts about how it's affecting the improvement of healthcare generally. And Dr. Al-Mandhari, would you like to answer that? How COVID has affected the situation from your perspective at the World Health Organization?
Yeah, thank you, Louisa, for this important question. In fact, I must say that this pandemic is like, you know, a big shake to us all on Earth. You know, either when it comes into healthcare leaders, professionals, decision makers at different levels on different sectors, including the political leaders, It showed us how strong our healthcare systems, but the most important thing that it showed us, if I may call it, how weak our healthcare systems when it comes into facing such global pandemic. As we have seen it, many countries, not only low resourced or middle income countries, but countries which were considered as having the best healthcare systems, went into a very serious, crisis in terms of making sure that healthcare services for this pandemic in specific are made available on time with minimal loss of lives and minimal cost on the healthcare system and the financial cost, but also to make sure that whatever other healthcare services that are needed by a wide range of people in the community, children, adults, men, women, are made available, which was not really, which we did not succeed in that. So this pandemic showed us what opportunities that we should really make use to improve and strengthen our system to make them more resilient in case we face similar scenario in the future. At WHO, there are three levels, or three types of committees that have been established and led by top political and technical leaders to assess and evaluate how WHO reacted, to this pandemic and how member states reacted to this pandemic, as well as other agencies, have reacted and getting the lessons learned. So hopefully we will learn the lesson and we will make sure that our systems are well improved and becoming resilient for whatever shake in the future, regardless of its scale.
Thank you, Dr. Al-Mandhari. Any other thoughts from the panel then on COVID?
Well, if I may add something from our direct experience on both sides, let's say here in Italy, which was one of the countries, the first country actually in Europe affected by COVID, and then the other countries where we're working, we immediately realized that one of the major problems to face was how to guarantee the continuity of COVID, of healthcare for non-COVID patients, because if this was an issue in Italy, where the health system is well structured, can you imagine in a country where the health system is much more weak? Therefore, the first thing we did was really to protect all our facilities worldwide with the training in IPC, procurement of extra DPI and so on. And this allowed us to stay open all through the first wave of the outbreak, and even now, fortunately, in countries where there is an acting war, like Afghanistan, but also in Sudan, for example, where we were the Salam Center, the only center for cardiac surgery that was always open and providing life-saving treatment to the patients. So this means that also when it comes to sudden, unexpected emergencies, perhaps there is something more that we can do to protect the entire community and to make sure that these new diseases do not affect additionally all the other situations that are already there. So definitely, I welcome very much the efforts also in WHO to revise and to discuss, because this is really something that we have to think about a lot for the immediate future and for the long term.
Yeah, thank you. And Diana, are you still with us? Is Diana still with us from Uganda? No, I think she has dropped off this call. So just one last very brief question. Dr. Farmer, do you feel that the model can be transplanted in other places, in war-torn countries? This would be hard, but needed the most. Well, I guess this is what the Centres of Excellence is aiming to do as well. Very briefly, please, Paul, as we're running out of time.
Thank you. The short answer, Louisa, is I am sure of it. You know, a lot of the places we've worked have been in immediate post-conflict situations, whereas emergency, like Doctors Without Borders, have gone in even when there's active conflict. But we know that once the guns are silenced, you can build very quickly centers like these that can make all the difference. In Haiti, for example, and I will finish here, Louisa, in Haiti, this hospital that was built after the earthquake became the national referral center for COVID because it had the staff, space, and systems required to take on a respiratory disease because of experience with trauma care. So I'm convinced.
Dr. Paul Farmer, thank you very much. Paul Farmer from Partners in Health, Rosella Micho from the NGO Emergency, Dr. Ahmed Al-Manthari from the World Health Organization. We also heard from Dr. Diana Atwine from the Ministry of Health in Uganda. So nice that she managed to break through the technical problems. And we heard that wonderful news of the conjoined twins being separated in Uganda as well. Thank you so much, all of you, for sharing your thoughts on centers of excellence. I will be back tomorrow for another In Focus panel when we'll be discussing the very topical issue of COVID and delivering the vaccine. Thank you, everybody, for watching and joining us today. Goodbye.
Thank you, Louise.
Thank you.
The year 2020 is the International Year of the Nurse and Midwife, as designated by the World Health Assembly. And believe it or not, the choice was made before COVID-19. Welcome everyone, wherever you are. My name is Rawa Oje, and I will be your host for this panel, part of WISH 2020. Everyone talked about them this year. Everyone applauded them and lit candles for them. The front line, like many like to call them, the White Army. But they are not soldiers. They are leaders at the forefront. And as Her Royal Highness Princess Muna Al Hussein said in her speech in front of the World Health Assembly last week, applause without action is no longer acceptable. Recognition without rights and proper remuneration is not sufficient. Through this panel, we will talk about challenges, but also about actions to take and how we can build on this year's recognition to improve the conditions in which nurses and midwives work globally and locally. Let's welcome members of this panel. I have with me in the studio Professor Debbie White. She's Dean and Professor at University of Calgary in Qatar. And we have with us Dr. Sana Al-Harahshi, Senior Associate of Research and Policy at WISH. We have with us also Professor Ruwaida Al-Ma'aita at the Faculty of Nursing from Jordan University of Science and Technology. We also have Mr. Jim Campbell, Director of Health Workforce at WHO, and he's very keen on us letting everyone know that this year WHO Health Assembly awarded the General's Health Leaders Award for Outstanding Leadership in Global Health to Her Royal Highness Princess Muna Al Hussein of Jordan for her dedication and service to health and humanity and her tireless support over 6 decades for nurses and midwives. We also have with us Ms. Afra Musa Saleh Ali, the Assistant Director of Nursing at Primary Healthcare Corporation, PHCC. Feel free throughout the panel to send us your questions and to whom you would like to address it. We will try to make this conversation as interactive as possible. Each member will answer my first round of questions in 3 minutes. Then we will move to your Q&As, so make sure you send us your question as soon as it comes to your mind so we could have the time to queue it in and address it to the proper panelists. We will start with you, Dr. Sana Al-Harahshi from WISH, Research and Policy Associate of Research and Policy at WISH. Can you begin the session by giving us a brief overview of the report?
Okay. At the beginning, I would like to thank all the contributors to this report, starting with Professor Deborah White and Afra from PHCC, Mariam Al-Mutawwa, the Executive Director of Al-Rumaila Hospital, Dina Norman, the Executive Director of Nursing at CIDRA. This policy briefings provide an overview of the progress in nursing and midwifery with a main workforce development with a main focus on Qatar perspective. It highlights the current evidence about nursing and midwifery contribution to health and population well-being. Nurses and midwives are at the heart of the healthcare system. They play an essential role in prevention, promoting health literacy, emergency response, and patient safety. As now the world fights the COVID-19, their contribution is immeasurable and countless. It highlights also the global and national key issues and achievements. At the global level, it highlights the contribution, it highlights the achievements in the several areas in policy, education, training, leadership, and capacity building, the job development. At the national level, it highlights also several achievements in leadership and management, partnership, education and training, and initiative undertaken. Qatar has made a lot of efforts in this area, and regardless with all the significant contribution, there are several challenges and gaps that must be highlighted, such as the absence of a fulsome workforce model and the lack of uniformed coordinator national strategic plan for entry to practice, education, and leadership capacity building. There is also a lack of uniformed and coordination between intersectoral cooperation for retention and recruitment. There are also challenges in regulation and organization issues and marketing to raise the profile of nursing. To build a strong and sustainable health workforce, there is a need of sufficient, high-skilled and empowered and motivated health workforce, including nurses and midwives. To build this strong workforce development, we need to work on the following area. To create a long-term workforce modeling plan to inform health and the population service needs, to raise the status and the profile of nursing in order to enable them and their contribution and empower them to contribute greatly to health and meet the health needs of the population. Also, there is a need, there is a lack on coordinated intersectoral recruitment and retention. So those are the challenges, and in order to make up those and address those challenges, there is a need of action in the following areas. Create a long-term healthcare workforce model to inform population health, strengthen and increase investment in nurses and midwives, education, training, and leadership capacity building, enact and ensure that there are effective legislation, regulation, education, and employment arrangement in place to advance nursing practice, improve and promote and raise the status of the midwives and nurses.
Thank you, Dr. Al-Harahsha. We will get back to you. Professor Ruwaida Al-Maaita at the Faculty of Nursing at Jordan University of Science and Technology. What can we do better to maximize investment in strengthening nursing leadership and influencing health policy?
Thank you so much. Actually, I changed all my speech for today or my intervention. But, you know, I would like to relate for the different call for action that we have from WHO, we have also from the State of the World Nursing Report, we have from the Global Strategy on Human Resources for Health, we have from the Strategic Directions for Nursing and Midwifery, from the ICN, from the ICM, as well as, you know, the WISH report, the new WISH report. They are all actually reaffirm the need for more investment in the education jobs as well as leadership for nurses and midwives. Of course, we have to prepare, you know, better nurses, better nurse leaders for the future. I don't want to talk about, you know, the COVID-19 because I said that I'm going maybe to say other things than what I prepared before. But I would like to relate also to the State of the World Nursing Report. This is very influential and evidence-based reports. This is a very strong tool that we can use. One thing that I would like to say that the report concluded that we need around 6 million new nursing jobs are needed by 2030 to address the global shortage. A simple calculation for that shows that we need to prepare more than 600,000 nurses per year. And if we, I don't think that we can start from next year. Anyhow, this is very strong evidence, the strongest actually. But during the Triad meeting last June, Professor Jim Bochan, who is a friend of Jim, warned us that the evidence alone does not change the world. So it will not change nursing, the evidence alone. He said, and I quote, "It is getting the evidence into policy dialogue and bringing power and knowledge to the political interface that is most important." So if we keep talking, we have numbers, we have data, if we don't use them in a very intelligent and smart way, we will not do anything. We will keep doing the same. Of course, this means that we need to invest more and to change the way we play it, you know, around. So what we should do, actually, we need to be more articulate in shaping and influencing and powerful profession, nursing profession, which entail profound changes and transformation of our education, practice, management, research, collaboration, and strategic partnerships, as well as leadership. Of course, you know, we need to sit more and not to discuss, but also to argue. We have many questions that we need to answer also in a different approach, a new approach. We have to answer what kind of nurses we need for the future. Of course, you know, in light of what we have, you know, now, in light of all challenges, in light of, you know, of the many nurses that we lose, of course, and other healthcare providers with this pandemic. And what are our plans to produce nurse leaders? What kind of leaders we're talking about? What we will do differently to prepare a critical mass of nurse leaders? For me, actually, of course, we need to cultivate more nursing leaders from the bedside to the boardroom and throughout the education system as well. So we need to look at the leadership issue from 5 or 6 eyes. The first eye is on the education system. need nursing students who are on the seats for obtaining their nursing degrees. Must be prepared as leaders, policymakers, and health providers of the future to influence the making and the shaping of the healthcare sector. The same we have to do and to prepare our faculty members. The second I actually will be on the nursing profession itself and also on the power structure of health and non-health sector. We need actually, for efficiency and proper gains, we need a larger pool of nurses and midwives who are policy competent with the skills that enable them to access the power structure inside and outside the health system. We need more nurses to advance their skills from policy development to policy influence, from organizational policymaker to state legislators, from nursing to health and non-health leadership positions at all levels where critical decisions affecting patients and health security are made. The fourth I actually, we need to look at the legislation, we need to look at the rules and regulations we have, and we have to update them accordingly. The fifth I is on politics also. We as nurses need to remember that the more complex the challenges and of what we have now, we learn, the more verification that health is very political. This is very true because the simplest term of politics refers to the exercise of influence. If we want to be influential, we have to know how they play politics. More also, the fifth I is in both policy and politics together. Understanding the interplay of policy and politics in health system, we need to understand it really very well because it is very crucial for nurses and nurse leaders in order to drive policy dialogue process and play an integral role in leading change and influencing health policy to achieve sustainable development goals as well as universal health coverage and economic growth. And also we need the seventh I actually, we need, this is the eye of the world on us, how we're going to respond to the all call of actions that we have from the different institutions, starting from up WHO, ICN, then down to the national level. This is very important. Today, we need to renew our commitment to continue emphasizing on the importance of creating critical mass of influential leaders. Can we do it? Yes, we can, because nursing expertise is a valued currency. With your collective and our collective voice and our partnership with WHO and others and the coordination, as well as with collective voice and power, you will definitely succeed in influencing policy to strengthen our nursing profession. We all now know that governments cannot achieve healthy nations without universal access to healthcare. This is the best and right time to make governments commit to actions and make proper investment in nursing, in influential leadership for nursing. Alone, we can do it fast. Together, we go far. Thank you.
If I were a nurse, I would vote for you and I will follow you blindly, I swear. Professor Debbie White, Dean and Professor at Calgary University here in Qatar. Following up on what Professor Maita said, there are major gaps sometimes in education program for aspiring nurses. Where are those gaps and how a university like yours works on filling them?
I think some very good points were made. I think when we talk about gaps, we have to talk about two things. Gaps in how the structure is in programs, whether it be in design and also in content. And the reason I say that is that we have, and we've had great success, I think, globally, but I still need that concerted effort around competency-based curriculums. So our curriculum is both competency-based and content and concept-based. That's absolutely critical. Another thing in terms of the particular structures is you really need that collaboration that was talked about earlier, where you have innovative clinical settings, innovative technologies where appropriate, and use those appropriately. So that isn't always in place. And so that collaborative piece is absolutely critical. I think in terms of content, we really have moved pedagogically from a place of a medical model that is medicine, surgery, such. We really have to understand all those competencies from a technical and content knowledge. But really what I'm seeing in curriculum, and certainly the report, the evidence in this report and many WHO reports, it is a call to look at things like global health, population health, the burden of chronic disease. And when you look at leaders, leaders have to have that knowledge because clinical leaders have to understand that. Leaders in policy have to understand that. When you talked earlier in terms of looking at leadership, that is something that we really, really closely look at. Students, and I would say students I've taught in the US in some courses, I've taught here, and I've taught in Canada, and they tend to think that leadership is administrative. It's not. Leadership is clinical leadership, but you have to know how to use the data. And I think we are moving better. I think this has been a gap in terms of how do we use data in policy and to make those arguments. Whether you're on the unit, you want a clinical improvement, you have to have data. How's that data aligned with the goals and the strategic planning? So in our programs, even in the undergraduate, we look at leadership on many levels as teams, collaborative teams, how to manage conflict, how to present a data, a policy brief. Because it's small P's, big P's. It's small, looking at leaders at the clinical level that can actually work their way through the system. So those are huge things that I think that they need to know from a leadership perspective. The other thing that I think is absolutely critical, and I don't think there's been enough attention in many curriculums, is around health literacy and health information. And so we have, at the University of Calgary and Qatar, we have actually pulled that through in our curriculum across all 4 years of our undergraduate program. And so they look at the influence of that on health and well-being. And what they learn simultaneously is how to message at different levels. And I think that's absolutely critical for clinical leaders working with patients, working in the community, working at a policy level, working with CNOs. So that is absolutely critical. And I think that has been missing in curriculum, but absolutely important in terms of that. I think in order to make really cogent arguments, that ability to use data and data science. And I think that although that has always been at a master's level, we are gradually bringing that back in terms of digital technologies and how do we use evidence in our information systems to actually look at evidence and build new research. So I think that that has been really an important piece that we have to do. The other is how we use technology safely. And so we have integrated that into our curriculum, and how do we use best practices. So an example that I could use in our curriculum, and certainly is being used worldwide, is some of the best practice spotlight organizations that use guidelines for nurses. So in our curriculum, the students will learn, and they are integrated into our curriculum so that they can then take that evidence that typically is built on systematic reviews and then take it to practice. And so in our curriculum right now, and in fact tonight, our students are doing a presentation on best evidence here in Qatar. And we are one of the only best practice spotlight organizations in the Middle East. And so students are on the forefront in international conferences presenting this sort of thing. So the leadership that was spoken to earlier is absolutely critical, and I think we have to look at the application of that. We tended to focus a lot in an undergrad at a theoretical level. Learn the content, learn about the different types of leadership. It's more than that, it's practice it, right? Look at how you can take evidence, how you build policy, how you're at the forefront of doing those sorts of things. So that has been, I think, really huge and an important piece to consider in terms of some of the big gaps that we've experienced. As mentioned earlier, I think as far as the gaps and filling those educational gaps, making sure we have flexible programming is really critical so that we can move where the health trends are, so that courses can be moved in and out. This is a huge thing that has to be considered, and COVID has done that for us, quite frankly, with online learning. The innovation that's going on in education is remarkable. Our students are loving it. Regulatory agencies have to think about that because online has not always been perceived as being positive. That provides more flexibility for people to come into programs. So that's absolutely critical. And so that is going to take a lot of collaboration. It's going to require people at every level to get together to think of national standards, national educational standards, and there's many examples around the world. And so that takes partnership with nursing, it also with our other partners, our allied health professionals, and policymakers, cross-sectorial collaboration. So that is something that we really have to look at a lot. It is being done and very well in some places. It's something we have to keep plugging away at, though. You know, one of the questions in terms of nursing education and midwifery, we don't have a midwifery program, okay? But I did want to note, and it's the WHO in terms of what they've done, and the publication, the Framework for Action for Strengthening Midwifery Education towards Universal Care. It's an excellent piece of information if people are trying to establish a nursing workforce, that is nurse midwifery. And here in Qatar, Hamad and also Sidra are looking at these documents along with the International Confederation of Midwives to build a solid, competency-based, flexible learning for midwives. I mean, that's absolutely critical. We only have to look to a few documents to see the impact that they have in terms of changing lives of patients and families. And I would say the same for nurses. If we build the education that is based on population health, global health issues, build them in terms of leadership, policy making, so that they can stand in the room and actually articulate well in a very short period of time and look at the different evidence, then I think we will build a very, very strong workforce right at the forefront, you know, at the clinical level, right straight through. And I would say the other thing that really needs to have serious consideration, and it's in the World Health, the World Nursing Report and World Health documents, organizational documents, is thinking about a chief nursing officer within the Ministry of Public Health that can oversee these national education standards, regulatory practices. I think that's absolutely critical. And it's a good place to go. It's an opportunity for young nursing leaders to aspire to another role.
Thank you, Professor White. Now to Mr. Jim Campbell, Director of Health Workforce at WHO. The COVID-19 pandemic has brought to light the critical role that nurses and midwives play in delivering care. Might you be able to provide an international overview of the workforce issues arising from managing the pandemic, maintaining essential health services, because women are still giving birth before and after pandemic, chronic disease patients are still requiring health before and after. And what about the preparation for a vaccine?
Thanks, Roa. Indeed, you know, essential healthcare services do continue. Just to acknowledge thanks to the colleagues who've just spoken in this year of the nurse midwife. Quite critical to recognize the role that we need to deliberate on policy, on evidence and action. Really encouraged to that WISH and our colleagues in Qatar are putting this agenda on the program, but putting the agenda on the dialogue for local government decisions. It's what really is necessary. We can bring evidence together at the global level, but it needs action at the national level to carry that further forward. Indeed, we've seen around the world the impact of COVID-19 on our health and care workers. And the evidence that we have clearly is, you know, 59% of the workforce around the world are in the nurses, and a greater percentage if we count all our midwife professional colleagues around the world as well. So 3 out of 5 of the workforce, nurses and midwives. They are indeed, as you rightly say, at the forefront of the COVID-19 response. We've been looking at all the available data from the member states reporting, from the published literature, from the news, from the media, from the journals, and we're seeing a whole series of issues that have really that we need to bring to attention. Firstly, in many countries around the world, as Roeda mentioned in her remarks, there is an existing shortage in the workforce. We don't necessarily have the workforce responsive to population needs. And on top of that, we've then had to deal with the pandemic. In the early days of the pandemic, worrying data from around the world in the number of infections amongst health and care workers, and tragically, the number of deaths. And it's any death from infection prevention control is avoidable, but the numbers that we're seeing are really, really very, very concerning. The data suggests that we're getting better the further into the pandemic we go. The first 3 months were quite a challenge for everybody. In the second quarter, better protection, better risk assessment, infections coming down, but still work to be done, and investment in the personal protective equipment is essential everywhere. The rights of health workers, the environment that they work, to be taken further forward. In addition to that, we have the burden of overwork, the stress, the anxiety, the fear that comes into the workplace. Just being part and a witness to the volume of infections, the volume of mortality, has an impact on our nurses and midwives around the world as well. And so they're dealing with stress, anxiety, and additional burden. And we know that there's going to be a major increase in the mental health burden amongst populations in the next 12 to 18 months. So yet more work is coming for that. We've identified in 30 countries, at least 30 countries, health workers have been on strike. They are, through their associations, nurses and midwives, through their professional associations, their unions, actually suggesting, that these conditions that we're faced with are untenable. Applause, as you rightly acknowledged, Roa, in your opening comments, applause is wonderful, but we need also to take action. So all of these factors are meaning that our workload, of our capacity of our professional teams of healthcare workers, nurses and midwives at the forefront, is under increasing pressure. And then we're hearing excellent news and evidence around the potential of new vaccine candidates being available at the end of this year or early part of next year. And that's absolutely wonderful. The investment into R&D, the speed, the pace at which that's done whilst maintaining quality is encouraging. But let's stop and reflect what that means. 2 billion doses will need to be delivered next year. That's the ambition. If you look at that, the majority of those 2 billion doses, 75%, are in low and middle income countries if we get equitable allocation. And that's huge work ongoing to deliver equitable allocation. And these are the same countries that Roeda was telling us earlier have already got a shortage of nurses, a shortage of healthcare workers, yet we're expecting them to do a global program of vaccine delivery and immunization in addition to all their other work. So real challenges coming through as we look at this. And then I want to touch on a point that Debbie made as well, if I may, around education. We are seeing with technology the utilization of technical tools, of this interaction, this virtual interaction. But we're also seeing huge challenge to the delivery of clinical practice, the disruption to clinical practice. And so, we potentially are very concerned about losing a year's cohort of education or a year's input into our cohorts. And what is the impact of that? As Roeda said, we need to recruit 600,000 and graduate 600,000 nurses a year to have an impact. And if our education is disrupted, what are the kind of things? So some real challenges that the world has to face, and therefore really encourage that Qatar is looking at their own domestic issues, the rest of the region also, and around the world. Let's turn evidence into action. Thank you.
Thank you, Jim Campbell. Ms. Afra Musa Saleh Ali, Assistant Director of Nursing at PHCC. From a primary care provider's perspective, how has the nursing workforce in Doha coped with the additional pressures of providing care within the pandemic? Ms. Afra, you need to unmute your teams.
It's a pleasure to be in this summit. Yeah, can you hear me?
Yes,
can you
we
hear
can hear
me?
you well.
Yeah.
Yes, we can hear you
It's
well.
a pleasure to be, to be with you during this summit. It is an exceptional circumstances that all the health sector raise high and above any perceivable expectation globally. So the experience here in Qatar to cope with the additional pressure of providing healthcare within this pandemic, it would be similar to how others cope globally. But first, let me acknowledge that the response to the coronavirus presented a real challenge for everyone, not just the medical staff, but also for all non-medical supporting staff. However, I believe that we here in Qatar, we managed it and we planned for it very well. We learned also from it. It was a process of planning, implementing, learning and improvement. So it was like a portfolio management. It was at a national level where it involved everybody, all health sectors, to work collaboratively to evaluate the available resources and reallocated according to the priority and the management. So throughout all this challenge, our nurses played a critical and important role. So since day one, nurses have continued to perform critical duties, including assessment, triaging, swabbing. They have also supporting the quarantine duties at our ports, the airports, and quarantine facilities, homes. There was also a reallocation of nurses according to their priority to support the country in this pandemic. So as I said, nurses played a vital role also. In addition to that, they played also a vital role in supporting the patient, educating them and their families, and providing evidence-based compassionate care. So all personal efforts and medical supplies shifted here to support the emergency. And there was some change in the work practice. And we put a preventative measure in place to decrease the level of transmission of this coronavirus. And to ensure also the safety of our nurses and also our patients, some of the non-urgent services, we put it on hold. And to support also the stay-at-home guideline, the Ministry of Public Health created a hotline for all to call for instant triaging and to obtain any critical information. So this service was available 24/7 for everybody, and the nurses were the backbone for this service, along with physicians, dentists, and other healthcare workers. So nurses have quickly adapted to these pandemic changes and have done an excellent job in many high-pressure situations where normal healthcare is required together with the pandemic response. At the same time, nurses have faced many challenges, and we have to acknowledge that. So many have been torn by their responsibilities to their patient and employer and the financial need to work, yet have very real worries about also burnout and becoming infected and in turn infecting their families. So consequently, at the beginning of the pandemic, we were supporting the nurses by providing the necessary training, and also we try to provide or support them with adequate personal protective equipment and to reduce their exposure to coronavirus through their work. Also, at a primary level, we provided a mental health support for all healthcare workers, including nurses, our nurses and midwives. And also at the national level, there was a hotline was available also to support nurses and other healthcare workers to avoid them from being, or if they felt any stress or unease or depressed. There are many other things, but this is some of the area that or some of the measures being taken to overcome this pressure or to cope with this pandemic.
Thank you, Ms. Sorry, I thought you finished.
That's it.
We will get back to you with more questions because we're running out of time. Afrah, okay, I'm very sorry. We're running out of time, so we'll pass immediately to the Q&As with Dr. Sana. You have a question. Over the last few years, Qatar has made large strides towards developing a world-class health and educational system, yet realizing the goals of a world-class healthcare system is not achievable without the appropriately skilled healthcare workers. Can you highlight some of the achievements that have been taking place in Qatar in the area of nursing and midwifery workforce in Qatar and what it needs to be done further? Dr. Sana, you need to unmute your teams.
Over the last few years, there are tremendous work have been taken place in Qatar in the area of nursing and midwifery, especially in the leadership and management, to develop good and highly skilled nurses to meet the need of the population. Qatar has invested greatly in developing the nursing and midwifery through providing program such as the Leadership Change Program in collaboration with the WHO and other local and international stakeholders to build leadership capacity building. Also, in the area of teaching and education and training, University of Calgary provide formal education. They have a program undergraduate and master level. And besides that, education and training opportunity has been provided also by CPD, and the Qatar Council of Health Practitioners has accredited several programs in this area. In terms of partnership, there are several partnerships have been achieved here in Qatar at the local level and the global level. For example, at WISH we have partnership with HMC and other stakeholders. In 2018, for example, in collaboration with HMC, we launched the Nursing Now Qatar, and it was the first in the region, along with the international campaign, in order to maximize the contribution of nurses and midwifery. Also, we partnership with HMC and other stakeholders to provide leadership courses for Qatari and international nurses. Also, we have a partnership here in Qatar with international universities and to accredit some program for nurses and midwifery. But regardless, and we have undertaken here in Qatar several initiatives and strategic plans, such as the HMC Nursing and Midwifery Strategic Plan and PHCC, CIDRA, and even the private sector, University of Calgary. But regardless of all this progress and development, there are several challenges which, as I highlighted at the beginning of this session. What we need to do, what Qatar needs to build a strong and sustainable healthcare workforce to meet the growing needs and the changing needs of the population. There is needs an action in several areas, such as creating a long healthcare workforce planning model to inform health and the population and the service need. We need, there is a need to strengthen and increase investment in nursing and nurses and midwives education, leadership capacity building, training. There is a need to ensure that there are effective legislation and regulation, education and employment arrangement are in place to advance nursing practice. There is a need for raising the profile and to promote and improve the status of the nursing and midwifery in order to enable them and enhance their contribution. They are under-recognized, even they call them the invisible group. The year 2020, the International Year for Nurses, brought the attention and the recognition of nurses, especially with the current pandemic.
But we need to take it more into action. I'm sorry to interrupt you, Dr. Harahshe, but we're running out of time, and I have so many questions to Mr. Campbell about the shortage of workforce. I will try to combine them together. There's a question about the imbalance, actually. There's quite an imbalance in nursing workforce. You have some countries who have more nurses per 1,000 person. You have others who have less. And then you have countries relying on expat nurses to recruit them as a workforce. How did the pandemic affect recruiting them? And how can we create a more a balance globally in the nursing workforce?
Thanks, Saroa. It's quite a few complicated questions within that. Let me just quickly say, what have we seen as a result? Clearly, around the world, you're right, differences in the density and the distribution of our nursing and midwifery workforce, some with undersupply, and some with oversupply. We've been calling for many years now about the need to invest in education and employment. The title of this year's State of the World's Nursing Report very much driving that investment in education, employment, and jobs leadership analogy. We've seen around the world those countries which are dependent upon a greater number of migrant health professionals have had to make rapid changes to their procedures. We've seen countries that have been, as the demand has gone up in the COVID pandemic, actively recruiting from other jurisdictions. We've seen the Philippines, which for many, many years has been a supplier to the world of the nursing workforce, actually introduce restrictions on Philippine nurses leaving the Philippines. They had a demand locally themselves, nationally themselves. They put restrictions into place for migration. So we know that if you don't invest in education and employment, if you don't work towards your own sustainable workforce, you are going to be faced with long-term challenges that when your system is under stress, you have limited ability to cope. And this is why I'm really encouraged when we see what Qatar is doing, when we see what other countries are doing to invest in domestic education and employment and a sustainable workforce. Over.
And let's hope that from the other side, with the recognition nurses had this year, that many young people will think that it's better to become a nurse than just invest in being a YouTuber. Thank you very much, all my distinguished guests, and I'm very sorry we didn't have the time to go through all the Q&As. Thank you, Professor Maaita. Thank you, Professor Harahshe. Thank you, Afrah, and thank you, Mr. Campbell and Ms. White here with me. See you tomorrow for another panel.
Welcome back, everyone. Here at Virtual Wish 2020, you're about to hear next from someone well known for her acting, but also for her activism and philanthropy. Back in 2006, she co-founded Eva's Heroes, a charity that supports and acts as an advocate for children with developmental needs. In 2012, she set up a foundation to empower Latina women through a focus on education and entrepreneurship. She's spoken out on self-harm and on anxiety and depression. And this year, she's highlighted how the pandemic has affected women and minority communities, often in frontline jobs and with multiple responsibilities and challenges at home as well as at work. She is Eva Longoria.
Hi, I'm Eva Longoria Baston, and I'm honored to be joining you at WISH this year. Even though the format looks a little different than years past, its mission is to create a healthier world through global collaboration. And this has never been more important than it is today. We all know the spread of COVID-19 has been rapid, and it has sent the world into shock. The virus has left people to die, families to mourn, and it's turned the most basic social interactions into political statements. This invisible threat has left visible scars on our societies. I don't have to tell you all, medical experts, policymakers, frontline healthcare workers, that this pandemic has not affected all communities equally. Around the world, low-income people, people without health care, people lacking access to clean water and sanitation, they've all been disproportionately affected by COVID-19. Here in the United States, Latinos and Black Americans are 3 times as likely to become infected with coronavirus as their white neighbors, regardless of state, region, or whether a person lives in a city or suburb or rural area. Doesn't matter. The Latinx community, which is my community, has been particularly hit hard. We're much more likely to be infected or to know someone who has COVID, in part because Latinos represent 35% of essential workers in the United States, even though we're just 18% of the population. So the Latino community is keeping the economic engine of this world going. We go to work every day to keep our country running, putting us at greater risk. For those who are infected, Latinos are hospitalized at almost 5 times the rate of white people, and we're an outsized number of deaths from COVID. We're losing people in their 40s, 50s, and 60s at alarming rates, and we're leaving children without parents or abuelos, grandparents, that they love and rely on in our close-knit families. What's more is our rates of infection and outcomes may be seriously underestimated due to undercounting. Critically inaccurate data, whether from lack of access to healthcare or testing, government undercounting, lack of options for the Latinx folks to identify their race or ethnicity on official forms, all of this means that we don't know the full extent of the crisis in our community. So we need accurate data to get the resources that our community desperately needs, like testing and contact tracing and medical treatment. We also need to recognize that while COVID is our most pressing emergency, it didn't create these disparities. The pandemic has been able to capitalize on a long-standing inequality for Latinos in the United States and marginalized people all over the world. It's brought to light the discrepancies between how communities are given timely medical information, engaged in response efforts, how they receive treatment and care, and how they're provided social support services. So by exposing these problems, we're offered the opportunity to address them. Something almost unprecedented is happening right now. We're uniting the world's best and brightest across many fields for a common cause. And we're not limited to only addressing COVID. We can bring our diverse perspectives and creative solutions to this immediate issue and the long-term conditions that make acute events like COVID so hard on marginalized people. Because the pandemic hasn't created just a medical crisis, but also an economic crisis, an educational crisis for many, many families. Monthly bills are going unpaid, businesses are failing, parents are worried that their children are falling behind at school. You know, joining an online lesson isn't easy if you can't access the internet from home, or if you don't have a computer or an iPad or an iPhone. So at a time filled with uncertainty, our children are absorbing the anxieties of the grown-ups who surround them. They can feel our energy, and their window on the world can often be the very same device where cyberbullies lurk and insecurities are amplified. So over time, and if we trust in science, the terrible physical impact of COVID-19, that will wane. But its impact on our mental health and on the mental health of our children, that might linger. So even before the pandemic, 1 in 4 of us was destined to be affected by a mental disorder at some point in our lives. Mental health support must be made a priority. And in good times, education and entrepreneurship, they offer transformational paths and economic mobility, mostly to women of color. But failing to address these concerns now puts us at a risk of losing ground on global education and anti-poverty efforts. So I want to return to my point that every one of us, even those of us without medical degrees, has our part to play in responding to COVID. My part, in 2012, I started the Eva Longoria Foundation to help Latinas build better lives for themselves and their families through educational programs and entrepreneurship. And in the last 8 years, we've helped more than 29,000 Latina women and girls in the United States and Mexico through many programs in STEM education, parental engagement, mentorship, college scholarships, microloans, business training. We've done it all. And COVID has posed, increased intersectional challenges for Latina women and girls. Our team at the Eva Longoria Foundation, we've really pivoted our programs to serve Latinas with the tailored assistance that they need. You know, as school moved online, we set up mobile hotspots. We got laptops for students who needed them. We ensured teens could still meet with their mentors virtually, especially as they felt isolated and anxious about the pandemic and about their family's health and economic security. We hosted free digital events with culturally competent therapists to help young women process and cope their emotions that COVID has caused for them. We've also continued to support our first-generation college students through scholarships that allow them to just focus on their studies. We've also launched free virtual programs to help Latina entrepreneurs pivot their businesses and succeed in e-commerce during this time. And while we're proud of all the work we've done, it's still going to take all of us working together and centering women, centering girls of color to address systemic inequalities that have been exacerbated by COVID. We have to meet the holistic needs of our global family because we live in a global community, and we have to emerge from this pandemic stronger. You know, in the United States, we've just come off an election, a very exhaustive, big election in which a historic number of people voted. And they voted for their vision of a post-pandemic world led by people of color, people across geographies and religion and races and ethnic backgrounds. They voted for kindness, for science, for cooperation. We came together across a huge diversity of experiences to do something bigger than any of us could do alone. So I encourage you to do the same. During the summit, to go beyond your area of expertise. Attend a session outside your specialty. Learn from a speaker you find inspiring on a brand new topic. Connect with an expert from another field. That kind of cross-discipline, creative collaboration and willingness to learn represents our best chance to address COVID, systemic inequalities, and other pressing global issues like climate change. You know, there's a saying in Spanish, lo importante en una familia no es estar juntos, sino estar unidos. The important thing in a family is not being together, but being united. So though we can't be together in person, the most important thing for this global community is to remain united. And our commitment to fighting COVID, and our commitment to standing up for those who struggle to get their voices heard, and our commitment to tackling the greatest challenges our world faces today. There's so many things that we can do together, but we can't do it by ourselves. Thank you so much for your time, and everyone be well.
A special thank you to Eva Longoria for that keynote address. The discussions here now continue with a panel discussion on cybersecurity and healthcare systems. And don't forget to check out the various interactive spaces around the Summit platform. Thank you. Governments and companies everywhere should be accustomed by now to the risk and the reality of cyber attacks. But often healthcare systems and organizations are lagging behind other sectors in cyber preparedness. It's a topic that a WISH report and our next forum panel discussion have been exploring, looking at the digital solutions which can revolutionize healthcare and mitigate cyber threats.
Hello, everyone. I'm Foli Batibo in Doha. It's my pleasure to be moderating this panel on cybersecurity and healthcare systems on behalf of the World Innovation Summit for Health 2020. Welcome to you all. Thank you to the WISH 2020 team, the Qatar Foundation, and all its partners for bringing us together for this unique virtual experience. Now, like all aspects of our lives, digital technology has brought extraordinary changes to the global healthcare system over the past 10 years. It has single-handedly transformed the way we treat, manage, deliver, and provide patient care to millions of people. And crucially, it's increased access to people who desperately need it. But the fast-paced changes, adoption of new digital technologies and tools have brought with them unprecedented threats through online attacks. Cybersecurity has become an urgent priority for healthcare providers around the world, with the goal of building strong defense systems that can act against cyber attacks. The effects of cyber attacks are many, but they can, of course, erode patient trust and even put their safety at risk, as well as their private data. Now, the number of cyber attacks on the healthcare systems around the world have significantly increased in the past 5 years. And it's become worse since the outbreak of the COVID-19 pandemic. Cyber criminals have exploited the widespread fear and confusion caused by the pandemic. We've seen a new wave of cyber attacks against healthcare agencies, including the World Health Organization, where earlier this year, scammers impersonating WHO in emails were targeting the general public in order to solicit donations to a fictitious fund. Others have also been targeted, including the UK's NHS, through the so-called WannaCry cyber attack 3 years ago that completely blocked its system, preventing staff from accessing critical patient data. And similar attacks have also targeted healthcare providers in Singapore, South Africa, Australia, and the United States. So it's a worldwide phenomenon. Now, data breaches cost the healthcare industry billions of dollars every year. And these attacks pose more than just a threat to information security. They are, of course, a threat to patient care and can interrupt patient care. And yet, despite this increasing and critical threat, healthcare systems and organizations around the world still lag behind other sectors in developing their cyber readiness. So we have to ask ourselves, why has the healthcare industry become such a target for cyber attacks? And what can hospitals, other healthcare providers, and public health organizations do to protect their networks and their patients from this threat? These are some of the questions that we'll be addressing as we discuss safeguarding our healthcare system, a global framework for cybersecurity, a report written and published for WISH under the leadership of Dr. Saira Ghafoor, Nikki O'Brien, Guy Martin, Emilia Grass, and Mike Durkin. And we have the honor of having Dr. Saira Ghafoor on our panel today. And this report looked at existing cybersecurity frameworks around the world and provides us with a new set of guidelines for healthcare organizations to address these challenges and establish more robust systems. More on the report in just a moment, but first, we're also thrilled to have with us some of the most trusted experts on cybersecurity and healthcare who will be sharing their experiences and perspectives, as well as solutions on how to raise awareness and improve cybersecurity in this sector. So, ladies and gentlemen, please welcome our panelists today. Let me introduce them to you. We have Arvind Sivaramakrishnan, who's the Chief Information Officer at the Apollo Hospitals Group, which is based in India. Dr. Ahmad El-Margamid is the Executive Director of the Qatar Computing Research Institute. Welcome to you. Vartan Sarkisian is founder and CEO of Apomatics, a risk management software company. Also with us, Dr. Deep Chana, who's the co-director of the Institute for Security Science and Technology at Imperial College London. And as I mentioned, Dr. Saira Ghafoor, Digital Health Lead at the Institute of Global Health Innovation at Imperial College London. A warm welcome to all of you. I very much look forward to having this very important and interesting discussion with you. And I'm also happy to say that this session will be highly interactive. We very much look forward to including questions from all of you watching us online. So please do send them to us using the comment section on your screen, and we'll attempt to put as many as we can to our panelists with the hope, of course, of getting as many diverse views as possible. And by the end, we hope to provide you with concrete actions on how we can raise awareness and improve cybersecurity in healthcare. So to kick off our event, it's my pleasure to welcome our forum chair, Dr. Saira Ghafoor, who is going to give us an introduction of the subject and overview of the report put together for this session. Take a look.
Hello, my name is Dr. Saira Ghafoor. I am the lead for digital health at the Institute of Global Health Innovation at Imperial College, and I'm the lead for the Safeguarding Our Health Systems, a Global Framework for Cybersecurity report. So the past decade has seen a surge in the use of new digital technologies across all healthcare settings, which has led to significant improvements in access and care delivery. A key challenge, however, is to keep any health data safe and secure, and to ensure that the patients and public can trust healthcare organisations with highly confidential information. The number of cyber attacks on healthcare organisations has significantly increased in the past 5 years. In healthcare, these attacks pose more than just a threat to information security, they can jeopardise patient safety. Through the COVID pandemic, we have seen a new wave of cyber attacks against healthcare organisations, including the WHO and the CDC. Other major attacks have included the WannaCry ransomware attack on the National Health Service in the UK in 2017. This exposes stark vulnerabilities within healthcare systems and the potential impact on the safe delivery of healthcare. In this report, we look at existing cybersecurity frameworks worldwide, and we examine why, despite being one of the sectors most targeted by cyber attackers, that the healthcare sector remains one of the worst adopters of cybersecurity frameworks. This report identifies key insights in the international healthcare cybersecurity landscape and also proposes a global cybersecurity readiness framework for healthcare organisations. The challenges in cybersecurity planning across high, middle and low-income health systems are varied. There has been a lack of investment and support to raise awareness of its global importance, and urgent work is needed to help healthcare organisations develop a common language and scale up cybersecurity planning. In response to this, we have asked members of the leading health systems network, LHSN, an international group of health systems and providers hosted at Imperial College London, about their organisational efforts related to cybersecurity. An initial survey of LHSN member institutions explored the current global cybersecurity landscape. We then convened a group of key experts in the areas of IT, cybersecurity, health policy and health systems to provide input on the most relevant elements of a global framework for cyber readiness in healthcare. This resulted in the ECHO framework, Essentials of Cybersecurity in Healthcare Organisations. The ECHO framework outlines 6 primary dimensions to consider when scaling up cybersecurity in a healthcare organisation. This framework may act as a minimum standard or as an aspirational checklist, and this depends on an organisation's resources and its cyber maturity. Developing effective global guidance on cybersecurity is challenging, and we understand this. While the ECHO framework is a starting point, a number of additional steps are needed to be taken by all countries across the world to cement cybersecurity readiness for healthcare in the future. The building blocks to improve cybersecurity are outlined as a series of policy recommendations in this report. Cybersecurity needs to be included in the design and implementation of new technologies and systems. We need to promote a globally validated and unified cybersecurity framework. The readiness framework presented in this report has been designed to be used across all settings, including high, low and middle income countries. And this introduces a common language as a first step. The next step is to validate the framework, and this will require strong partnerships at a global level. We need to develop and introduce practical context-based cybersecurity policies that can be adopted by all countries. And we need to engage with multilateral donors on cybersecurity as a critical element of digital health and patient safety. And one of the most crucial elements is to promote awareness, education and training on cybersecurity for all healthcare workers. While there is much to do in this area, we hope that this report will start as a serving point for health systems to assess and ultimately improve cybersecurity. Improved awareness, governance and accountability in this area are essential to protect healthcare organisations from future attacks and ensure that we provide safe care for all patients. Thank you very much, and we look forward to having you join us in the discussion panel later.
very much. Thank you, Dr. Saira Ghafoor, for that informative and insightful look into your report. It certainly laid the foundation for our panel discussion. So let's get to that now. Let me just briefly reintroduce our panelists in case you're just joining us now. We have once again with us Arvind Sivaramakrishnan, who's the Chief Information Officer at Apollo Hospitals Enterprises. Dr. Ahmad El-Margamid is the Chief Executive Director of the Qatar Computing Research Institute. We have with us as well Vartan Sarkisian, founder and CEO of Appomatix. Dr. Deep Chana is co-director of the Institute of Security at Imperial College London also. And of course, Dr. Saira Ghafoor, whom you just saw a few moments ago there. Dr. Ghafoor is the Digital Health Lead at the Institute of Global Health Innovation at Imperial College London. Welcome to you all once again. And to all of you watching us online, a reminder that you can send your questions and comments on the comments section of your screen. We'll be more than happy to put them to our panelists later in the discussion. So let me start with you, Dr. Al-Margamid, here in Doha. I know that you've previously said that there is no silver bullet solutions to the growing global cybersecurity challenges that we face today, and instead you're advocating for a better arsenal of tools, techniques, and countermeasures. Can you expand on that? What is that exactly? And in the current context that we're living in, cybersecurity in the healthcare system specifically? Turn your microphone on, Dr. Yes, there you go. There you go.
Good evening, everyone. Indeed, there isn't a silver bullet, whether it's to healthcare system security or any system security. Solutions that would work for large hospital settings would not work for enterprises of families of hospitals like we see now in Europe and in the US and so on, would not work for smaller clinics. So it's important that we look at the various topics. For example, we have to look at privacy, we have to look at medical devices, we have to look at financial types of attacks, such as ransomware, we have to look at enterprise security. We have to cover many aspects of topics and to defend against various types of attacks. If I may, Fali, let me just take a brief moment to tell you about the Qatar Computing Research Institute, which is a part of Hamad bin Khalifa University. To put a context, we work in 4 areas of computer science. We work in language technologies, we work in social computing, artificial intelligence, and cybersecurity. We have an interesting project that will be of interest to the audience and to the panelists, and that's SAHA. SAHA in Arabic is health. And in SAHA, we gather information from all types of devices, all types of things such as Fitbits or genetic data and so on, and we put it in a blender and we try to manage chronic diseases such as diabetes and so on. And it's a platform that we do jointly with Hamad Medical Corporation, with Sidra, with Cornell, with Weill Cornell Medical College here in Doha, and other participants. Last but not least, we also run the National Cybersecurity Research Lab for Qatar here in the Institute, and we run the Cyber Range. We work in terms of cybersecurity. We run abnormal user behavior, malicious emails. We worry about suspicious VPNs and dark web attacks and so on. The other point that I want to mention is the importance of partnerships in this. We value international partnerships. We have a long-running partnership with MIT CSAIL. We have a long-running partnership with Boeing, and also we have a partnership with the Washington Institute for Business, Government, and Society. I have the honor to serve there as a distinguished fellow and a member of the advisory council. The Institute serves as trusted advisor on important commissions in the US, such as the Cyberspace Solarium Commission, the National Security Commission on AI, and so on. Why these partnerships are important? Because it's important to be part of the global discussion on policy, on research, and on industry directions. So what I'm going to do today is I'm going to discuss, as the panel goes on, the 4 topics of privacy, medical devices, financial types of attacks like ransomware, and enterprise security in the context of cloud computing. Cloud made these things more prominent on IoT devices, bring your own devices, legacy systems, and so on and so forth. So in the ensuing discussions, I will take each one of those topics and I will detail them further.
Okay, we'd very much look forward to hearing that. And thank you for telling us about what you do at the Qatar Computing Research Institute and the importance of partnerships. But before we look at the solutions, let's go back to the origins, the root causes of the problem. And I want to bring in Arvind Sivaramakrishnan. Experts say, Arvind, that healthcare is 20 years behind banks when it comes to cybersecurity. Why is that? Why is it that many workers within the healthcare sector still don't recognize the connection between patient safety and cybersecurity?
It's the topic of healthcare, and traditionally we've always believed that it will not happen to me. So that goes with almost everything that we deal with in healthcare. That's why probably it's a little, not up to date as what we would call it. The second aspect is compared to the other industries, whether it's banking or automotive, healthcare is a little late to the game in terms of digital transformation. Not medical technology, but information technology that's powering medical technology and then powering health systems. So literally digital transformation that's enabling health systems. Compared to any other industry segments, it's late to the game. So this is probably why we are a little delayed. But having said we're a little delayed about it, it's a subject that covers everybody. Mm-hmm. It's a subject that deals with the entire organization. It's a subject that deals with me. It's a subject that deals with you because it's health that all of us are involved in. And like what Dr. Ahmed was mentioning and in Dr. Saira's note also, are financial implications to not just a person, but a society, an organization, literally an economy. So that's probably why it's getting more, though it started late, mm-hmm. It's catching up at a pace that is not really desirable. This attention is not the attention that we need, but that's what it's getting. Right. The other aspect is everybody is realizing the need for digital transformation in healthcare because we are a planet of more than 1 billion people and we don't have healthcare capabilities to serve such a large community. Our supply to demand is always going to be large and we're not going to make it up. But when you say we're not going to make it up, we're not giving up. Right. This is how do we get healthcare to everybody who needs it? That means technology. And that means that people can also, unfortunately, infringe on this technology to prevent certain things from happening. Why do they do that? I'm not going to go philosophical. Right. But
that's a whole other question there.
Absolutely.
Technology has to be made secure, of course. Fartan Sarkisian, I want to hear about your experiences, based on your work as CEO and founder of Appomattox. What are some of the key challenges that your clients come to you with? And what is, in your opinion, are the continuous challenges that healthcare organizations and providers need to be aware of, even once they have a robust cybersecurity system in place?
Thank you, Foley. So if we take the first part of your question, first of all, we see a cultural challenge. It's the strong posture and the culture of cybersecurity or risk management is pretty much being neglected. And there are reasons for that as well. It's not being, I very much agree with Mr. Arvind. There's a concept of it will not happen to me. We've seen this throughout many years. And So it's not being prioritized. So what really is needed in the healthcare industry is more of a leadership, cultural change, and an understanding to push that awareness through in order for them not to neglect it. So typically, especially when the times get tough, or there's COVID, or there are other priorities, cybersecurity, certain technologies might take the front, but majority, especially risk management or compliance needs and so on, will typically get shoved down to the bottom, third or fourth in the list of priorities. And I understand that. I run a business. I get you quickly have to do something to make sure it works. Don't worry about that. We'll deal with that later. The other challenge that we keep seeing is a lack of expertise. So Security Magazine in 2020 just recently stated that 76% of cybersecurity experts are stating that there's a shortage globally for the topic of cybersecurity. And ISC Squared in last year, 2019, talked about a 4 million person shortage in the industry as well. So this is also driving this incapability or unwillingness to actually get things done. The other issue, the challenge that we see is an execution challenge. So this is another interesting statistic. UK Breach Survey talked about how 85% of basically leadership and boards state that cybersecurity risk management is important, but when you actually look at what's actually been done, if you average everything out, only 35% is actually executed. So there's a gap there, perhaps stemming from the shortage of expertise. And also other interesting things. For example, antivirus, it's almost ubiquitous. Everybody in all organizations have that running. It's nice, it's simple, it's there. But when, as Dr. Ahmed was saying earlier, that there's no silver bullet. You can't just have an antivirus, you have a variety of different things. And that's where, again, sort of say, the ball is being dropped. Right. And lastly, when you're managing these kinds of situations, you need to manage a variety of different elements. There are lack of solutions when it comes to risk management, really planning this together, especially for what I call small or less mature organizations. There are very complex, big GRC, governance, risk, compliance tools and software that large, mature organizations can grab. But if you want something, if you're a small clinic, if you want to get going, get something started, you resolve to an Excel spreadsheet. And that naturally causes other issues. Because of Excel spreadsheets, then you're keeping a track, it's not real time. You have a variety of these kinds of issues that stem from that as well. Okay. So there are these multiple challenges that we continually see.
Well, let me bring in Dr. Saira Ghafoor on that. We heard there from the previous speaker about the challenges, including the cultural challenge. And you speak in the report, Dr. Saira Ghafoor, about the need for a commonality of language, particularly as cyber attacks become more complex with the potential to affect multiple national health systems simultaneously. Can you expand on that? How do we create a common language?
That's right. Thank you, Folly. So absolutely, we've seen that the number of cyber attacks is rising. And certainly from our survey that we did as part of the report, we saw that all of the respondents who took part in it saw that each of their organisations saw an increase in the number of cyber attacks that they've experienced in the past couple of years. And we know that cyber attacks are becoming more sophisticated, and we know that cyber hackers and attackers are now realising the potential of system-wide havoc they can essentially create. And because of that, there's a greater chance of large-scale cross-border cyber incidents. And we saw that in the WannaCry attack in 2017. The NHS in England was not the sole target, but certainly it was one of many targets across many different countries. And certainly healthcare is a critical part of any country's infrastructure. And if this is a cyber attack that's going across different countries, we need to be able to connect with other countries also being hit by that. And certainly if we've got that commonality of language, if we've got a framework such as the ECHO framework, which we've proposed in this report, and we understand all the different components that would be part of that in terms of what we need as a healthcare framework. This will make it much easier to communicate, but also in terms of assessing cyber maturity in organisations when you're implementing changes, and also very important in terms of stepwise change when you're implementing new technologies into any given system, and will also help providers of any technology, whether it is kind of hardware or software, and knowing what's used in healthcare, it will help to improve that given setting.
Right. Deep Chana, Dr. Deep Chana, the report, Dr. Saira Ghafoor's report talks about a lack of funding and the need for investment and support. And one of the previous speakers addressed this to raise awareness about the global importance of cybersecurity in healthcare. There's urgent work needed to scale up cybersecurity planning, but the investment is not there. How big of an issue is that in your view?
Well, I mean, I think it's a huge issue, really. It's very well having lots of plans and policies in place, which of course is a critical component, but you need to back that up with action. Whether you're an individual, whether you're an organization, or whether you're a government, when that action needs to occur, of course it needs investment. And I think when you have the global landscape, you see quite a variance, and it's highlighted in the report, quite a variance in the commitment to financing or funding and committing activity towards cybersecurity within different countries, within different types of organizations. And really the interesting thing with cybersecurity and this hyper-collected world that we live in is that it doesn't differentiate between those boundaries. And so you're quite often only as strong as the weakest point in that interconnected world. And so it really is something that requires a global effort. And, you know, I think one of the things I would like to highlight here is that, you know, repeatedly, one of the big things that we need to look at now is in the following from COVID-19 is really learning from the lessons that have already occurred. We've seen threats, as Saira pointed out, and they're highlighted in the report. We've had COVID-19, and one thing COVID-19 shows us is that any time that we're going to have a biological pandemic such as this, it's probably very likely that that event will trigger the risk of its digital or cybersecurity counterpart, which is a cybersecurity pandemic, and it's in fact what we've actually seen. The framework that I think has been developed here really is, you know, something which moves us towards this idea of open policies and standards, which I think somebody else talked about as well. We really need transparency in the development of these standards. That's one thing which I think is very important. And we then need, on top of that, a commitment to intergovernmental collaboration and inter-organizational collaboration to keep the standard alive, because the standard's never going to stay static.
To what extent is that intergovernmental collaboration that you talk about happening already or not happening?
Well, so I was going to come on to this. I think one of the big lessons from COVID-19 is that, in fact, we've seen a systemic failure in all of this. If I'm honest, I think what we've seen is quite a lot of isolationist activity, occasionally dressed up as a collaborative activity, and we have to address that head on. This has not been a model way to respond as a world to a global event. And it's something that we've got to get right, and we have to be very honest about that. Another aspect, which I think you could have seen very easily in what's happened over the last 9 to 10 months, is I've seen a sort of waxing commitment and waning commitment to protect and preserve the rights of the individual and the citizen when it comes to data. I know we have systems like GDPR in place already, but you can see that there are opportunistic moves around this data. One of the things you talked about earlier on is what are the barriers? Why have we not seen enough in cybersecurity for health? Right. One argument, I suppose, is yes, you know, there's a complicated system, and yes, there are latencies, and there is momentum in the system which makes it difficult to sway. That's very true. But the other way of looking at it too is that it's a gold mine. There is a huge amount of commercial interest and potential self-interest, etc., and protectionism that can circulate around the medical data. It is a potentially enormous market. And one of the risks, the key cyber risks I see when you look at the global perspective, is the possibility for cyber exploitation, what I call cyber exploitation, where some of the most disadvantaged in the world aren't given the protections on their data as we build a digital healthcare system. And they really are the most cyber vulnerable, if you like, as far as I'm concerned. So, I mean, I'll stop there, Folly. There's a few more points I'd like to make.
You've touched on a number of important issues, including the disparities between countries when it comes to cybersecurity. And I want to bring back Dr. El-Malghamid to talk about this. I mean, in the proposed global framework that's proposed in this report, do you think it's flexible enough to adapt to local needs and realities? You talked about the experience here in Qatar, but is this framework flexible enough to adapt to local needs and the realities while we're still maintaining a unified way forward?
Yes, so thank you. I want to come back also to one of these points. See, one of the biggest problems in healthcare and why security is even more complicated is because of the fact that the attack vectors are so huge. They're much larger, much bigger than any other industry. Especially after the introduction, just imagine how many devices are in healthcare systems, from defibrillators and MRI machines and so on and so forth. Each one of these devices, and there are thousands of these, are internet connected, or at least they're connected somehow. And all of these, while they serve a big purpose, they also could be used as a way to attack the system. Also, one thing in healthcare, and it's also available in other industries, but in healthcare, legacy systems, and the CIOs here will resonate very well with this. Healthcare has a huge number of legacy systems. By legacy systems, these are old systems that have not been converted. And the problem is, we come back to the investments that you've mentioned and the others have mentioned. Because of the huge cost that it would take to convert and to bring these legacy systems up to snuff, they typically are left alone and bashed. I've dealt with these in the telecom industry years ago when I was at Belcor and Telcordia and so on, that you just typically you know that the system works, but you don't know exactly why it works, but you leave it alone because you can't fiddle with it. If you fiddle with it, you would break it. The last point that you asked me to address.
Yeah.
See, the thing is, privacy is of the utmost importance here, right? So privacy is very important. And why is privacy very complicated in healthcare, much more complicated than other industries? Well, because you have many actors, right? The practitioners, you have the researchers, you have the consultants, you have the patients, you also have the patient's relatives that sometimes have access to the electronic medical records. You know, all of these things, and you're trying to balance access control to the data, to the information, with privacy regulations. These two things together, you're trying to basically manage data leakage, unauthorized access, abuse of authorization, which is very real threat. The last point I want to say is that the majority, at least maybe 60% or so of data leakage is caused by insider threat, whether it's malicious or whether it's unintentional. And we have to protect against that as well. It's something that couldn't be ignored. And my heart goes out to the CIOs of hospitals. It's a job that is so thankless, but he's laughing because he knows what it takes.
Right.
So privacy is very important, but the complexities are so difficult. Security is very important, but the complexities are very important in healthcare.
So I guess we should go back to a basic question of how this happens. How do hackers gain access to healthcare data and networks? For example, in the case of the DCH health system in the US, hackers were actually able to seize patient files and lock them until they were paid money to release these files. Vartan, is this type of attack becoming more common today? Are they becoming more sophisticated?
So not only attacks, I would say, can become and are becoming more sophisticated, the frequency is increasing, the capability of launching attacks are becoming less complex, so less sophisticated individuals can initiate an attack. But I would agree with Dr. Ahmed that we have a saying in the cybersecurity world and the risk management world that cybersecurity is not a technical problem, it's a people problem. And it's very much the case here. So to answer your question, I would say the majority of these kinds of breaches are due to employee negligence or human error or insider threat. So it is very much a people's problem. So if you go back and look at cases, more often than not, that's the case. So malware infection is because somebody opened a phishing email and clicked on a link. A successful email compromise because maybe perhaps the two-factor authentication wasn't enabled, or it was a weak password, and so on and so forth. So yes, there are more sophisticated attacks, but still we are very much in that initial stage, especially in the healthcare industry, where this is why I like ECHO and what Dr. Saira has done, is because it sets out those kinds of essentials that need to be embedded in order for at least the basics to be taken care of. It's always about marginally reducing those risks step by step and step by step. So those still can be attacks, majority of attacks can still be mitigated by following certain frameworks like ECHO. Does that answer your question?
It does, it does. And I do want to get the perspective of Arvind in India. Do you also agree that this is a people's problem? Having worked extensively across India, one of the biggest healthcare markets in the world, can you give us your perspective on the development of cybersecurity in India, and in particular how cyber governance has developed in recent years, and how organizations are ensuring that they meet the legal requirements in India?
Talking about the legal requirements, India has the Information Technology Act. It's close to about 20 years old. It's, for the lack of a better word, a little liberal, and it needs to live up to its times. And so what the government is doing now is coming up with the Personal Data Protection Bill. It's still in the parliament. It's gone to the Joint Parliamentary Committee for review as it relates to infringement on other aspects. Or when it becomes law, you need to take care of it. But what the government is trying to bring in here is an inclusive policy. Is trying to do is bring something in where you have cybersecurity by design. And that's what what Vardhan was alluding to. Yes, it is a people problem. And here, when you start developing enterprise systems, particularly in healthcare, where you are designing for privacy and security as part of your inherent DNA of the building block, you start taking care of stuff. And then overlay that with I won't find it uncomfortable saying an excessive overdose of training, because you just need to make sure that whichever direction you go, you are aware of your responsibilities, not just as a stakeholder, but also as a consumer on what this does, because an expected lapse can lead to so many people being affected. So I think it's a combination of that in terms of being educated, making it the DNA of the system. So in India, we are seeing this catch up. Obviously, there's a lot to go before we hit maturity and say that, we are there. But I definitely believe that people are more aware because, the mobile revolution has definitely taken India by storm. It's done a lot of wonders in terms of the leaps in terms of digital enablement across the country. And organizations are taking it seriously. That means that almost we see all big health systems treat this as a board subject, treat this as a strategic subject. So that kind of lays stress in terms of how important, what's the importance people give. It's no longer an IT subject.
Right.
It's a subject that involves everybody.
Dr. Deepchana, Arvind says that people and organizations are taking this issue more seriously. So what then do you think is the next essential step in working with government and policymakers to embed the cybersecurity framework in practice?
Well, as I said to answer on your last question, really the lessons need to be learnt from previous incidents. Now we've got enough history to motivate action. I think that's the first thing. Absolutely, cybersecurity has to be inside boardrooms, and it needs to be inside government decision-making systems and processes too. that is something we've discussed for quite a long time, I think, and we've also talked a lot about in the cybersecurity community the idea of cyber by design. We have technical methodologies now, such as DevSecOps and things for developing safe tools. But what we really need is security by culture now, and I think this alludes to what Vartan was saying. And we need that cross-organizational understanding of cyber risk, and for people to be conversant in cyber risk and its potential ramifications right the way through the organization, whether you're government, whether you're industry, or whether you're academia. And I think that that's really the next step, is making sure that we've got the right competence right the way through our organizations, but also that we are seeding the right kind of talent pipeline and talent development for the next few years for this growth of what is going to continue to be a major issue. And I think you heard from some of the numbers a second ago, this isn't something that's going to sort of slowly fade away. It's going to become a more and more important problem. And we need to ensure that we invest in the talent to pull that through. And so that, the next generation of people in the workplace are going to be well equipped to understand cyber risk and have it, as I said, in their culture.
Dr. Saira Ghafoor, I mean, even if we're well equipped to understand cyber risk, and even if there's awareness across all levels and sectors, is a robust cybersecurity system able to handle and adapt to continuous or unexpected challenges such as the COVID-19 crisis that we're facing today?
Absolutely. You've got to see, even in the past couple of months, what we've seen is a rapid introduction of so many new technologies. And that's really to ensure that we're still able to give patients access to healthcare. Across the world, we've seen remote technologies being introduced into healthcare, video consultations, telephone consultations taking place, and we need to do that. And at the same time, the education piece is critical across the board. As people change the way that they work, they need to make sure that they are taking on that responsibility of making sure that cybersecurity is part of their training, part of their education, part of their responsibility into delivering patient care as well. At the end of the day, everybody who works in a healthcare organization is a custodian of patient data. And certainly, as we've seen with all these new technologies that have been introduced, we know that actually some of them are here to stay and it's not going to go back to business as usual. For that, what we need to do is actually, take a bit of a pause and actually look back at all the new introduction of all of these different technologies and actually look at the security profile of them and make sure that the ones that are here to stay are secure by design. As we move forward, that we're not going to have the problem, as Dr. Ahmed had earlier said about the legacy infrastructure. We can't have all of these technologies bought in, used for year upon year, but not have the full security profile of them. But certainly, I think in a very quick way, the education part needs to be there for every professional that's working with new technologies, new systems, and that's how we need to quickly develop this piece. And deal with something like a pandemic coming through.
Dr. Ahmed, your thoughts on this? How do we adapt to the constant changes?
Right. So let me tell you, the problem is so complicated as been mentioned. So on top of everything, you have a supply chain, right? So the report aptly points to supply chain as a major problem, especially in healthcare, in all the devices. I can't imagine the nightmare to CIOs when they hear the word plug and play. So you have devices that become so easy, right, to integrate into the network, and people call them plug and play. And you also have devices that are cloud enabled, right? While you're trying to secure your parameter, you have devices that can grab an IP address and go online. So one of the things that we found that is very helpful here through the Ministry of Transportation and Communication, the Ministry of Interior, we have a common criteria lab. And the common criteria lab is a test lab where devices get tested and so on and so forth as a criteria to bring it into a operational system. I mean, I don't want to be repetitive, but I can't underemphasize the difficulties that we face by this sort of huge number of devices, and maybe quarter of attacks are due to these devices. So it's a major problem, and people who are trying to defend the healthcare system are just they're the heroes, because the problem and the magnitude and the attempts of the attack. I mean, I equate healthcare cybersecurity to national cybersecurity. Could you imagine if the healthcare systems were taken down during the pandemic? I mean, the problem is extremely serious, and I agree completely with what Barton said. It's a very serious problem. The difficulty on top of everything is that healthcare hospitals and ministries of health have to be realistic in a shrinking budget environment. So they have to prioritize. And what do they prioritize? Do they provide the healthcare, or they secure the legacy system? You know what I mean? At the end of the day, they have to prioritize. Right.
But is that prioritization that you talk about, is it happening already in some places, you think?
It is. It happens every day. It has to happen every day. I mean, for those that are responsible for securing healthcare systems, whether it's at the national level or at an individual hospital level, they have to make those choices every day, and it's risk versus benefit versus how do you manage risk? At the end of the day, it's about risk. How do you manage risk? And how do you protect your environment given a limited amount of resources?
Right. Arvind, interestingly, what I found interesting in this report is that, where healthcare cybersecurity is concerned, low and middle income countries could have apparently an advantage on high income countries, on rich countries. The report talks about low and middle income countries having the opportunity to leapfrog the challenges in the high income countries. Do you agree with this? And are there examples of this already happening as we speak?
Definitely, yes, because low and middle income countries don't need to deal with some of the problems that the other developed or high income countries have. So the problem is the same. What you need to achieve, the end goal is well known or is well articulated to everybody. So it's a direct jump. So they don't need to go through those steps of learning. And that's a good advantage. And second, in this aspect, low and middle income countries also have some sort of a cost advantage because they're able to get their scales of power. So that also financially, while this could be a financial, better advantage, which is unconventional, right. That's where these countries have. And I think they just move faster because it starts making a level playing field, especially right. on a topic that is technology, that's intellectual, you start moving forward. So definitely, yes, these countries have a stronger advantage and they have smaller problems to deal with than the other countries. There is no baggage. So,
Ron, do you agree with that? Do you think low and middle income countries have a stronger advantage than rich countries, despite not having the financial means that rich countries have?
There we go.
But they're a bigger target too.
I would say yes. I would say that if you're approaching an information security management system, if you're setting up a system from scratch, it possibly would be easier, but provided you have the motivation to do so, provided you have the leadership to do so, the budget to do so, and some of the technology or the necessary means to do so. So pretty much touching on all of the points that we've touched on. Then to add another layer to it, I would say, then you don't have to do everything that's take frameworks, for example. You don't have to go ahead and set up a NIST framework if you're a tiny little clinic You can just go ahead and follow some of the ECHO or Cyber Essentials or other typical smaller guidance frameworks to get the ball rolling, essentially. But in order not to, for the audience, not to paint a nihilistic kind of picture that it's so complex, what are we going to do, and so on, if I can break it all down, are there lots of challenges? Yes, there are lots of challenges. Can we solve these challenges? Yes, we can solve these challenges. Are they complicated and complex? Yes, certainly they are complicated, but as I said, we can gradually, through leadership, through the necessary frameworks like ECHO, step by step begin that process. Then it takes us to the next question. Have we learned from history? Would people immediately pick up and just get on with it and get their information security management system or risk management set up? Possibly not. Being human, possibly we would go back to the original statement I made, where it's people kind of shrug it away, or they rather focus on business. They don't understand the real tangible material implications of this. So that brings us to the next question, which is, if we are not learning from history, if we are saying we want something to resolve the entire health industry as a whole, how do we push that forward so that we don't have this essentially this counterpart to the pandemic, as Deep mentioned, as cyber being the counterpart to the next pandemic? How do we get to that point? So then that takes me to perhaps a contentious topic, which is there a need for some kind of regulation? Take GDPR. So right. GDPR pushed a lot of organizations to essentially, the way we say, up their game, to begin taking this seriously because it was legally required for them to do so. Now, and as contentious as this topic might be, a lot of people are opposed to this. Nevertheless, I think we should address the elephant in the room. Should this be, because it's to do with people's personal identifiable information, sensitive information.
And who regulates?
And who regulates, exactly. And how do we structure
you
that?
Want to take that up? I mean, what's your view on this question, this elephant in the room? Then that's the question of regulation, and who regulates this?
Mm-hmm. Yeah, exactly. And who regulates it? How do we structure that? Around which frameworks? ECHO is a wonderful beginning. Perhaps others are out there as well that we can pull in from. And again, is it too much perhaps for certain organizations? Whenever a topic of regulation comes in, a small clinic will say, are you joking? I cannot do this. I cannot afford this. I don't have the budget for this. I don't have the expertise for this. How am I going to buy solutions for this? So all of these things have to be taken into account. When people throw regulation out there, you really have to consider the mature organizations as well as the small mom and pop shops that have opened up. They're trying to get their business going. We have to keep business in mind, basically.
Briefly, your thoughts on regulation, and then I'd like to come to questions from the audience, because we have quite a few questions from our audience. Just your thoughts first, Dr. Ghafour, on the question of regulation. Who regulates?
Absolutely, and I think what Barton was saying is that disparity between the kind of cyber mature organisations to ones who are, much smaller in size. But again, if you don't bring in some element of regulation, then you kind of think, who are these organisations accountable to in terms of cybersecurity? And as we rely more and more on digital technologies to provide healthcare, and we know that actually there is a huge fallout in terms of the impact of what would happen if a system fails, essentially because of a cyber attack. You need to make sure those systems are robust, are in place, and there is some accountability and regulation. Certainly in terms of what's happening in the UK, and from our experience here, this has changed over the past couple of years. But I think at the same time as having regulation, what you need to have hand in hand is to make sure that you're providing organisations with support, with education, with help in making sure that they can attain the levels that they need to report back to. So if you don't have those hand in hand, then regulation is one of those things that, you can have it there, but you can, continually fine a healthcare organization for not meeting those regulatory requirements if you're not helping them achieve all of that as well. And you've got to give them time in which to do this. Yes, you've got some who are going to be much ahead of the curve, who've got, all of these elements in place, but then there's the much smaller ones who are going to need a lot more help, and that's where you need to invest.
Right. That was an incredibly timely and meaningful conversation. Let's get questions from our audience now. I mean, thank you all very much, of course, for sharing your views and offering us solutions on how we can scale up cybersecurity in healthcare and provide a secure patient-doctor environment. So our audience who've been watching us online have quite a few questions for you all. So I'll now open up the floor to questions, and we'll try to get to as many of them as we can. So the first question goes to Dr. Deep Chana. And the question, Dr. Chana, is why has there been such a lack of investment for health cybersecurity compared to other critical sectors? I think we touched on this a little bit before, but you can perhaps share your views with us on that.
Yeah, I mean, I think some of the other panel members through the discussion have maybe touched on this a little bit. And as I said before, I think there are a number of different factors. One of them, of course, is that the priorities in the healthcare system are quite often, in a different place. You're just trying to deal with very restricted budgets and deliver the healthcare system and deliver good health and well-being to people. The focus has been on that in the past. And so you can argue that the sort of data piece has crept up on the industry as it has in other industries as well. And I think in limited budgetary environments, it then becomes very difficult to say, well, look, I'm going to do this whole cyber thing whilst I'm not doing the kind of frontline stuff that I need to do. And again, COVID-19 has shown us that. So I think that is certainly a big factor, and that then obviously motivates perhaps more investment, but also maybe smarter ways of operating and working and the cultural things that we've talked about as well. I do also, however, think, when I go back to what I said previously, is that there are also some vested interests that we have to talk about, right? There are clear interests around not regulating some of this space or not creating standards. We are already quite far down the line of seeing several instances around the world of data grabs effectively on health data. And again, there's a tension between all of these different things. But I think probably the first part of my question is the predominant driver. The second is the emergent.
All right, thank you for your response. Dr. Ahmed, a question here for you. You mentioned legacy systems that are often left alone for fear of breaking. And the question is, how can organizations try to make these systems more secure as part of their cybersecurity planning?
Well, so that's a chicken and egg problem. This is a very costly process. Anybody that has been involved in doing a data migration project, anybody that's been involved in doing an ERP system project, SAP or Oracle of that nature, knows the enormity of these tasks. Migrating a legacy system is just it's a humongous task that most people end up at the end of the day just leaving it alone. Back years ago, we used to call it a spaghetti ball because it's just so intermingled, you don't know what to do with it. So if you had an unlimited budget, yes, you will tackle that problem. If you don't have an unlimited budget, you fence that system, you sort of limit its access through the internet somehow, and you live with it as long as you can until you retire it. If I may comment on what David had mentioned on regulation. See, regulation and laws can only go so far, in my opinion. First of all, you have to attribute the problem. So attribution in cybersecurity is a big problem. If you can't have accurate attribution, how could regulations and legal aspects work? So we need to advance the way we do attribution. And the solution here could be technical. I know that we're looking for social and cultural, but to this problem, the solution may be technical. We have to be more proactive. We have to perhaps use artificial intelligence to do predictive analysis of logs in order to anticipate problems before they occur. And I'm very impressed, for example, here in Qatar, this type of technology is used, at the relevant ministries. The Ministry of Interior, they use predictive analysis on all kinds of logs to try to anticipate problems before they occur, and to be able to do better attribution. If you have better attribution, then you can pursue legal routes, you could do regulation and so on. Sorry for deviating from your question, but
that's okay. That's okay. I think it's important that you pointed out that more proactive use of AI, artificial intelligence, we talk about AI a lot lately, is needed to anticipate some of the problems before they actually occur. Anticipation is key, isn't it?
Also, I'm sorry to interrupt you. The cybersecurity is becoming more like a data analytics problem. You know, it's to a certain degree, not 100%, but to a large degree, is becoming a data analysis problem.
Okay, let me move on to Vartan. A question here for you, Vartan. You'd mentioned in your comments earlier that there's a 4 million person shortage in the industry right now. And so the viewer here asked, what is the best way to recruit people in healthcare where perhaps salaries will not be as high as in other sectors?
I think this is a fascinating question. It's definitely a question for some government officials and ministers, and as well as some organizations. But in terms of training courses, whoever asked the question, so if the interest is coming from the point of, are there courses out there? Is there shortage out there? Can I train and can I essentially prepare and get in the market for this? Absolutely. This is one of the most fascinating, one of the most exciting jobs out there. So equally, organizations themselves, leadership, if they are taking this seriously, they can assign a budget for training. They can assign a budget for training for CIOs, as we mentioned or risk managers or compliance managers, as we mentioned in this conversation on this panel. This is a continually evolving field. So continual training is absolutely necessary. So not only should there be private-public partnerships, government initiatives, budgets are set aside to train. University courses are there, plenty of them, they're fantastic, but also organizations themselves, even if they're small, it doesn't take much to set aside a budget and send an individual to get a course with one of the governing bodies or one of the frameworks, or an online course to basically get up to speed.
Right. Well, just to follow up on that, there's a question here for Arvind. Arvind, a question just to follow up on what we just heard there from Vartan is, we often hear from clinicians and admin staff in hospitals that they don't understand the cybersecurity guidance that's sent around, and they feel that it should be the job of IT departments to address these issues. So what can organizations do to better encourage all staff to engage with cybersecurity measures?
Well, one, to be fair to the clinicians and those healthcare workers, I think we need to talk in English to them so that we are not talking a language that scares them, and thereby they think that it is some rocket science. So I think the technology teams are guilty of that crime. But I would say an inclusive policy, getting everybody to work together to understand the problem statement and start defining what are the way forward. Obviously, as you're defining the way forward, you know the challenges in front of you. That means that the solutions you make will be inclusive, even though sometimes people would feel that it's getting infringing on their freedom and their free movement that they had without the earlier, curbs on policy making and even compliance. So I would say let's make it inclusive, more training, talk about it in simple language, and articulate in terms of impact and how we can help mitigate. Rather than always talk about the problem, if we can talk about the mitigation also, talk about the solution, I think we're going to have everybody join hands and make this happen and not make it sound like IT.
Yeah, make it inclusive. That's a very important point you make. Dr. Ghafour, another question here for you, and this is relating to the COVID-19 pandemic, of course, because this is what a lot of people are dealing with and experiencing right now. The question is, we've seen an increase in the number of cyber attacks against healthcare organizations during the pandemic. We mentioned the WHO earlier before. Why is this, the question is, and what has been the impact on healthcare?
I think cyber attackers are now realizing the potential havoc that you can cause using a cyber attack. And obviously, we were already going through such a chaotic time with the pandemic itself and the misinformation surrounding that, that when you throw in a cyber attack into the mix, that you know that the consequences of that can be very significant to catastrophic. I think earlier we had one of the discussions that I think it was Dr. Ahmed mentioned that, could you imagine that a cyber attack in the midst of this pandemic would be utterly chaotic against any given healthcare system? And I think the big issue is, I think cyber hackers, attackers, etc. They realise now that the potential impact it can have on the on any given healthcare organisation, and using that vehicle of a pandemic when everybody is using that across social media, across all different emails that you send to various people, etc. That using that as a target, that is much easier to do that. And obviously, healthcare organisations are out there. They are the ones being contacted for various bits of information. For example, the WHO and the CDC were giving out lots of information about the pandemic. Also, there was the Johns Hopkins Centre about the tracking of the pandemic as well. That was another kind of target in terms of their web domain as well. So It's a very easy vehicle to kind of put that onto. And across the healthcare sphere, essentially, all different organisations were facing the same issues, that you were moving to remote systems. Healthcare workers were moving across different areas that they potentially may never have worked in. You were having different people accessing systems because there was an urgent need to do so, and hence it was more vulnerable.
Okay, that was a question, by the way, from Galia Al-Ail, who's watching us online. Thank you, Galia, for that question. Now, before we end, I'd like to go around and ask each one of you in 1 minute to tell me what you think to end our discussion today, a final word, a message that we leave with. What do you think is the best way to speed up progress in cybersecurity within healthcare? Dr. Deep Chand, I'll start with you.
Thank you, Folly. Great session. I'll keep it very simple. Isolationism must give way to open collaboration. And that's, right the way through the government systems, right the way through our private sector, and with our sort of individual behaviors and cultures within organizations as well. So I think that's the key thing. And we could talk a lot about the various technical approaches, and there are many. Machine learning and AI is coming around the corner as well, making this kind of framework that's been published even more urgent for people to get on board with. So I think transparency and collaboration, as I say, needs to give way to perhaps some of the more isolationist things that we've seen.
Dr. Ahmed, your final thoughts. What's the best way forward to make healthcare systems more secure?
Yes, I think the most important thing is to increase and improve partnerships and communication across agencies, whether at the national level or internationally. The criminals are communicating all the time, very easily, exchanging information. The responsible agencies are not communicating as well and as easy. If I also may add that, in my opinion, during the COVID, the biggest threat was coming from misinformation on social media, which was not the topic today, but that caused a lot more chaos than cybersecurity.
We'll get to that topic later on today at WISH, by the way.
Very good, very good. So partnerships and communication will go a long way to address this problem, in my opinion.
All right, thank you for your thoughts, Dr. Ahmed. Arvind, your final thoughts then. How do we speed up progress in healthcare when it comes to cybersecurity?
Start now, start immediately. Every step counts. And don't hesitate to communicate. Don't hesitate, even if there's a mistake, deal with the design. Whether it's legacy or the new age systems, deal with the design. But every step counts. Don't worry that it's a problem that's bigger and difficult to solve, but just start and start sincerely and start in full earnestness.
Okay, thank you for that. Vartan Sarkisian, your final thoughts. What message would you like our audience to take away with them today as we wrap up this discussion?
Thank you, Foley. 3 quick points. First of all, it's important for leadership of businesses, organizations to remember that this concept that this is a tech problem, it is not a tech problem. There are tech solutions out there. It is possible to resolve it in a variety of different ways. So it's a people's problem, essentially, and it's a leadership challenge. So I encourage leadership, or no matter what size, to take this on and fully and deal basically and start resolving it gradually. Second thing is, it is difficult, to earlier point, that the return on investment would be, it's difficult to find, to materialize. So they shouldn't look at it as, I put in this and I get that, but it's a more of a, it's an insurance. It's something that you're taking care of your customers, your clients, your employees, and so on. So that's an important point to keep in mind. And lastly, you do not need anything too complex. It's very, you can start with very certain basic measures and that don't take much time, that don't take cost resources or money or funds. And yet there's a lot that an organization, even a small clinic, can achieve by following simple initial steps, achieving those, and then moving on to the next. So I actually want to leave it on a positive note that this is a challenge, but we are able to resolve the challenge. We just have to become more active and prioritize it.
Thank you for your optimism. Thank you very much. Dr. Ghafouri, you have the last word. You've presented the ECHO framework to us today. What is the next step?
Absolutely. So I think one of the key things about our message across cybersecurity and healthcare is always awareness that cybersecurity is a patient, or an attack on cybersecurity is an attack on patient safety. And this is something that we need to keep in mind first and foremost as we move forward. We've proposed the ECHO framework as a starting point. We are very thankful to everybody who's participated, both in the survey and all the experts who participated in the Delphi process to come to this framework. The next steps for us are to work collaboratively with organisations across the world to test and trial this framework to make sure that we can iterate and refine it and make sure that it can be used for the purposes it was created and be used in low middle income countries as well as high income countries. And we look forward to doing that and partnering across the globe. Thank you.
Thank you very much. Thank you to all of you for your valuable insights today. As we've heard, in order to scale up cybersecurity in healthcare, it's important to promote a globally validated and unified cybersecurity framework, and that requires strong partnerships and commitment. Thank you once again for your insights. Thank you to our online audience who've been watching and taking part in this important discussion, and to the WISH 2020 team, of course, the Qatar Foundation and all of its partners for making all this possible today. For more on cybersecurity in healthcare and all the other sessions at WISH 2020, visit the website 2020.wish.org.qa. From me, Folie Batibo in Doha, thank you very much for being with us once again. Have a very good evening. Thank you.
Thank you.
Hello, I'm Michelle Hussein, and welcome to the next session of Virtual WISH 2020. We've probably all talked this year about unprecedented times, and with the immense impact of COVID-19, another pandemic, one that millions of people around the world live with and have done for years, is easily overlooked. Every year, there are more than 1 million new cases of HIV/AIDS. The epidemics of malaria and tuberculosis are also ongoing. The Global Fund is a partnership that works to fight all three diseases which together account for more than 2 million deaths a year. That number is, however, about half the number of deaths at the peak. Now, though, the Global Fund is warning that COVID could soon wipe out years of progress. And its Executive Director, Peter Sands, joins us now. Welcome, Peter Sands. Why do you say that years of progress on these three diseases could soon be wiped out?
What we've seen since the emergence of COVID-19 is very high levels of disruption to programs to prevent, test, and treat HIV, tuberculosis, and malaria, the other three biggest infectious diseases in the world. In fact, 70% of the Global Fund's programs across the world report significant levels of disruption. And there is a huge amount at stake here. We're talking about diseases that kill over 2 million people a year, and we could lose up to a decade's worth of extremely hard-won gains in reducing infections and mortality.
But is that disruption due to the diversion of resources, lockdowns, health workers being put on the fight against COVID instead? What is it that is causing that?
It's sort of everything. What we've seen is diversion of resources. For example, much of the testing for COVID-19 is actually being done using molecular diagnostic tools that have been put in place for tuberculosis and HIV. Now, it's a good thing those tools are there and can be used for COVID, but what we need to ensure is that we don't stop the diagnosis and viral load testing for HIV. But it's diversion of resources, it's huge pressure on health systems. Remember, many of these countries have much more fragile health systems than richer countries in the world. And also lockdowns have made it very difficult to run, for example, HIV prevention programs, education and sexual and reproductive health. These things have all had to move very swiftly to a remote, a virtual environment in communities where access to the internet is much, much more limited than we see in richer societies.
And which countries are you most concerned about?
Well, I would say I'm concerned both about pretty well all low and low middle income countries, but also even in upper middle income countries, key populations, marginalized, criminalized, often stigmatized populations. Actually, what we've seen is in some ways human rights related barriers to health have been exacerbated by the lockdowns. So there are vulnerable populations in a whole range of different societies. But it's not like we're just sort of letting this happen. The Global Fund with partners has responded and responded very quickly to supporting countries and communities in working out ways to get around or mitigate the impact of COVID-19. And indeed, it's relevant to the World Innovation Summit for Health in that we've actually seen a lot of accelerated innovation, people doing things in different ways because of the crisis. And one of the lessons I hope we learn from this crisis is the benefits you get from rolling out innovation more quickly.
Can you give a couple of examples of that? Because that is exactly what the WISH community is all about, those kinds of ideas and sharing them.
Well, for example, for both HIV and TB treatment, we have moved very swiftly to digital consultation as opposed to face-to-face, to having courier-based distribution of drugs, to having multi-month dispensing, so people don't have to have the drugs delivered to them quite as often. If I think about bed net distribution for malaria, the traditional method was you would take all the bed nets in a truck to the center of a village, then all the families would gather and take them back to their households. obviously from a COVID point of view, that's not a very good idea to have everybody gather. So we've shifted to having health workers, volunteers on motorbikes going house to house. But the interesting thing is we've been using GPS tracking to ensure that every house is covered. And we're actually getting a higher level of household coverage of bed nets through this method than we used to through the method of just bringing it to the center of the village.
So there are positive changes that have come, but you are making an urgent appeal for the funding that you'll need to try and get things back on track against HIV, TB and malaria in the next year.
Absolutely. The Global Fund reckons we need about $5 billion over the course of the next year, both to mitigate the impact, the knock-on impact of COVID-19 on HIV, TB, and malaria, and to help countries respond to COVID-19 itself, because we've been one of the principal providers, for example, of testing for the poorest countries and communities in the world, and for PPE, for frontline health workers. Many of these countries have far lower ratios of health workers to population than richer parts of the world. We simply cannot afford to lose those health workers who are putting themselves at risk every day.
Can we talk a little about the relationship between COVID and fighting COVID and each of the 3 diseases that you work on, given how quickly the world has come together to try and find a COVID vaccine? Does that give you hope for a vaccine against HIV? Because in all of these years that virus has been with us, all of those deaths, all of those new infections, that hasn't, while we've done a lot on treatments, and people are living with the virus and with AIDS, the vaccine has never got there.
I hope that COVID actually is a stimulus, a catalyst for us to rethink our approach to the other 3 big infectious diseases. We don't have a vaccine against either HIV, TB, or malaria. The contrast actually is very stark. TB is the biggest infectious disease killer in the world up till now. And this year, 2020, COVID-19 and TB will be in pretty similar territory on current trends as to how many people they kill. They will probably each kill somewhere around 1.5 million people each. But there the comparison ends. To start with, on January the 1st, 2021, we will know how many people in the world have died of COVID-19, but we haven't invested in the same data systems for TB. We will have to wait till October 2021 to know how many people died in 2020 of TB. And likewise, the money. Total global spending on prevention, treatment, and testing for TB in the world in 2020 will be about $6.5 billion. The number for COVID-19 is not 100 times more, it's several hundred times more. And likewise with all the innovations, as you said, vaccines. If I look at the R&D pipelines for TB, I can point to a handful of products that might be coming in 2020, new tools to fight the disease coming in 2021. If I look at it for COVID, we're looking at several hundred. So I could talk through that with HIV, I could talk through it in malaria. The fundamental picture is the same, is that we should use COVID-19 as a catalyst to say, why are we still satisfied to be allowing so many people to die of diseases that really we know we can beat?
Should we also be looking carefully at the potential overlaps, for example, between treating malaria or the BCG vaccine that's been used against TB and some people are pinning their hopes on against COVID as well? Is there a relationship there that the fight against both diseases could benefit from?
There are lots of interconnections, and indeed, most low and low middle income countries' responses to COVID-19 have been off the back of the capabilities in infrastructure that have been put in place to fight HIV, TB, and malaria. The supply chains, the laboratories, the frontline health workers, the community systems are the same. It's also really important that we get very good at differential diagnosis. So if a child presents with a fever, is that child got malaria or have they got COVID? If somebody comes in coughing, have they got TB or have they got COVID? And so we need to sort of treat the person, not just the individual disease. You mentioned the BCG vaccine against TB. This is a good indicator of how we need to be careful not think that vaccines are a silver bullet. BCG only really works against pediatric TB. You still have 10 million people a year falling ill with TB and more than a million are dying, even though we've had this vaccine for many, many years. As we think about the fight against COVID, it's really important that we absolutely accelerate and deploy vaccines as quickly as we can, but we also deploy treatments and we also deploy testing. We need the full armory to be able to really defeat the pandemic.
But also, should we be mindful of the problems when you do have vaccines developed that are not widely used because their efficacy is not as it should be, and that's been the case with malaria?
You absolutely need to be very careful about the clinical trials, the efficacy, the safety profile, and the way that the performance of different medical tools is communicated to the public, because if you lose the public's trust, then it's very difficult to actually get everybody comfortable with having a vaccine, taking a treatment, or for that matter, for isolating themselves. I think one of the big lessons actually that can be learned from the fight against HIV, TB, and malaria is that you absolutely need communities involved. You need community leadership, community buy-in, because if you don't have that, and many countries have seen this as they've tried to do test, trace, and isolate with COVID, if the community doesn't believe it, it's not going to work.
Peter Sands, Executive Director of the Global Fund to Fight AIDS, Tuberculosis, and Malaria. Thank you very much.
Thank you, Michelle.
For much of the time that Tony Blair was the British Prime Minister, our next speaker was by his side. Alastair Campbell saw politics from the inside, but in recent years he's turned his focus onto mental health, writing and speaking openly about his own lifelong struggle with depression. He published his latest book entitled Living Better, Learning to Survive Depression, which will form the basis of his masterclass today.
Thank you. Nick, are you speaking or am I? I wasn't expecting to. I thought I was coming in at the end of this, so I
That's
shall
fine.
leave it
Well,
to you now.
I'll fire away. It's very nice to see you there. And I've got to be honest, I'd be really happy if I was in Doha, because it's, as you can probably see from the light on my face, it's just suddenly got very, very dark outside here in London. But I'm delighted to be with you, and I'm delighted that you've asked me to speak about mental health. And, you know, Michelle said there that during my time as a advisor to Tony Blair and to the Labour government, I wasn't constantly struggling with mental health. I was, most of the time I was fine, and I was very energetic, and I was able to I hope make a big contribution. But the depressions kept coming and going, and I think that one of the reasons that I've decided actually to spend quite a lot of my time at the moment campaigning on mental health is because I really think we need to change the lens through which we look at mental health. And when I talk about that, I mean that as individuals, I mean that as governments, I mean that as countries, I mean that as cultures, that we have to shake off the shackles of literally millennia of the way that we've thought about it. And the reason the book that Michelle mentioned is called Living Better. There you are, How I Learned to Survive Depression. And it's really in two parts. The first part is very much about my life, my story, my family, things that have happened in my past that maybe led me to have some of the mental health challenges that I've had. And then the second part, I call it the search for a cure, but it's really just looking at the different ways that different people, different organizations are looking at this. And the way that I see mental health and the mental health debate is that we focus really on mental health when it becomes mental illness. And what I want, when I talk about changing the lens, I want us to look at mental health. And I want us to get to a place where we all feel that we can be as open about our mental health as we are about our physical health. And I know that has helped me. I know that that approach has helped me. If I go back through my mental health journey, as it were, I really first became aware of mental illness when my brother, Donald, he was in the army, and he was diagnosed with schizophrenia. And he was invalided out of the army. And that was a life-changing moment for him, but also for the whole family. And that was really what inspired my interest in this, because as I describe in the book, the drugs that he was on until he died age 62 were the same through that, pretty much the same family of drugs through that whole period. Despite everybody knowing that they shorten your life, and despite everybody knowing that the side effects can be terrible. Now, I accept that the drugs helped him to lead a reasonable life, a reasonably good life. But at the same time, the research, I always feel that mental health is at the back of the queue when it comes to research. And I wanted to try to get it to the front of the queue, because I think this is so important for all of us. And then in 1986, I had a psychotic breakdown myself. I don't know why. I mean, I was drinking too much. I was overworking. And it was a horrific event, which I describe in very great detail in the book. But I was also incredibly lucky. I was arrested for my own safety, and I was arrested by two policemen, and there was something about them that made me trust them. And when one of them just said to me the very simple question, which are the best questions you can ask when you're worried about somebody who might be struggling with their mental health, he just said to me, "Are you okay?" And I said to him, "Do you know what? I don't think I am." And it was the first time I had ever admitted to anybody that I might have a problem, that I might have a weakness, that I might really be in need of some sort of help. And the next thing I know, they were both in plain clothes. I didn't know they were policemen. But the next thing I know, I was in the back of a van, and then I was in a police station. But I was lucky there as well, because they made a judgment that actually I wasn't a danger to them, I was a danger to myself. And they called in a police doctor who I was allowed to leave, provided I went to hospital. And I was very lucky as well with the psychiatrist that I had in the hospital, who didn't lecture me, didn't nag me, didn't tell me I was a terrible person, didn't tell me it was all my fault. He just asked me a few questions, which led me to the conclusion that I probably needed to stop drinking. So I stopped drinking, and yet the depression still kept coming. And I was lucky as well because, and this is why a lot of people on this at this conference will be employers. You will employ people. And I have been incredibly lucky with my employers. And one of them is a guy called Richard Stott, and he'd been my boss at my previous newspaper. I was a journalist before I went into politics. And Richard had been my boss at the Daily Mirror, which I'd left to go to a different paper. He was very angry with me. But he was one of the first people who phoned me up when I was ill. I was in hospital, the nurse wheeled the phone in. I picked up the phone, it was Richard. And he said, I hear you've gone mad. And I said, well, I'm not very well. I'm in hospital. I'm probably going to be here for some time. And he said, well, don't say I didn't tell you. Told you not to leave here. Told you you should have stayed here. But here's what you're going to do. You're going to stay in hospital till they say you're better. You're going to go back to that job that I told you should have never left before. You're going to take the money there till you're 100% fit. And then you're going to come back here and you're going to start at the bottom. And even as I tell you that story, I feel a kind of a weight coming off me, because that was somebody saying to me, as I was in hospital, as I was mildly psychotic, as I was paranoid, he was saying to me, I'm not going to judge you by what's happened to you now. I will judge you by what I know. And too many employers, I think, don't judge people on that. If they know that somebody's got a history of mental health problems, they're written off. He wrote me in. And then the second person I was very lucky with was Tony Blair. Now, when Tony Blair first asked me to work for him, I said no. And one of the reasons, well, lots of reasons, but one was my family was very opposed. I had a nice life. I'd got my life back together again. I'd rebuilt myself. I'd rebuilt my career. I was doing well. And yet it was quite a big challenge to be offered, and I was very, very tempted. He said to me that he really, really wanted me to do it. He didn't feel there was anybody else that he could do it as well as I could. And he kind of knew how to play the strings. And eventually I thought, okay, I'm going to do it. However, I felt I had to tell him why I was so worried. And I had to tell him that one of my worries was the fact that I'd had a nervous breakdown under pressure. And I was obviously going to enter a world, high-level politics, where the pressure would be even greater. I was worried I might crack up again, to be absolutely frank. And I told him the story. I told him about the build-up. I told him about what happened. I told him about the psychosis. And I can remember, as I was telling him, that I was inside my head. I could hear bagpipes, Elvis Presley, ABBA, Edith Piaf, Jacques Brel, football commentaries, rows with my partner, rows at work, rows at home, all going on in my head. I could remember Tony just looking a little bit worried. But then he said to me, he said, well, look, I'm not worried if you're not worried. And I said, well, what if I am worried? And he said, I'm still not worried. And that was actually one of the reasons why I agreed to do it, because I thought that's another boss. He's going to be my boss. He's probably going to be the prime minister. At the time he was leading the opposition. And he's not defining me by my mental illness either. And when I talk about my brother Donald, he had the same, he held down a job, despite having schizophrenia. He had a job for 27 years. Wasn't a very high powered job. He was in the security department at Glasgow University, and he was also the official piper. He was the official bagpipe player for the university for ceremonies and so forth. But the reason that he was able to hold down that job, despite fairly regular periods of quite bad illness, was because the university never ever defined him as a schizophrenic. They defined him as an employee that they valued who had schizophrenia. And sometimes that meant he was ill. And sometimes it meant they had to adapt to that and they had to look after him in a different way. And I think that is the approach we have to take, because when I talk about changing the lens, so there's a tendency to think that mental illness is all bad. And I don't wish my depression on anyone. I wouldn't wish schizophrenia on anyone. I think illnesses like OCD, like chronic anxiety, these are awful illnesses to have. And yet, at the same time, if you were to say to me, okay, there's a button there on the top of your water bottle, and if you press that button now, you will never, ever get depressed again. And I might say, well, okay, I don't ever want to be depressed again. But at the same time, I don't want to lose that incredible energy that I get when I'm coming out of a depression. And I don't want to lose the incredible creativity that I sometimes feel when I'm maybe a little bit manic and a little bit borderline dangerous. So I now have a depression scale. I mark my moods every day when I wake up. And 1 is ecstatic. At 1, Brexit never happened, Donald Trump never became president, and the world is a really happy place. And that doesn't exist. So number 2 is the maximum that I'll allow myself. 3 and 4 is where I like to be. 5 is where I am when I'm feeling a little bit edgy and I'm not quite sure where my mood's going. And then once I'm into 6, I'm into what I call the downhill slalom. And then I'm into 6, 7, 8, 9 quite quickly. And I never allow myself to go to 10 because 10 is suicide. And that's my mood. And that's what I mark every single day. And just so as you know, this morning wasn't great. I was 6. And I don't know if you can hear. And here's the other thing I like to talk about in relation to this is the relationship, the link between physical and mental illness. I don't know if you can hear, but my voice is maybe not quite as strong. If there's any Brits on, you will know me talking on the television or the radio. I can be very, very forceful in the way that I speak. When I get depressed, my voice weakens, my eyes weaken a little bit. My skin actually changes hue a little bit. And that sense of the physical and the mental is an incredibly important part of why we need to change the lens as well. Because if I go back to the time when I was cracking up, there were 3 things that I never took seriously. I never took my diet seriously, I didn't exercise, and I didn't care about sleep. There's a passage in this book where I talked to a young guy who's now the editor of the Daily Mail called Geordie Gregg, and he was then a young reporter and I was his boss. And I recall calling him into my office. I was the youngest news editor in the British newspapers at the time. And I said to him, Geordie, I just want to tell you something. Sleep is a waste of your time and mine. Now, I would rightly get sacked for saying something like that today, but that's what I thought. And now I take my sleep incredibly seriously. I take my diet seriously. I exercise every single day, even when I'm not feeling that great. And so what I've tried to do, and what I've done towards the second part of the book about my own depression, is that I've tried to put down all of the things, all of the strategies and all of the tactics that have helped me. And I talk about it surviving depression, how I learned to survive depression, because part of my survival of depression, I've accepted that there will be periods in my life when it's just going to come and hit me again. And I describe in detail what that feels like. And I can't describe everybody's depression. I can only describe mine. I'm not an expert on depression in general. I'm an expert on mine. But I've developed a relationship with it that I've learned how to deal with it much better than I used to. When I used to get depression, I would just literally turn in on myself. I wouldn't tell anybody. If anybody suggested to me that I wasn't okay, I would turn on them and say, what are you talking about? You're the one with the problem. If you think I've got a problem, why are you nagging me? I would say to my partner, why are you not just sort of letting me be who I am? And that's very, very difficult for the person that you're living with or the people that you're working with who can tell something's wrong, but you don't want to admit it. So now the very first thing I do when I feel a depression coming on, the very, very first thing I do, I tell Fiona. It often happens as I'm waking up and I will say to her straight away, oh my God, it's happening again. I will, with my work colleagues, I will tell them. And that helps me. And I think it helps them to be able to deal with me better. And one of the most extraordinary things that when I was researching the book, and I almost called the book How a Jam Jar Saved My Life. And the reason for that is that I was very interested in exploring the genetics of mental illness. And I discovered that there was a woman in Canada called Dr. Janine Austin, who runs a genetic clinic where essentially she studies the genetics of people who are struggling with their mental health. And I went to see her and we really went through my whole kind of family tree and so forth. But actually, the thing I took away from her And this is what I'm going to close on before Nick takes control and we go back to a few questions, I hope. She said to me, she said, the thing you've got to do, think of your life as a jam jar, okay? And I've described in detail my own jam jar, but I'll come on to that. She said, down the bottom of the jam jar are your genes. And that basically is where you come from. It's your parents, it's your background, it's your language, it's your country, it's your culture. Nothing you can do about it. That's who you were born as. And then the rest of your life fills the jam jar with good experiences and bad experiences, nice memories. Lots of it you just don't remember. It disappears. Most of what we do, actually, we don't remember. But the important stuff kind of stays in there, good and bad. And most people, most of the time, they can manage it. And life is sort of manageable. And she said, when it becomes unmanageable is when the jam jar gets too full and it explodes into illness. And what she said to me was, instead of focusing on this bit where all the Freudians take you down here and they want to try and, you know, work out what sort of strange thoughts you had about your parents and all that stuff. And then the analysts, they want to take you in here and sit you down on a couch and say, what did you do last Tuesday? And what did you think when you were doing it? And all that stuff. And she said, it's all fine. And I live in NW3 London, which has the highest proportion of psychiatrists per head of population probably anywhere on the planet. And I've got a very good psychiatrist. But she said, that is not going to help you as much as if you could grow your jam jar. And what she meant by that was to build onto it. And I've got one on my wall, visual, my jam jar that's grown. And so my jam jar, very briefly, FFF is Fiona, family, friends. If you get your key relationships right, your jam jar is growing already. The next big chunk is MA, meaningful activity. And for me, meaningful activity is two things. It's meaningful activity that pays a living, allows you to have a decent standard of living, and meaningful activity that allows you to change the world for the better, hopefully. And then I go into my fundamentals, the basics that I mentioned, sleep, exercise, and diet. And then I go into the things that are special to me. So I wouldn't expect everybody in the world to have bagpipe music as an important part of their jam jar. But I play the bagpipes and I listen to the bagpipes and it helps my mental health. I wouldn't expect everybody who's involved in this conference to understand why Burnley Football Club is a big part of my jam jar, but it is. I wouldn't expect everybody to understand why Jack Brel's music is, but it is. So all of this stuff builds up. And then there's the thematic stuff, creativity, curiosity, always wanting to learn things. Languages to me are very important. Words are very important. So that's the jam jar extending. And the thing is, I met this lady in Canada. If you'd have bumped into me on the plane on the way out to Canada, and you'd have sat next to me and you'd have said, are you that Alistair Campbell guy who talks about having depression? And I'd have said, yeah. And then you might have said, well, you seem okay most of the time when I see you on the TV. So how do you deal with it? And I would have said, well, do you know what? I take medication every day, which I do, and I see a psychiatrist and I'm feeling really, really bad. That's what I would have said. That was my stock answer for how do you deal with depression. Now, my stock answer is I get my jam jar out and I show them my jam jar and I say to them, the reason I can cope with it is that I've accepted it's part of who I am, but I have not accepted that there's nothing that I can't do about it. There's a lot that I can do about it. It doesn't mean I'll always be successful, but in trying, all I can say is that since I've had my jam jar, the gaps between the really bad bouts have got longer. And when the bouts come, they've got shorter. And I thank the lady who gave me this. I'm also pleased to say that this very day, she's being nominated for a major award for her work. And I hope it's partly because I've been able to publicize the work that she does. So, you know, just to close with this thought, mental health, we all have physical health, and some days it's good and some days it's less good. And it's just the same for mental health. We all have mental health, and some days it's great and some days it's not great. And the sooner we can all accept that, and the sooner we can all say to each other, when you ask that question, how are you feeling? it is okay to say, do you know what? I don't feel great. And it's okay for the other person then to have the language of empathy and understanding to say, do you want to talk about it? And if they do want to talk about it, they talk. And if they don't want to talk about it, they don't. But at least you can feel that's a normal part of the conversations that we have. So let's break down the stigma. Let's break down the taboo. Let's put more money into research into mental health, because particularly with this pandemic now, it is the big health challenge coming down the track. Thank you for listening, and I'll now hand back to Nick in warm, sunny Doha.
Thank you, Alistair. Thank you so much for that. I mean, really, you can see how heartfelt it is, and I think our audience will really appreciate what you shared. We're going to have some questions, as you can imagine, that have come in from our community, our global community. So we'll just go to those in 1 second. Okay, so first question here is, you mentioned that you're a 6 today. Does that stay the same throughout the day? Do you sort of accept this is a 6 day, I'm going to cope with that, or do you go through? Do you try and alter it, or have you given up trying to alter that, and do you go back to bed and try tomorrow will be a different day? How does that work?
I mean, that is a brilliant question, because in the old days, I would stay in bed. And as I stayed in bed, I would descend further, 7, 8, 9, because I would say to myself, there's nothing I can do about that. Now, in fact, today's quite a good day. I've actually done quite a lot today. And I'll give you 2 or 3 things which I did right at the start of the day, which helped. First thing, as I said earlier, I said to Fiona, don't feel great. The dog, our dog was on the bed, and don't ask me this, right, but my dog knows when I'm not feeling great. And she just jumps up on the bed and she just sort of lies there next to me. It's really quite strange. When I'm really bad, she's always there, first thing. So that sort of helps. The next thing I do is anybody who's ever known people or been in a community with lots of depressed men, you notice how they don't have the designer stubble like you've got, Nate. They have scruffy stubble. Because, and I recognize this, the first thing that goes for me is shaving. I think I can't be bothered. So I force myself to shave. And then the other one that I've got is I've got a blind on our landing. And I force myself to open it. And I force myself to stand there, whatever the weather, and say to myself, it's a nice day. Now, if I don't do those things, I slide further. Now, through today, I've done a couple of things that have been quite challenging. I've done a couple of things that have been quite relaxing. I've done a couple of things that I've forced myself to do. And I would say, as a result of that, I'm about 5. And as to whether you would see the difference, I hope I've put in a lot of myself into this. I like to be energetic. I like to pump it out. I'll be tired. I'll be more tired at the end than I normally would be. So that's the way it works.
Yeah. I'm just going to really go through these because we have quite a lot here, and I think they're quite interesting the way they've come through. So, how do we cope with setbacks in our mental health? And linked to that, how do we recognise progress?
And I wrote another book a few years ago called Winners. It was about the winning mindset in sport and business and politics. And my favourite quote in the whole book was from an Irish athletics coach who coaches the Kenyan athletics team. And he said, the loser is the winner who evaluates defeat properly. And so I think if you have setbacks, I don't think there's anything wrong in ruminating about them. Because the thing is, I know that me, when my mental health's not in great shape, I'm ruminating all the time anyway. I can't control the stuff that's kind of going around my head. So once I'm through that, I actually do try to say to myself, what was that about? Where was that coming from? And I never have the answers, by the way. I never know why it gets triggered. There's never anything. It's very rare that it's something specific. So, but trying to analyze it yourself, and then actually, I find for me, the openness is just, I find it really, really helpful. Now, I know look, there'll be people from some countries who are on this now whose cultures is very, very different. And I accept it's a lot easier in the UK or America than it is. I mean, I was in Ghana a couple of years ago, and you know, I was talking to, there were about, I think, 2 psychiatrists for the whole country, thousands of faith healers who were, you know, and still a belief that a lot of kind of mental illness was kind of, you know, to do with the devil and all this sort of stuff, you know. So that's, so I accept I'm speaking, as it were, from our culture. But I think in any culture, if you're conscious, the thing about people who have mental illness is what it means is that you're very, very conscious of what's happening in your mind. So in the times when you're feeling okay, really think about it, really, and think about what you learn. And I mean, I said earlier, I don't resent my mental health challenges. I get a lot out. I feel a lot of my creativity and productivity comes from swinging around a bit on the scale. I don't want to be kind of like that the whole time.
Next thing we've got here is, well, I'm going to link 2 together, because one is, how cathartic was it for you writing the book, writing things down? Is it always cathartic to write things down? You're a journalist, you know, is that something you've always done? And then the slightly strange one for people listening that I don't think it will be for you. You're passionate about trees. Is this a form of escape for you? So there you go.
That's a relatively new passion, though. And I think that goes back to the point I made earlier about always being curious. So anybody who follows me on social media, on Twitter, I'm Campbell Claret, will know that every day I post a picture of my tree of the day. And it's taken off ridiculously. People send me their pictures of trees from all over the world now. And is it a form of escapism? No, I think it's a form of forcing me, when I'm out and about, just walking around the place, to root myself in the moment a little bit. And actually, you know, if you're on a train, you just look out the window and you see incredible trees everywhere you go. Now you see incredible buildings as well, but I've just kind of latched upon trees. And then the thing about cathartic, here's a question for you. Who wrote an absolutely brilliant poem called Think in Ink? The answer, ladies and gentlemen, was Marilyn Monroe. Marilyn Monroe wrote a poem called Think in Ink, and I think in ink. And was it cathartic? Absolutely, definitely. Is it always cathartic to write? Definitely. Why do I write a diary? Because at the end of the day, I want to just try and make sense of what the day has meant to me. Why have I written 16 books since I left Downing Street? Because I write every day. And I really do recommend, you know, the old thing about when you're facing a problem or a decision you can't quite, you know, well, write down the pros on that side and the cons on that side. We do it all the time. We make lists. Why do we make lists? Because it allows us to order our life. So yeah, it was very, very cathartic. And also it allowed me to think through my own depression in a way that actually, despite having had years of therapy and all the rest of it, I'd never really done before, in the same way of actually tracking my own life and then tracking all the things I've done since I admitted to myself I've got a real problem.
So if we suspect a family member, a question in here, a friend and or a colleague is suffering with mental health problems, what should we do? What are the signs from your perspective? I mean, you've said there, I mean, you gave some great examples, one with Tony Blair, you also mentioned previous bosses, and you've also kind of, even with the police saying, are you okay? What are the signs? Are there signs? Is it something that you've got now an antenna for, that you know, you're not a healthcare professional, but you have that lived experience and you have written extensively on this?
Well, I get a little worried sometimes because I get lots of people who write to me and people who stop me in the street and come up to me on trains, and they talk to me like almost as if I am a doctor. Now, on the one hand, I think that's good because it means that they feel that there's somebody there that they can relate to and open up to. But it's very rare that I will give them, other than very commonsensical life advice. If I sense there's a real problem, I will say, look, I really think you need to, see somebody. But what I can do is say to them, and there's no shame in that at all. And that might be a lifesaver for you. But I do think that question, are you okay? You see, if you say to people, how are you? It's the way we're programmed. If you say, how are you? We always say, we're fine. But, particularly now with the pandemic, are you okay or how are you has become a kind of existential question. So I think one of the things I talk in the book about my 1 to 10, my mood. One of the companies that I have done some work with, they're talking about, based on a talk I did there, they're talking about bringing in a thing at the company where at the start and the end of every week, they ask all of the staff to fill in a form which says how are they feeling physically and how are they feeling mentally on a scale of 1 to 10. Now, as long as the culture is such that people trust each other for it not to be held against them if they say they're feeling bad, then I think that's a great thing to do, where you can have that openness, because we are so open about our physical health, partly because often you can't hide it. If you're on chemotherapy and your hair falls out, we all know. If you've got a stinking cold and flu, and you're sweating forward and your nose is running, we know. If you've broken your ankle, we know. So I just think if we could feel that we could be open, and I think that, look, the signs that I usually, I think depressives do have an eye for each other, definitely. And it is actually, I think, it's something you see in the eyes. There's something there. There's a lack of life in there when somebody's feeling depressed. And I mean, I recognize it in myself and I recognize it in others. And when I see it, I just say, you okay?
Yeah. So a couple of kind of politics linked questions. I mean, one is asking about, you're somebody who's been in the public eye, you've been scrutinized, you've been under that sort of pressure. What effects does that have on your mental health, and how does it manifest itself in those situations? And how do you cope when you can't pull out of the public eye? Are there situations where you cannot step back, and what do you do then?
I mean, honestly, it never bothered me. The situations bothered me. So the times when I personally, I was working for Tony Blair, he was the Prime Minister. If you're the Prime Minister of the United Kingdom, you expect to be under scrutiny, you expect to be under pressure. It's kind of what you signed up for. I would get drawn into that in regular sets of circumstances but what would be worrying me would be the situation that led to that. The flack that I was getting, I mean, I was very conscious of being a lightning conductor for him. Mm-hmm. And I almost saw that as part of my job. The only time it got to me was, I describe a bit in the book where my mum, who, I mean, she's dead now, sadly, but she was very small. I mean, I'm large, okay, I'm 6'3", nearly 2 meters, and I'm pretty well built. My mother was tiny. She was this high and she had no fat on her at all. And she hated me being in the public eye. She absolutely hated it. And whenever I was under the cosh, she would literally not turn on the telly, not turn on the radio, never look at a newspaper. She found it really hard. When I thought of that, I found it hard. And I describe a conversation in the book where I went up to see her one day in the middle of one of these kind of frenzies. And Tony phoned me up and I said, listen, have a word with my mum and tell her not to worry. And so I put her on. He was very nice to her. Anyway, she ended the conversation with saying, anyway, Tony, it's been lovely talking to you, but I've got to tell you, ever since Alistair's worked for you, I've had diarrhea a lot of the time. I need to go to the loo now. So I think when it gets to your family, it's hard. But I think if you definitely develop a thick skin.
Well, there's a link between the mental health and the physical health that I wasn't quite expecting, but I think it really explains it really well. And I've got time, I think, for a couple more questions. One is, again, it's kind of in the career you had when you were in 10 Downing Street with Tony Blair. You were working with a large number of people who also were under scrutiny. Were you spotting mental health issues when you did spot mental health issues there? And if it was people who were on maybe the opposite political side, how did you react? How did you feel a need to do something about that?
That's a really good question. I mean, the only person who comes to mind, and who I've written out at length in the book, was Charles Kennedy, the leader of the Liberal Democrats, who everybody knew he had a drink problem. And I was, even though we were in different parties, I'd always been a very good friend of his. When I'm not a friend, but when I was a journalist, I had good relations with him, and I became a good friend of his over time. But actually, I did feel able to say to him, "Look, I'm really worried about you." And he felt able to open up to me, and I almost persuaded him. In fact, I did persuade him to go into a rehab place up in Scotland, where actually my son had been when he'd had problems with alcohol. And but at the last minute, he just decided he couldn't face it, for a reason which I understand. He didn't want publicity. He was worried about what his opponents would do with it. He was worried about what the media would do with it. And yeah, I'm quite good. I'm quite good at saying to people, you know, you don't seem yourself. You seem very stressed. Is there anything you want to talk about? And I now you mentioned, I actually in the last month have had 4 MPs who've got in touch with me about different things, and there've been 2 Tory, 2 Labour.
Wow. So to explain to people from outside the UK and in the wider realm, I mean, you were part of, well, Tony Blair, Prime Minister of the Labour government, and the Conservatives is now Boris Johnson. It's the opposite side of the aisle. Yeah. So I think we've got time for one last question. I think we could have gone on for a lot longer, but we're going to keep you to talk about fake news in a few minutes with another panel.
Which is not good for anybody's mental health.
No. And the last question really is, not surprisingly, about COVID-19. And there's been a sharp focus on mental health, a good thing, during COVID-19, associated with various lockdown measures and limitations placed upon us. But the financial impact still lies ahead of us. Are we about to see a huge rise in cases? What efforts should be put now to make sure that things are in place when that potentially happens?
Well, I don't have any doubt it is going to happen. In fact, I've written a chapter about this in the book, because the book was meant to come out in May, and it got delayed because of the pandemic, and eventually it came out in September. So I've written a chapter about COVID. And I've talked in there about a piece of work that's been done by an Australian university, where they've modelled suicide trends. Now, Australia has actually, compared, say, to the UK, compared to the US, compared to a lot of the European countries, has not been that hard hit by COVID. Nothing like as bad. And yet they're talking about a substantial increase in suicide as a result of the economic implications. If you add, though, if you just go through, say in the UK, 50,000 people dead, okay? A lot of those people leaving behind families who couldn't see them. A lot of those people dying, and funerals that were, you know, a couple of people who were there, people who couldn't actually grieve in the way that we normally would. The frontline workers who were working in, you know, exceptionally difficult circumstances, often without proper equipment. Kids who couldn't go to school, students who couldn't take exams, parents who were trying to work at home and raise the family. I mean, it's not difficult to see where the psychological challenges are coming. So in terms of what we can do, governments have to strategize for this. They have to look. One of the problems with the way that this pandemic has been handled is that very few governments actually look like they were putting into practice planning that had been, everybody's modeled all this stuff before, And yet it was almost like, oh, didn't you see that coming? Nobody expected that to happen. And so I think it's actually about sitting down and planning for that, planning for the worst, because then that's the only way that you can maybe prevent a lot of the worst happening. And if you think, I remember the global financial crisis, again, I say this in the book, Alan Milburn, who any Brits on the call will know, he was the Secretary of State for Health in the last Labour government. And I can remember during the global financial crisis, his constituency was in the northeast in Darlington. And I can remember he just sort of almost casually said to me, oh, I'm having to get an earlier train because virtually every journey I've made in the last month, the train's been stopped because of a body on the line. We know that happens. Economic depression. Why is it called depression? It leads to mental health crisis. So I think the answer is you've got to prepare for it.
Well, I think we've reached the end. I think you've helped us prepare a little bit more than at the start. It's been really enriching, really useful.
I enjoyed it.
Commend the book. It's a great book. People should search it out. We're really glad that you've come and joined us here at WISH 2020 online. And thank you very much. And we look forward to seeing you in a few minutes in a different conversation around fake news. So
Fantastic.
Thank you so much, Alistair Campbell,
for
being our masterclass man today.
Thank you.
Thank you.
Ladies and gentlemen, if there was ever a right time to fight fake news and misinformation, that time is now. With a global pandemic that's infected more than 50 million people and showing no signs of slowing down, it's absolutely critical that people get the right information that could save their lives. Hello, everyone from Doha. I'm Foliba Thibault. It's my great pleasure to welcome you all to this last session of the day at WISH 2020, a timely conversation on how to deal with misinformation in the fight against COVID-19. Many thanks to the World Innovation Summit 2020, World Innovation Summit for Health 2020, of course, for bringing us all together today. Now, when this year began, none of us, of course, imagined we'd be where we are today, dealing with a global health emergency of this size and this scale. But as the last few months have shown, it's not just battling the virus that's become incredibly important. It's also fighting against fake news and mis and disinformation around the world. This includes, of course, unproven so-called drugs or remedies to ward off the virus that have proven fatal in some instances. It's also about providing the correct health information to people who may not otherwise have it. The World Health Organization recently signed an agreement with the online giant Wikipedia to have its information widely available on the site in more than 70 languages. The agency says that this is part of its efforts to counter misinformation and provide people with the right tools and data to keep themselves and their families safe during this crisis. And now, as drug companies release promising results for a possible COVID-19 vaccine, we must also tackle the issue of the anti-vaccine movement and how it could impact the fight to end the pandemic. And of course, the rise of fake news didn't start with COVID-19. It's been around for some time, but its power and influence became apparent 4 or 5 years ago when the United States and the United Kingdom held crucial votes in which misinformation and fake news played a prominent role. So what these incidents related to the 2016 US election and Brexit referendum vote have shown us is the extraordinary need to build a framework and provide tools to allow us to easily filter facts from fiction when it comes to online information, especially critical messaging on global health. So how do we tackle then this pandemic of misinformation and come up with solutions to not only dispel rumors, but ensure the right message gets to those who need it? Ladies and gentlemen, and I'm sure it'll provide to be a very, very interesting discussion, prove to be a lively conversation, I should say. So let's get going. Let me introduce to you our experts who will be joining us on this panel. We have with us Ms. Alistair Campbell, who's a former Fleet Street journalist. He was a communications strategist who was also spokesman for and director of communications for former UK Prime Minister Tony Blair. Mr. Campbell has written 14 books in the last 10 years, his most recent being the current bestseller, Living Better, Learning to Survive Depression. Thank you, Mr. Campbell, for being with us. Also with us, Dr. Fiona Godley, who's been the editor of the BMJ since 2005 and is the first woman to hold that position in the prominent medical journal's 180-year history. And her team at the BMJ has been frequently called upon over recent months to counter medical myths surrounding COVID-19. Ms. Godley, thank you for being with us. Welcome. And also with us, Dr. Mihailo Popescu, Head of Research at Auspex International and former Head of Research at Cambridge Analytica, the company which, of course, was put under the spotlight for its use of social media during the high-profile political campaigns, including the US election in 2016 and the UK's Brexit referendum. Thank you all for being with us today. I look forward to hearing your thoughts on this very important topic. Let me start with you, Mr. Campbell. With hundreds of millions of people turning to social media for their news every day, rather than traditional media, do you think the fight against fake news is hopeless?
It feels hopeless a lot of the time because I think we've created societies and cultures where we believe what we want to believe. And we can find anything that to support what we already believe if we look hard enough for it. And I think that what social media has done is kind of force people into the ever narrower circles of understanding and circles of debate. And of course, what I thought would have happened when the whole kind of fake news thing started was that actually political leadership would recognize that it was a challenge to them, instead of which what we've seen is political leadership that has exploited it to their benefit. So if I felt there was one thing that had to be done to get us to a place where we could feel that there's at least some sort of playing field that we all recognize as an objective truth, which I think we all need, then it has to be to where we're in democracies to get rid of those people who have exploited this to their own ends. Donald Trump being one of the worst examples. Boris Johnson here, I think, is one of the worst examples. But of course, also it happens in dictatorships. I think Vladimir Putin has got a lot. He's had a big part in the development of this whole phenomenon.
Mm.
One of the best books about. Sorry.
It's absolutely true that normally when we in normal circumstances you would look to governments for regulation, but as we've seen recently, it's very often these same governments that have been actually relaying this fake news. So how do you deal with that?
Well, it's very hard. It's like, when you see somebody like, yesterday, Donald Trump, I won the election. He says it as a fact, and he's used the way that the media landscape has changed. He's used that to develop a backing where people will believe him. It's not just that they'll support him for saying it, they believe him. Mm-hmm. And I was talking, he said that thing famously a few years ago, and he was up against Hillary Clinton. He said, I could walk down Fifth Avenue and murder somebody and my people would still love me. Well, I was listening to a German podcast the other day, a guy called Sasha Lobo. He said it's worse than that. He could strangle a cat live on television, and while he was strangling it, he could say he really loves cats.
Right.
And his people would believe him. So I'm afraid I don't really know what the answer is to that, other than democracy getting rid of him.
Let's bring the conversation back to the COVID-19 pandemic. Dr. Fiona Godley, bad information produced intentionally or otherwise has always existed. What is unique in your view about the way misinformation and disinformation works now during the COVID-19 crisis, and what's made it so potent?
Well, I think this is absolutely a very complicated phenomenon, isn't it? And I think, as you say, the COVID pandemic has absolutely brought into high relief problems that had been around before the internet, but amplified by social media in recent decades. And the COVID pandemic has really made us all sit up and realize, because we're all impacted by what are a whole range of different, what we would consider extremely damaging behaviors. The very fact, going back to what Alistair has just said about that these behaviors are emanating at one level from the most powerful person in the world, makes the whole idea of truth sort of apparently pointless. You could think he can say what he likes and people will believe him. And some of the most gross examples have been promoting treatments that don't have the data to justify that promotion. And we've had a whole sequence of examples around that. But he's not the only person doing it. It just means he kind of legitimizes it. And some of the other things are pure just to make money, data by press release. Promotion by press release of the recent vaccines is an example of, I would say, very poor behavior that we would expect better from people who are doing such important work. And all they do by behaving like that is to legitimize other people doing the same. So I think there's a range of different things here. There's the politicization of social media. There's the use of social media for hate speak, which is perhaps in some ways the easiest thing to tackle, because we know that when we see it, whoever is being attacked. But when it comes to science, I think the real problem is that drawing a line between what is really, really kind of non-scientific, anti-scientific behavior and actual discussion, debate, nuance, uncertainty, of which there is a vast amount in medical science in particular. Drawing that line extremely hard, and I think just say early on that plans to kind of suppress or shut down that debate in order to tackle fake news in science is very potentially very dangerous, I think.
Briefly, before I move on to Dr. Popescu, what are some of the most outrageous so-called fake facts that you had to counter, Dr. Gottlieb?
Well, they come in all sorts of guises, I think. We've had thinking specifically about COVID, we've had the idea of injecting a disinfectant into your veins. That was a wonderful moment for us all. But seriously dangerous, because as Alistair said, people will do what people in
people did do it,
and people I gather did do it. But we've had people promoting hydroxychloroquine for the treatment of COVID. And doing that with very poor science. And then if you go onto the internet, you can find people who feel that science has been suppressed, when in fact it was just rather poor science, and better science has proven against the drug. You've had, as I say, people just wanting to make money and their share price rocketing in response to early release of data. I think these are all really egregious examples, and they come in many different forms. It can be medical journals who get it wrong. The Lancet's MMR article, which got taken up and has become the basis of a lot of anti-vaccine debate. That was, in a medical journal. You've got the sort of Daily Mail just exaggerating and distorting stuff. You've got the companies with their press releases. You've got President of the United States. It happens really at every level.
Right.
That's the challenge that we face.
Let me bring in Dr. Popescu to conversation. Dr. Popescu, the company you previously worked for, Cambridge Analytica, came under fire and had to file for bankruptcy after it faced multiple allegations of harvesting the private information of some 15 million fake Facebook users. And I know you joined the company just a few months before that, and that you didn't really want to go into it. But I just want to ask you about the bad actors. There are plenty of them, of course, that want to exploit the global health emergency for their economic or political gains. What are the main causes of misinformation that we should be most worried about, in your opinion? Is it the political operatives, social media algorithms, unregulated media? Which is the most harmful?
Well, Folly, I would say it's a mix of all of these that you have named, and I would love to be able to pinpoint and say, oh, these are the main villains, but I can't. I simply don't have much visibility. If I was to split or classify sources or generators of fake news, I would put them in two broad categories. One are those where the fake news have misinformation as its end goal, and this can be weaponized in for different purposes, political warfare, or destabilizing the country, or any type of hybrid conflict. We've seen we assume that these kind of fake news were propagated in the political arena in the past elections, most predominantly the ones in 2016 in the United States. On the other hand, you have fake news that don't have misinformation as its end goal. They have something else. For example, I don't know if you're aware, but in North Macedonia, there is a little place called Veles. And this is where a bunch of kids have created a fake news portal. They created a series of viral fake news about politics in 2016. And suddenly they had a massive stream of traffic on their website. As soon as you have a massive traffic, the Google switches on Google Ads, so does the revenue comes in. So these two guys, they didn't have any other agenda but to generate pocket money for themselves. There was plenty of pocket money. On the payday, they would go out and they would treat the entire village, with drinks and foods in the restaurant. And these kids, they didn't have any political agenda. As soon as the elections in United States ended, they found a new topic, and these were football transfers. So they were talking about, prominent football players having a severe injury, being out of the pitch for, months, et cetera, again, driving the traffic in order to gain profit from it.
So would you say that was a successful fake news campaign then?
Obviously, it was a successful fake news campaign, but I need to stress here that misinformation causes real harm to people's lives, to health, to finance, and democracy. And this pandemic, appeared to be a fertile soil for spreading fake news and misinformation. People stayed in home. The internet usage surged. People went online on social media more often and longer than they usually did. And obviously, the doors were open, for misinformation and fake news. When people are anxious and apprehensive, this is already an open door for highly emotional fake news, to put the foot in and really, get the best of us.
Alistair Campbell, when would you say things took a significant turn for the worse? What laid the way for the alternative facts and fake news that we're experiencing today?
I'll tell you one moment when I realized that it was being used as an act of actual strategy. I think you've always had people who've had difficulty telling the truth. You've always had, you know, don't forget, we've all had newspapers that, you know, frankly, a lot of newspapers, their business model is to kind of, you know, Fiona used the word exaggerate, but I think often it's gone beyond that. If the story is a good story, let's not worry too much about whether it's true. There's always been an element of that. But I'll tell you the moment when I thought, my God, this really is now a problem and I don't understand how we're going to deal with it, was actually Donald Trump's inauguration, when there was pictorial evidence and there was evidence from the transportation data in Washington, D.C., that there had been more people at Barack Obama's inauguration than at Donald Trump. And when Kellyanne Conway was challenged about Trump saying that there were more people at his than there were at Obama's, and the journalist was saying, but we have the pictures, and she said, you're going to have to get used to being dealt alternative facts. That was an act of strategy.
That's interesting, because some people would say, Alistair Campbell, that it's the spin doctors, you were a spin doctor once, that it's also, you know, the big business who paved the way for these so-called alternative facts and the way things are treated right now. What do you respond to that? The spin doctors, is it their fault?
No, because you see, the thing about, for me, what a spin, I don't even know anymore what a spin doctor is meant to mean. What I like to think that we did, my job was to support a prime minister in the communication of an agenda that he had for the country. And that's what we were trying to do. And if you go back, you know, some of the best spin doctoring, yeah, I was once asked, what's your favorite soundbite of all time? And I said it was Veni Vidi Vici. Right? I saw, I conquered. That's back, you know, we're talking centuries ago. Some of the best strategic communication is in the Bible. The 10 Commandments is one of the best pieces of communication there's ever been. So I don't accept that. I think that I certainly accept that in politics and in government and in campaigning, you push really, really hard against your opponents. You try to define a certain way, and sometimes the truth, you know, can get lost. I accept that, but I don't accept that we lied. What I see with Trump is somebody who lies as an act of strategy. And I think that I mentioned Putin. I think it's really interesting in Russia. There's a great book written about Russia called Nothing is True and Everything is Possible. Nothing is true and everything is possible. When as an act of strategy, you try to persuade people that there's nothing they can believe other than that they want to believe from the voices that they want to believe it from, then the world has a problem. And that's where we are now.
In the US, Fiona, we've seen President Trump, as we've said, contradict his own health experts like Dr. Anthony Fauci. Whose responsibility should it be to ensure that the public gets the right information about the pandemic?
Well, it's been very painful watching that. You know, Donald Trump's medical advisor standing beside, and not somehow you felt that in the right world they would have stepped forward and said, actually, Mr. President, you're talking a load of very dangerous rubbish. And you know, you likewise to some extent, perhaps in other countries, the UK, you know, we've watched the advisors of government, you know, I think being more silent than we would like. So all of those are kind of variations on a failure to stand up for truth at times. And I guess that in terms of whose responsibility is, each of us individually has to stand up to our own truth. But as professional groups and as you know, scientists, medics, whatever your role, I think that despite agreeing with Alistair and I think Mike about the huge complexity and difficulty, that this is it's an inconquerable problem in some ways. Each of us in our own role has to continue the fight because we can't relinquish the ground. And that means, you know, it is important to have the fact checking. You know, at the end of that terrible speech from President Trump, where he, you know, came on after Biden had been declared in the second day, I think it was, and he just a vast number of untruths. And I think the fact checking of that speech was really important, and people need to continue to do that work. I think it's right to hold accountable people like Anthony Fauci, who I think has done a fantastic job under extraordinarily difficult circumstances, and hasn't done it by laying out blame. He's done it by just continuing to speak his own truth. And I think, I have huge admiration for him. So I think each of us has to continue to do that. We have to keep educating those around us, especially the young, how to appraise evidence, how to make a rational argument, how to deal with uncertainty. We have to invest in and support really good journalism so that there are people who are actually actively presenting challenge and checking the facts for us. I mean, the whole host of things that make up that continued fight against untruth. I mean, there is no ultimate truth, but there are facts. There are facts. So, and there's rational argument around those facts. I think we've sort of lost the art of, as Alistair said, we're all penned in now in our very narrow sort of echo chambers created by social media, and we have to try to broaden that discussion and really, really teach and encourage rational argument.
Right. Dr. Popescu, Dr. Fiona Godley mentioned social media there. I mean, once again, online platforms are being used as a main tools for disinformation and consumer hoaxes. But we can't blame online platforms alone, can we?
We can't blame the online platforms. It's the medium that is actually used to spread the misinformation. However, that platform has partial responsibility about controlling and enabling mechanisms that are doing fact checking. What we know from behavioral science is that people are most susceptible to trust news and trust misinformation in an online environment. And there are multiple reasons why that happens. Once we're in an online environment and once we scroll down, the threads of the news or browse through the wall, there is loads of information, and we don't sufficiently invest ourselves in number one, checking the source of the information, and second thing, checking the truthfulness of the statement or truthfulness of the content. If you, for example, add an image to a headline, it is several times more likely to be trusted than just having text. So there are different mechanisms how we actually start trusting the misinformation, and these mechanisms are simple. And they're actually playing on our cognitive biases. So number thing is there is something that is called belief built by repetition, and it's nothing new. Goebbels once said that 1,000 times repeated lie becomes a truth. So this also happens in online environment where misinformation is repeatedly displayed. People start believing that it is true. Second thing, if it's written in a plain language and if we can quickly process it, we're more likely to hold it as a fact. And finally, there is something called motivated reasoning. And this tells basically that, our own paradigms and worldviews are actually picking on what we are going to believe. And even in cases when the evidence is shown that we were wrong, sometimes we struggle to really reject our false beliefs.
So what is the best way then, do you think, Dr. Popescu, to fight and to tackle this misinformation and disinformation as well?
So first, we have to acknowledge that, most of us living today and probably watching this session were born before the internet has been launched. Okay. And very few of us actually had some kind of subjects in the school or at the universities about media literacy or, let's say, critical reading and understanding of the text. So first and the foremost, we have to educate people. We know the science shows us that in particular susceptible to misinformation are generally older people as well as people with lower education. The younger, on the other hand, have more chances to be educated in the school and taught about how to read and approach this use. So they better handle their information, but they're more likely to spread misinformation. So that's one thing. Education is the key. Second thing that I believe is going to help us tackle this is actually enforcing tech giants to label and prevent fake news spread. They started recently doing so, and we've seen that the European Commission has called tech giants to really, step up and really face this challenge. Finally, we as consumers of the news, we have to call up those news and headlines that we as consumers see that they are misleading. The evidence, again, scientific evidence shows that only 1 in 2 will actually, call up misinformation when they see it. So half of the people just decide to ignore and pass by something that's untrue and that's sitting there on social media.
That's interesting. Alistair Campbell, I want to talk to you about the issue of free speech. As we know, tackling misinformation is a very delicate dance between accurate information and free speech. And many countries, including China, Egypt, Malaysia, have brought in legislation to control what they consider fake news, and nearly all of them have been accused of committing excesses. So what do you see as the critical points of tensions when it comes to free speech and the battle against misinformation, and what should be done to resolve these tensions?
Well, look, when you're talking about dictatorships where people are locked up for who they are and what they believe and what they say, that is something which the rest of the world should be alarmed about and should be united in campaigning against. Instead of which, what we have on the extremes of our politics, we have people who claim the mantle of free speech is being used against them. So I'm amazed, for example, how the people who are never off our television screens in the UK, particularly on the right, constantly saying that they're not allowed to say what they think. They never stop saying what they think. So actually, we do have free speech, but what we have is the exploitation of free speech as a political tool being used against. I mean, to give you one example, I don't even know what the word woke means. That's become the new thing, that if you're not allowed to say something, it's because of this woke agenda, this woke liberal agenda against you. So I think that what that is doing is minimizing the battle for free speech, where free speech really is being outlawed, where free speech really isn't being allowed. So, I think that I agree with Michael about we have to call this out more than we do. And the trouble is, we've already, people are leading busy lives, and it's like, I don't want to spend all my life going through social media. I don't want to spend all my life worrying about some right-wing crank is saying on American radio. I want to kind of get on with my life, but the noise around us is now so loud that I feel that we do. I think Fiona and Michael are saying it in a different way. They're saying the same thing. We all actually, if we worry about what sort of society we're living in, we're actually going to have to embrace this as a duty, actually to challenge what is being said about the world around us on social media and in the mainstream media all of the time. And it's bloody exhausting. But if we don't do it, and if we don't have the organizations who will do it, I saw somebody was appealing for a fundraiser to hire some journalists. And on the one hand, I thought, yeah, I can see why. But the point they were making was that most of the big media, and whether you're talking about, Google, Apple, Facebook, Amazon, etc., they're the big powers. But then when you talk about television and big newspapers, they are run in the main by right-wing billionaires, certainly in our country. Okay, how do you challenge that?
Right.
You challenge that by giving a bit of support to the little guy who's trying to stand up against it.
Dr. Godbee, over the course of the pandemic, different social media companies have made a number of changes to their policies to try and tackle this, fake news and harmful and misleading information. We've seen Twitter and Facebook label misleading tweets by President Trump, for instance, or even remove them. And yet, when you speak to Americans, 28% of them believe that Bill Gates wants to use the COVID-19 vaccine to implant microchips in people. So, first of all, do you see an achievement of an effective vaccine being undermined by this? And, what else could be done? I mean, social media companies, of course, are trying to do something about it, but what else should be done?
Well, I absolutely see this as a threat to a successful vaccination program around the world. And, you know, we've seen the rise in certain infectious diseases because vaccination has become so you know, subject to people's fears, and that those fears have been played upon by a whole range of different groups. I mean, not only people who have a kind of you know, academic medical view that vaccines may be harmful, but also, as we've discovered, you know, Russian bots who want to just destabilize and have decided that anti-vaccine is a mechanism for just spreading doubt and putting, you know, fear in people's lives. So I think it's a huge issue. I go back, I think, to my point that suppression isn't the answer. I think it's a good thing that the social media platforms are on notice and, you know, can invest some of their vast wealth back into trying to make these platforms, you know, less propagating of really untruthful and misleading and damaging information. But I think also we have to sort of, picking up on the thing that Mike said, is it's not as if those groups, the groups spreading this stuff, have all the tools. Those tools are just as available to those wanting to present truth. And I think we don't necessarily make the most use of them. The point you've made, Mike, about pictures, about repeated messages, about clarity. In a podcast I was on this morning, someone mentioned that the German government's approach to encouraging public health measures, and just as a really good example of how to get it right. And, you know, we don't always do that, in fact rarely get that right. So I think there's a lot of skills that we, if we consider ourselves to be on the side of the angels, need to learn and adopt and make use of widely in order to continue the good fight against these things, because fight against it we must.
All right, we'll pause and we'll take some questions from our audience now. So quite a few questions coming in. Let me put this first one to you, Mr. Alistair Campbell. The term fake news was popularized by Donald Trump. Do you think this concept and that term will naturally regress when he leaves office?
I'd like to think it would, but I don't think so. Sorry, my light has just gone out.
It's fine. We can still see you. That's the most important.
I don't think it will, because I think it's a phenomenon that's too deep. He did it very deliberately right at the start. If you remember anything that anybody said that he didn't like, he just said it was fake news. And it's this business of saying, unless it's something that I'm saying to you, unless it's something that's to my benefit, it is not true. I think Biden winning is a huge step forward. I think Biden on the health front saying we're going to get back to listening to science is a huge step forward. But I think that you'll find other actors will come in. I mean, look what's happened in Brazil with Bolsonaro. He's done the same thing. How other actors use this in future elections, I think will be jury out on whether this is going to lead to a big change. I fear it might not.
All right, so fake news, the term at least is here to stay in your view. Dr. Popescu, another question here from our audience. Do you think social media has put profits before truth? Many feel that they do not do enough to stop inflammatory or obviously untrue stories. Shouldn't they fact check? A question from someone who's watching this online.
Thank you. That is a very interesting question. I would say that technology is exponential and humans are not. And, you know, when we build an innovation and when we deploy this innovation, we create a new complexity and we don't know how this complexity is going to pan out. So I truly believe that all social media were built with something positive in mind. And the way how we use this technology, you know, I can start selling Hummers and you can use Hummer to fix something, but you can also use Hummer to you know, smash someone's head. You know, I didn't produce this Hummer for people to go around and smash things. So I don't think that, you know, spreading of misinformation was the purpose of the social media. They do have responsibility of controlling what gets spread on social media. Obviously, something that is against the morals, something that is you know, against ethics, something that is racial, of course, should be banned. And obviously there are policies that are banning propagation of such content. More recently, we've seen the surge of misinformation and fake news. And obviously, there is always a time lag until, those platforms and companies and social media pick up on this issue, understand how it works, and then start implementing some measures to either prevent, control, or label this. So I would say ultimately, I don't think anyone had this bad option at the beginning, at the start of building these social media platforms. But as I said, innovation and technology always comes first, and then academia and law follows. And there is always this time lag when you have people who are taking advantage of the vacuum, and do certain things that are harmful.
But can I just jump in there? That is why it's so alarming that you have in Britain a prime minister who has said he's prepared to break the law, and you have in America a president who is not abiding by any of the norms of the transition of power. So that's why I find this so scary about what's happening at the moment. I completely agree that normally you would have these other parts of the system, if you like, and academia and law, definitely part of them, big important parts, who then come in and analyze something. But if you've got the technology companies who, it strikes me of maybe, I agree that they didn't necessarily set out to go around smashing people's heads open with hammers, but while their heads are being smashed open, they sort of sit there saying, well, there's nothing much we can do now. We will just carry on being nice to each other and trying to.
There's nothing much that anyone can do, then, what hope do we have? Who do we turn to?
I agree with you fully. I think that with great power comes great responsibility. Obviously, social media platforms nowadays have massive power, and they are the ones who are very responsible, to the societies and communities using those platforms. But we as users have also we need to come to a realization that these platforms are apparently free to use, okay? And we need to wonder, how come I could use this platform free of charge? How is this platform making the money? Am I being a commodity? Of course I am. We are being sold, as audience. If you went to a supermarket tomorrow and you brought a basket of, groceries to the, till, and they said, oh, just pass by, that's fine. You'll say, like, is someone crazy? What's going on? I should be paying for these services. We need to understand that social media are having massive infrastructure behind themselves. For example, Facebook, their data warehouse center, the size of 10 football stadiums. Imagine the utility bill, the electricity bill just to run those servers is massive. So how are they making the money? Obviously, they're selling us as audiences. So in that respect, there is some kind of conflicting interest. The social media needs to keep us selling as the audience to make sufficient profit. But in the same time, if they don't prevent, misinformation and fake news spreading, this can come back to them as boomerang. And obviously it's coming. People are realizing that, big portion of responsibility is down to social media. But I'm saying, we are not innocent neither. We as users have to realize that, it is our responsibility to think about, our role in all this, ecosystem.
Users indeed have a role and responsibility. Dr. Godley, let me put this final audience question to you. With such a divided world right now, how do we encourage people to consider views from the other side and to reflect on their own preconceptions? This is going to be vital when a vaccine is rolled out.
Well, I think that's absolutely right. This gets back to the point about helping people to, trying to find ways that people will acknowledge uncertainty, nuance, and be able to live within that and discuss alternate views. I mean, at its core, we have to deal with education, of the young, but as Michael's been said, in fact, it's often the older groups who find this more difficult and become more easily sort of sectioned off into specific, very hardened attitudes. So I think it's going to be extremely difficult. I agree with what's been said about the need for the social media platforms to take responsibility. And I think they are making sufficiently vast profits for us to demand that. I think the election of Joe Biden is an important event, a crucial event, because we may now see politicians and therefore lawmakers stepping up and saying this needs to happen, and those vested interests that are so much keeping the current status quo in place will be challenged if we have people of that sort in government. In the UK, we haven't got that sort of government yet. I'm not making a party political point here, but it's certainly one where behaviours of certain high politicians in power have fallen below what we would like, and we need to hold those politicians to account. So there's a whole host of things, but I think in the end it's that combination of the politicians, the legislature, the social media platforms, and us as individuals, and real courage to those people who do put their heads above the parapet, who really put their really work to try to battle against the untruths and misinformation, and I think they are the real heroes of the moment.
All right, let's try and end this on a hopeful note and not doom and gloom. Alistair Campbell, your last word. What if anything gives you the most hope in the fight against fake news and misinformation? Is there anything that gives you a bit of hope?
I think so. It relates to something Michael said earlier. I do think that younger people are kind of onto this in a way that maybe we're not. And I think that I thought what was one of the most extraordinary things of when Zuckerberg was at the Senate, the Committee of American Representatives, and it really was like watching a generation gap on display. I think there will be enough innovation at the young end of the market to give me hope that it will dawn on our generation that we have helped create an absolute monster. And I look at my generation and I think they're on it. I hope they're on it. But that is hope rather than expectation. I'm not confident.
You're not confident?
I'm not really confident, no. I think we're in a real mess. I think in the end, politics is going to have to take the lead on this, and that means getting rid of bad governments.
All right. Dr. Popescu, are you a bit more confident than Alistair Campbell?
Well, I have to admit I'm always an optimist, and I would say with the rise of education, more and more people will be able to recognize fake news and fall, less likely to fall prey to the fake news. So I'm hopeful in that respect.
And Dr. Godley, you have the last word. What gives you hope? Are you confident? Are you hopeful that this fight against fake news can, if not be won, at least can be advanced?
I think the realistic answer is we are in a mess. I think we've got real challenges ahead. I do tend towards optimism, and I do tend to think that the answer lies in the young. And I think what's been said about holding politicians to account, making them realise that they do set the global tone. We have to tackle bad government and misinformation that they encourage.
All right. Thank you to all three of you for a very lively and interesting discussion. Of course, we could have gone on. There's so much to talk about. Thank you very much. Thank you to our online audience as well for watching and taking part in this important discussion, fake news and the COVID-19 pandemic. And of course, we'll be talking about this, I'm sure, in the next few months when, a vaccine becomes available and is distributed. And of course, to the whole Wish 2020 team and the Qatar Foundation and all of its partners, thank you for bringing us all together for this very special virtual Wish 2020 Summit. For more on this and other sessions at Wish 2020, please visit 2020.wish.org.qa, and don't forget to join us tomorrow, Wednesday, for another full day of sessions at Wish 2020. Thank you very much for watching. I'm Foliba Thibault in Doha, wishing you a very good evening.
It's shortly after 9 p.m. in Doha. Hello from the newsroom of Northwestern University in Qatar. Wherever you are in the world, wherever you're watching from, welcome to the Agora, the final live session of day 3 of Wish 2020. Everyone's gone home. You just heard Folly say goodnight. So we've been left alone here to make mischief. If you're watching this, it essentially means you're one of the cool kids. So what is the Wish Agora? The Wish Agoras are based on gatherings held at ancient Greek assembly places where communities would gather to share news and exchange views. Introduced at Wish 2018, this year we've moved our Agora conversations online because, well, 2020. I'm Nick Bradshaw, Director of Outreach at Wish, and I'll be moderating today's session, which I hope will be both informal and engaging, and which posits the question, how did we let the wearing of masks become political? For decades, centuries, surgical masks have been worn by healthcare professionals around the world. In countries like Japan and Singapore, it's standard to wear a mask in public if you feel unwell and you think you're at risk of spreading disease. This year, as the novel coronavirus spread around the globe, more and more public health bodies advised that the wearing of masks to stop the spread of COVID-19, with the WHO joining calls to mask up in public in areas where social distancing isn't possible in June, having previously argued that there was not enough evidence to say that healthy people should mask up. But now, not everybody agrees with this. Not everyone agrees that it's the right thing to do. In some parts of the world, not wearing a mask has become a political statement as well as a public health issue. With me tonight is Professor Ivo Velev, a member of the Behavioural Science Group at Warwick's Business School over in the UK. Ivo is an expert on not just the way we behave, but also how we can be nudged into behaving differently. Shortly, we'll also be joined by a panel of 12 members of the Wish community, who I'll bring into the conversation in a few minutes. But first, I'd like to speak to you, Ivo, to help us get an overview of the topic we're discussing tonight. When it comes to wearing masks, why do some people comply but others don't? How has it become the case where in most parts of the world, many parts of the world at least, that what appears to be a personal aspect to our response to COVID-19 has actually kind of turned into a mass response, often one that's politically driven?
Well, luckily, we can answer this question by getting some data from the Imperial College London COVID Behaviour Tracker, which has been conducted for a few months now. This is the largest COVID health behaviour survey study of its kind in the world. To date, we have more than 400,000 participants in 29 countries with 42 million data points on behavioural, social demographics, comorbid chronic conditions and self-reported symptoms and so on. Thanks to YouGov, they provided the data for free. And the tracker now has shaped the way that both World Health Authorities and World Economic Authorities track and model COVID consequences. So what have you learned from this tracker? You can find it online, but just give you in a nutshell, the summary points. We show willingness to improve our behaviors, but our actions don't always match up. For compliance, law persuades more than messaging on key behaviors. So legal consequences are really crucial around the world. About our response to COVID being politically driven, the tracker shows trusting government and trusting health authorities is associated with health protective behavior, such as wearing a mask. And what we also learned from the survey is that COVID-19 is global, but one-size-fits-all solutions doesn't work. The global pandemic has highlighted national and cultural differences in responses.
What's the impact of people wearing masks on other measures being recommended by public health authorities? I mean, I'm thinking things like social distancing. I know that you've been involved in some research around that.
Well, what we find from the survey again is there is large regional variations in this. So how frequently Europeans report carrying out protective behaviors. For example, the most adhered to preventive measure is hand washing, but there is a large variation in Europe. The most striking example, with 4% in Sweden report wearing a mask compared to 96% in Spain. In some countries, there's a correlation between health protective behavior, including mask wearing and other behaviors. For example, take Spain, mask wearing is correlates with washing hands and keeping social distance. In other countries like Sweden and Norway, hand washing is adhered to, but not mask wearing. There's a wide discrepancy between these two different types of countries in terms of who wears mask and whether mask is also correlated with other behaviors such as hand washing. Quite interesting study that we conducted at Warwick about the impact of face mask on social distancing. So wearing masks can actually adversely affect attitudes towards social distancing, our study shows. We found out that participants prepared to stand closer to others while wearing a face mask, and they also would like to stand closer to other people who wore masks. And those who felt a greater risk are likely to maintain a greater distance. So in this case, those who believed face masks are effective at preventing the spread of COVID-19 were more likely to relax the distance if they or the other person were also wearing a mask. So our results could be particularly relevant for countries where mask usage is now low, but social distancing guidelines have been relaxed. If countries need to return to a greater level of physical distancing due to a second wave of cases, that may be harder to implement mask wearing and social distance, respectively, than it was when mask use was low at the start of the pandemic. So our finding appears to be a classic case of risk compensation, in which decreased risk from one intervention, for example, you wear a mask, you feel more protected, and you see other person being more protected, is accompanied by increased risk from another behavior, such as you decrease the social distance between you and the other person. So risk compensation in general occurs when people respond to a perceived reduction in risk brought about by safety intervention, for example, better car brakes, by increasing the riskiness of other related behaviors. For example, you drive faster. So this is really important for messaging. And from a psychological perspective, the theory is that people have an optimal level of risk they can bear. So if an intervention reduces overall risk, for example, wearing a mask, people will take other risks until they return to this tolerated risk level. So we need to be careful about the side effects of actually wearing a mask on social distancing.
Fascinating. So maybe the whole thing, I mean, we'll definitely get into this, but the idea that when you wear a mask, you think that it's almost like a magic shield and therefore you're going to be okay. And I think we'll definitely come back to that. But as an expert in behavioral science, how would you persuade people who now see mask wearing as a political choice, a choice that's kind of intrinsically linked to their liberty? How do you persuade them to wear a mask?
Well, a choice that is intrinsically linked to one's liberty has been the dilemma whether to smoke, especially in public places. So we have lessons learned on this topic, which boil down to first introduce law or government advice, then establish social norms. So the Imperial College London COVID Behavioural Tracker showed us that the single biggest influence across all reasons of face mask wearing appears to be the law. This is well illustrated by the inflection point in the UK when compulsory mask wearing was announced. There is also clear age effect. In Europe and North America, compliance increases with age. We have observed that younger people are actually less likely to comply. Not personally having symptoms is a top reason for not wearing a mask, as is lack of belief in mask efficacy. Asian countries are the most face mask compliant. Numbers exceed 50%, for example, in every category. Europeans are more affected by than North American peer pressure. Others not wearing a mask, other people thinking they would have it, for example. In contrast, North Americans, however, are far more likely to question the value of wearing a mask. So for them, we need to stress public health messaging about the effectiveness of masks, about perceived susceptibility to COVID infection and perceived severity of COVID symptoms. What we found, however, from the first wave of COVID is that protect yourself messages will have limited impact for the general public because many consider themselves at low risk. They're overconfident. They underestimate the risk to themselves from COVID-19 infection, and they're likely to be persuaded otherwise. Of course, this might be different for those with specific vulnerabilities who are asked to shield themselves for extended periods of time. So in general, there are do's and don'ts that the government should follow in this respect, which I'm happy to share. In order to, the key here is to motivate and to enable. Think about what information people need and how to motivate them and how to ensure they can make the change, in this case, wearing a mask. And so to motivate, for example, the government needs to stress how desired behaviors protect the most vulnerable, including those we love. We have to present powerful images and the actual voices of those we need to protect, loved ones, the vulnerable. And we should not show that often a minority of people are doing the undesirable thing. For example, not wearing a mask, which only reinforces the wrong social norm. And we need to communicate how our sense of self is rooted in membership of families and neighborhoods and communities. Protect each other messages are promising in this case because they build on promoting our collective identity. For example, fellow Londoners, members of our local community, and so on. And wearing face masks outside of the house could complement existing government messaging of social responsibility if communicated alongside the effectiveness of masks in protecting others who are not infected. And well, wearing face masks could demonstrate that an individual is concerned for other people's welfare and is enacting desired social norms around safety and hygiene. And the second component, I'm finishing here, to enable the public, which is the second biggest pillar of successful behavioral change, we should not give vague advice or suggestions. Be precise, give precise about what behavior is needed and present examples of what following the advice or not following the advice looks like. So tell people that what support is available to help them adhere with face mask wear and so on. And we need to recommend that the public wears face masks in the community and what could go wrong with wearing a face mask, what guidelines are available and what is the rationale. We need to educate and train the public in terms of when and how people should wear masks and when and how to dispose the mask, any risk associated with their use and such practical things.
Great, thank you. Plenty of food for thought there. Thank you, Ivo. So we've heard from our experts. Now let's hear from our panel. So welcome to our jury of 12 upstanding members of the WISH community. I think we might even have 13 tonight, we're very lucky, who tonight are actually sitting down and being forced to stare into their laptop cameras. If I could ask you all to raise your hand if you have something to say, either a comment or a question for our expert, Ivo. And if I could ask you to be brief so that we can hear as many viewpoints as possible, and don't forget to unmute your mic before speaking. So, panel, do I see any hands? If I don't see any hands, I'm going to start coming to people directly. There we go. I see a hand in the middle. I recognize the first face there. I see a few hands now. You see now everybody's keen to join in. Person in the middle who I do actually recognize, the 13th person who's our interloper, Sulfa. I should know your name by now. Sultana Afdal, my boss. So she's the CEO of WISH. Sultana.
Hi, Ivo. So my question harks to the political divide when it comes to the wearing of masks. I will put it, focus on America because it's an easy case for me to, cite. So with over 60% of Democrats believing that a mask should be worn and less than 20% of Republicans believing the same, a YouGov recent poll, a CBS YouGov recent poll also cited that 57% of Republicans believed that the deaths from COVID were at an acceptable level, whereas less than 10% of Democrats thought the same. So when it comes to the wearing of masks, I can more or less understand the political divide would be with the messenger, but when it comes to deaths, I'm quite confused as to why they're not persuaded more by medical evidence than political persuasiveness. So that's where my question is. When you look at it from a behavioral insight perspective, how has that medical advice been superseded by political political parties, basically? So if you're a Democrat and you believe a certain thing, has behavioral insight not been able to, I really just want to see, I suppose I'm not phrasing this question very well.
Yeah.
Why is it that medical advice doesn't supersede partisan political divides, I suppose?
Well, I mean, the key finding from
Thanks,
the
Sultana.
survey.
Ivo?
Thank you very much. Thank you, Sultana. It's actually a very good question about why the communication about the benefits of wearing masks, about the epidemiology around COVID is not penetrating the specific political group that we are discussing, the one that you mentioned, the right-wing MS society. So what we found from the survey, and I've seen that again and again in other COVID-related behaviors, is that response to all this messaging from government, from health authorities, is actually contingent on trusting government and trust in health authorities. If people don't trust the authorities, they wouldn't listen to the advice. And what we found with COVID-19, there's a lot of conspirative thinking going on in specific community. The infogenics, which is spreading around false messaging and false stories. As you know, the information pandemic is quite prominent, especially these kind of groups I found from the research from WHO and others. So basically, if there is a explanation behind, if these people have a specific reason to not to believe these messages, for example, because of other explanation why the government is sending these messages, for example, to suppress us and to oppress us, and because of hidden agenda that the government might have, which these communities might believe, then they wouldn't trust the message, they wouldn't follow the advice. And that is not only actually related to face mask wearing, it's also related to social distancing and staying at home, which we see now in other countries as well. Trusting government and trusting the health authorities is the key variable explaining these behaviors. And the Republican Party, I'm not sure some members of it actually are helping in this respect, who explicitly communicate to the public not to trust the media and health authorities.
Thanks, Ivo. So I actually want to go, I think, you mentioned there the US. Do we have anybody on the panel who's in America at the moment? Do we have anybody in the US? We do. There's a hand. So as somebody who's in the US at the moment, you, I think, have been in the thick of this politicization of mask wearing. What's it like from your perspective over there? What are you seeing? The way things have developed over the last year, leading up to the election, of course.
Absolutely. It's been very divisive. It has become a political issue, and it's become a political issue because of the leadership. So when you have the leadership of the country make it political, it does become political. And I think the question goes to, well, why did the leadership, why did the president make it a political issue? And is it an issue of masculinity? Is it an issue of maybe downplaying actually the severity of the virus, you know, when he compared it to the flu? Is it an issue of having people focus on other things and not drawing their attention to the pandemic? I mean, there could be so many different reasons why the leadership or, you know, the president decided to kind of take that stance when it came to wearing or not wearing a mask. I think also at the very beginning of this pandemic, there was a lot of messaging issues that happened. Wear a mask, don't wear a mask. There's not enough, protective gear for our healthcare workers. It only protects people that are from getting a virus. It doesn't protect yourself. And so a lot of that mixed messaging also led to the distrust that people felt from what we were hearing as people. It also became extremely related to the campaigns of these two individuals. Joe Biden made a very big effort to make sure that he is wearing a mask. He's always seen campaigning with a mask. The Democrats are promoting kind of the use of protective gear, whereas the opposite, happened with the Republican Party. If you watch the news right now, even daily, the local news will show you people in the hospital coming off of ventilators, still believing that some of this is a hoax. And the healthcare providers are boggled by it. They're saying, how can somebody be sick with the virus and still not believe that the virus exists. So, I think misinformation, the politicizing by the two candidates, the pandemic happening during a campaign year, the president and the way that he took kind of a stance at approaching the pandemic have all really impacted the public's kind of digestion of this, the mask wearing and to wear or not to wear a mask.
Mm-hmm. So thanks for that perspective, because I think the other side, if we look at what's happened in the US, and obviously led by President Trump, the other side of things, I suppose, is the WHO perspective. And even there, though, it wasn't. I think it was early June when the WHO said that it was the right thing to do to wear a mask. Does anybody think here that was an issue, that they were right to wait, or they could, because I know it was based on evidence that's why they said they were going to wait? I see Ramadan. Do you have any thoughts on this, or anything else you want to bring in? I don't want to kind of put you into a corner.
Yeah. Hi, my name is Ramadan. I run my own. I call it a think tank that mostly work with decision makers and policy makers around global health, global development, especially in the line of innovation. And of course, WISH is a partner and a family for me, that we've been, working on different issues. I have done work with WHO, but I can't speak on their behalf. I don't work for them. I think I have a few observations. Maybe I'll throw a question at the end of it. I think the issue with masks has been, the whole COVID-19 has been heavily infected with the fact that in 2020, average individual, whether they live in the most far part of Asia or in Africa or in Europe or US, are mostly influenced with social media. And I think this has been a little bit of a platform that the policymakers were not prepared, how fast this social media would affect the opinion and develop a certain understanding, even among professionals. What shocked me, I work with, like I mentioned before, with a lot of global health organization, and some medical doctors reach out to me as late as in June and ask me if there is a hoax and this is just a process to do this vaccine with every individual to digitally control them and all of it. Medical doctors asking this question. And referring to some stuff he saw in WhatsApp and in the social media. To the conclusion on the side, or the question I would probably throw here at the panel, is how much the policymakers have to come down to understand the impact of social media and more or less partner with this platform. I know there is a lot of effort right now happening with Facebook, with WhatsApp and others, and WHO even engaging with them to try to somehow control those fake news and feed into kind of as accurate as possible, the issues around, how accurate the mask prevent you from, getting infected or infect others. But still, it's so far away from being, I would say, trusted platform, so forth. So the question is, what could be done in social behavior among individuals, among community, but also policymakers who could work with with countries and so forth. On the issue of the hesitation around wearing the mask, I think there has been some confusion. There is an issue around whether this is a respiratory infection or not. It would go through the just engaging with people who are nearby 6 feet away from you or not. But frankly speaking, I think that hesitation has been, I would say, extremely affected, what we see right now and where things are going. I don't want to blame certain organization, but there has been no collective voice in trying to clear this at the very early stage.
Mm-hmm. So, I mean, does anybody, thanks Ramadan, does anybody in the panel feel that they've been affected by social media, that they, or rather, is there anybody there who isn't somebody who believes that masks are a good thing to do, wearing masks are a good thing to do? Is there anybody who would say that? Who would? Oh, somebody there. Hector, please. Do unmute yourself and speak. Hector.
Hello. Hi, my name is Ekta. Masks, I feel, are a very simple thing, just a piece of a cloth that has two stretchy bands at the end. Just put it on your mouth to cover your nose and mouth. Although experts have highlighted many times that wearing mask is mandatory in areas where social distancing is not possible, still people are not ready to wear masks. They are ready to risk their lives. What I feel is, to a great extent, the onus lies with the health experts who did not highlight the importance of wearing masks at the right time, when the pandemic began. So if it would have been highlighted at that time, people would have been more aware and they would have taken it more seriously.
Thank you. Thanks for your opinion, Hector. Appreciate that. And a very brief answer, which is great. So, gentleman there with wearing a jacket and a white shirt, very well dressed. Just raise your hand if you, yes, if you want to speak. Unmute yourself, please. Yes, unmute yourself.
Go ahead.
My name is Dr. Mazen Shtawi. I'm a director of women's services at Al Ahli Hospital. I want to touch upon a point raised by Ivo about human behavior and trust in government. While we believe in strong health systems in high-income countries, I think the trust between the people and the governments in some low and middle income countries, the trust has been broken. So there has been no trust. And that sometimes led politicians to cover for their failures or to cover for a bad economy, that they do not want to send clear messages about the importance of wearing masks. So at the beginning of the pandemics, many countries were not prepared for a statement to say everyone should wear masks, either because of lack of resources or either because of inability to get hold of some masks. And that kickstart sort of made many people to be lax about wearing masks. Now, if you look at the people from the other hand, I see some abnormal behavior in terms of some people are wearing masks because of the law and because they have to do it, while in fact they're not wearing masks. They are wearing like half masks, covering their chins, leaving their mouth and their nose open, and I think that is really abnormal. And the last point is, I see it more and more. People at the beginning of the pandemic, some of them were very stringent, religiously wearing masks all the time, expensive ones, and now they're feeling fed up. They say, okay, I'm fed up, I just wanted to relax about it. So, Ivo, what do you think about that?
Well, as I said before, we need to do two things as government when we're trying to persuade people. One is to enable them. The second is to actually motivate them to do what we ask them to do, in this case, wearing a mask. And when we're talking about enabling, it's about communicating the right instructions, how to actually wear the masks in the appropriate ways. So it's like improving their capability to execute the behavior. When it comes to motivation, messages should link to the sense of duty, solidarity, and inclusion. And we also should communicate messages coming from the voices representative of and trusted by the local community. So when, for example, we are lacking trust in the health authorities and in the government in general, as you mentioned, in specific countries and regions, and that definitely happens in the UK, as I observed myself, what we need to do is find the local messenger and the local trusted person that actually can influence people to change their health behaviors. In our situation, we found that, for example, receiving a text message or a letter from your personal GP, not from the health authority locally, is actually influencing people to change their behaviors and turn up for health screening, such as health check, which is a national health check screening for various risk-related factors, cardiovascular disease, and also cancer screening. So when women, for example, receive a letter from the health authority about cervical cancer screening, say they're less likely to turn up on their appointment compared to when they receive a message or a letter from their personal GP, which we show is actually drastically increased the likelihood of them turning up for cancer screening. And now this is a national policy, text message from your GP, not from the health authority. So find the local messenger, a trusted person, Usually it's the local doctor or physician.
Ivo, I'm really sorry. We've run out of time. But I feel that we've ended on a reasonably good note there. I'm really sorry for those of you I couldn't bring in. We're going to try and bring you in again tomorrow. We're back again tomorrow. So thank you for being part of this session. I hope you've enjoyed the debate. That's it for day 3 of Wish 2020. We'll see you here again tomorrow. Until then, that's it. Goodbye.